check. Check, hello, check. Hello, check, hello.
Good morning, respected dignitaries, esteemed faculty members, distinguished delegates, and dear colleagues. The moment in medicine where every second matters, when waiting is not an option, and when the right decision made at the right moment can change the course of patient life. And today we have a technology that allows us to look beyond the clinical science, beyond assumption, and quite literally look into our patient right at the bedside. And that technology is point of care ultrasound, that is the POCUS. From uncertainty to clarity, from clinical suspicious to visual confirmation, and from assessment to action. Sometimes within minutes, POCUS has transformed the way we practice critical care medicine. And that is exactly what brings us together this morning. With immense pleasure and enthusiasm, I, Dr. Sukanya Singh Rajput, consultant, Jeevandan Health Hospital, would like to welcome you all to POCUS Pulse 2026. That is point of care ultrasound beyond textbook. So to all the doctors with the curious minds and enthusiastic heart, our ultrasound probes are ready, and let us begin this journey with the fascinating world of bedside ultrasound. A special word of gratitude to our faculty members who have traveled within and from outside the state to share their expertise, experience, and clinical insights with us. Before we begin the scientific program, it is my privilege to introduce and welcome our esteemed chairperson throughout the session, Dr. Shrikant Srinivasan Sir, Chairperson, Manipal Institute of Critical Care Medicine, Gurgaon. Ladies and gentlemen, it is now time to formally begin POCUS Pulse 2026. To deliver the welcome address, it is my privilege to invite Dr. Kundan Kumar Sir, Head of Department Critical Care Medicine, Jeevandan Health, Patna, and one of the key driving forces behind today's workshop. So may I request you to kindly come on the stage and to deliver the welcome address. Thank you.
गुड मॉर्निंग एवरीवन। एक्चुअली मैं फॉर्मल नहीं बोलूँगा, है ना। एक्चुअली ये मेरा पहला एक्सपीरियंस है और मैं यहाँ पे एक वर्कशॉप अरेंज कर रहा हूँ विद द हेल्प ऑफ ICSM पटना एंड द जीवनदान हेल्थ। और जो भी हमारे डिग्नेटरी, जो भी हमारे फैकल्टी हैं, गेस्ट फैकल्टीज हैं, है ना, मैं उन्हें थैंक्स बोलना चाहूँगा कि उन्होंने अपने कीमती समय में से हमारे लिए कुछ समय निकाला और यहाँ आए और हमें अपना बहुमूल्य समय दिया। और और मैं यहाँ पे ICSM पटना के जो भी ऑफिस बियरर हैं सबको मैं थैंक्स बोलना चाहूँगा, स्पेशली राजेश सर, किशोर सर की, मतलब कि सर के गाइडेंस और हेल्प से ही हम लोग ये सब कर पाए यहाँ पे। और हम लोग मतलब सब कुछ जानते हैं कि फोकस जो है वो आज के क्रिटिकल केयर प्रैक्टिस में जस्ट लाइक आइज एन ईयर है। तो और जो भी हमारे यहाँ पे एक्सपर्ट्स हैं वो अपना इंसाइट देंगे, हम उनका एक्सपीरियंस को यूज करेंगे और अपने क्लिनिकल प्रैक्टिस को हम लोग और बेहतर करेंगे। सो वंस अगेन थैंक यू ऑल एंड आई फील प्रिविलेज टू वेलकम यू ऑल टू द फोकस पल्स। थैंक यू।
Thank you very much, sir, for those inspiring words and for setting the perfect tone for today's program. So, let's start with our academic session. As we all know, every journey in ultrasound begins with the fundamental. And a sound understanding of ultrasound physics, probe selection, gain depth, focus, and other machine control, what we commonly call knobology. To take us through these fundamentals, it is my privilege to invite Dr. Prabhas Chandra Jha, sir, Interventional Radiology Senior Consultant, Jeevandan Health Patna, to conduct the session on USG physics, basics, and knobology. May I request you to kindly come on the stage, Dr. Prabhas, sir.
Pointer है. Very good, very good morning, everyone. I will discuss today morning session with basic ultrasound physics and knobology. Basically, optimization of machine for proper use is very important. So first of all, I will go through all these things. That is introduction part. Then the properties and principles of the ultrasound wave, and what is the interaction of the tissue with the sound wave, and further different types of transducer, and then finally we will go through the knobology part. So introduction, the sound, actually ultrasound wave is, which is more than 20 kilohertz, and which is not audible to the human ear, and normally the which is audible range is 20 to 20 kilohertz for human ear. In the diagnostic ultrasound we use commonly 2 to 15 megahertz. And apart from diagnostic, there are few therapeutic purposes also, that is tissue healing and tissue destruction, that is high intensity focused ultrasound, and other for the therapeutic purposes. So properties of ultrasound, it is a mechanical wave and it requires medium for propagation, and it is based upon the compression and rarefaction of the wave, which is longitudinal in the nature, and the basic parameters which includes wavelength, frequency, and velocity, and the relation between the frequency and wavelength is the velocity is equal to frequency multiplied by wavelength. So there is an inverse relation between the frequency and wavelength, and resolution is also inversely related to the wavelength. If there is a higher frequency, then there will be a better if higher frequency there will be uh, if there is a higher frequency, better penetration, and resolution will be higher frequency, there will be poor penetration and the resolution will be better, and it is inversely related to the wavelength. So key principle is to use the highest frequency for optimum penetration or depth. So there is a trade-off between the frequency and resolution. If you will use high frequency, that is it gives you better resolution, but penetration will be low. The propagation of the sound wave, it depends upon the density of the tissue, that is the bone or soft tissue having different. Normally the soft tissue having 1540 meter per second, and the bone having the highest velocity for the sound, and the poor will be in the gases, that is the air having the least one. So principle of ultrasound, it is based upon the piezoelectric effect, that is the main electric current is supplied to the piezoelectric substance. It causes mechanical deformation, that is it vibrates and it produces ultrasound wave. Finally the sound wave travels through the body tissue and it returns back to the transducer, and which finally converted into digital signal, that is what we use for the diagnostic purposes. So these are the cycle. We can see how the electric current actually causes electric crystal vibration and further sound pulse production, which interacts with the tissue interface, and which further return of echoes is being detected by the transducer, and it further convert again into the electric signal, which used as a digital display, what we see on the monitor. So basically the pulse echo principle, it is the same thing that as I have shown you, the electric current further how it produces ultrasound wave, and it's a reverse there is a production of digital images. So basically there are different types of interaction of ultrasound, that is reflection, diffraction, absorption, scattering, and attenuation, and all these parameters determines the quality of the images. The reflection is the specular, that is when a sound wave falls approximately 90-degree angle, the incidence of a strong echo is very higher, and when it goes through the different tissue composition, the amplitude of the sound wave decreases and it causes attenuation. And a few of the sound wave which actually absorbed by the body tissue, that is absorption, and it causes heat effect in the body tissue. And the refraction is the sound strikes on an oblique boundary, and it in between the varying densities of tissue, there will be bending away from the transducer, so it causes various types of artifacts. So coming to the transducer part, basically it having all these component, what we use for the scanning purposes, that is a transducer, it having transmitter, receiver, and processor, which further used for the generation of the images. And there are various components within the transducer, that is a matching layer, the outermost layer, which actually we keep on the body surfaces or any area of interest, that is the outermost layer. Then there behind that layer there is a piezoelectric crystal, and back of that it is a damping or backing block, and the complete setup is encased in a plastic case, which is very actually fragile, and we have to take care of all these things. The handling of the transducer is very important. Even a small drop can cause damage, and finally we will actually able to find various artifacts after transducer damage. So basically when ultrasound beam falls there the wave actually it is a fan shaped, and the near upper half is also called as Fresnel zone, and the lower half is it is the Fraunhofer, that is far field, and upper half is the near field. So the beam becomes progressively divergent in the far field. The focusing in the ultrasound is very important. Focusing is basically it is a narrow the ultrasound beam and produces higher intensity at the focal zone, and it improves the lateral resolution, that is a side by side two object determination. It is improved by focusing. So during a scan it is very important. The practical rule is that place the focus at the level of region of the interest where we have to see the things. We have to focus upon that. The transducer area, there are various types of transducer area, that is the linear, curvilinear, phased, and annular. We commonly see all these first three one, that is the linear. For the superficial structure, it having higher frequency, so it gives you a better resolution, and but poor penetration basically. So for superficial structure where we have to see any blood vessel or any soft tissue in the musculoskeleton or any nerve fibers, we have to use linear array. In the curvilinear, we usually in the abdominal scan or fast imaging or any deep structure, we use curvilinear, and phased array, that is the sector probe, which is used for the cardiac image, basically echocardiography purposes. So there are different modes of ultrasound, that is A mode, amplitude mode, which actually mainly in the ophthalmologic evaluation, and B mode, which is very important. Actually, grayscale imaging, all the things based upon the B mode, that is brightness mode. Then it is M mode, that is motion mode, and there are special when you require color flow study, that is the color Doppler. So basically we will discuss here B mode, that is brightness mode. It is the 2D gray scale images, and it is based on 256 shades of gray, and the strong echoes gives you brighter image, and the weak echoes give you darker. And if there is no echo, that is anechoic structure like fluid. So all the foundation of modern real time ultrasound based upon this B mode. M mode basically it gives you better temporal resolution. That is, it is mainly used for the particularly cardiac structure evaluation, when you have to see different structures like cardiac valves, cardiac chambers, and the fetal cardiac. Basically, we used for the fetal echocardiography and other purposes. So what we see in the B mode, we will see actually gray scale images, and it give you very good soft tissue contrast. That is any static image. In the M mode, when we have to see any motion related things, there are various diagnostic purpose used, as in the case of heart rate or echocardiography, or even in the diaphragmatic excursion or pleural movement in the focus we use commonly. And the color Doppler, there are various application of color Doppler, especially when we have to see any valvular stenosis or any flow related changes in the peripheral or carotid arteries. So basically Doppler part, actually it is basically physics of Doppler is part, that is blue is away and red is towards the probe, and it is not basically related to the arterial or venous. Anything which will come towards the probe, it will give you a red and red signal, and away from the probe it will give you blue signal. And the proper position of the probe is very important in this, because anything perpendicular to the probe, 90 degree to the probe, will not give you color. Even you will able to see pulsation of the vessels is there, but you are not able to pick up the color. In that condition, you have to actually orient the probe properly, and there are also some maneuver that steer and all the things you will see on the machine, so that you can properly acquire color imaging. So basically, there are few other advanced apart from the color Doppler, that is power Doppler. In the color Doppler, you will able to see the direction of flow, and also the basically velocity of the things, area of interest. But in the power Doppler, if you are not able to see color, very low flow is there, then you just put button PDI, that is power Doppler imaging. You will able to see there is some flow within the area of interest. And apart from that, pulse wave Doppler, it is basically a spectral. What is actually amplitude of flow, what is direction, and all the quantitative parameters can be basically calculated from the pulse wave Dopplers. And the continuous wave, it is actually independent of the all these parameter in the very high flow, just like any area of valvular stenosis, or you have to see for the what is exact velocity. Then pulse wave causes too much aliasing artifact, then you use continuous wave Doppler. And the drawback of this is there is range of ambiguity. You cannot pinpoint depth of location and all the other parameters, but in the pulse wave you can calculate all these things. These are a few spatial imaging technique, that is harmonic imaging. Usually in the machines you will find that is HI written over there. So you will just put a button and it will actually enhance your image quality, and tissue characterization will be better in that case. It also reduces noises and clutters, and improved lesion conspicuity you will able to do after harmonic imaging. Then there are partial compound imaging. This is basically various artifacts can be reduced with this. So now coming to the artifact, there are various kinds of artifact. Basically the machine assumption is everything's in the body actually machine assumes the everything's in the body having same velocity, but actually different tissue having different velocities, and interaction of various different types of tissue gives you artifact like even and these artifact having actually diagnostic use also in the, just like in the gallbladder stone you will see very actually posterior acoustic shadow. In the cystic lesion you will see able to see posterior acoustic enhancement behind the area of lesion. So now coming to the novology part, basically practical manipulation of ultrasound control to obtain best possible diagnostic image. Poor optimization can reduce basically imaging quality, hide pathology, and it also misleading appearance of the uh, area of interest. And the goal of this novology is to optimize first and interpret second. So this is the basic workflow. You have to select proper probe. Actually depends upon it is superficial or deep structure. Then you have to take preset is usually installed in the machine. Actually what you have to actually study, and then you have to set overall gain, then time gain compensation TGC, then appropriate focal zone, then optimize frequency and adjust dynamic range, and then zoom whenever required, then use zoom, and then finally measurement and whatever is required. So application preset you can find in the machine. There is already many presets available for diagnostic purposes. So and you can choose any mode, whatever. First you have to just go through the grayscale mode, characterize the tissue, then you can use whenever required for further color Doppler or pulse wave Doppler and continuous wave Doppler. Depth is very important. So first you have to start first you should start with the maximum depth and then slowly decrease and optimize for at least what is your area of interest. That should be in the 75% of your screen. So basically reduce if you will reduce depth, you will improve the actually image quality, and excessive depth can basically deteriorate image, because too much image can cause poor resolution. Too much depth can cause poor resolution, as you can see in this image. Overall gain, it is echogenicity. If you are dealing with too much dark, you are not able to see the structure in the area of interest. So just rotate knob, that is 2D knob. Actually, if you will rotate clockwise, you will able to see increase in brightness, and you will get good image quality. And too much gain, even if you do too much brightness, then it will cause it basically poor sometime poor visualization. So optimum visualization is very important. and too little gain causes dark images. So overall gain is very important for optimization of image. Then TGC basically at different, when sound wave travels through the body, in the deeper structure you will find poor dark image or sometimes poor resolution. So in that condition we can adjust TGC knob for proper resolution. We can increase the brightness at particular level where you have to adjust that. So it smooth and uniform grayscale images. Focus is very important. You can you have to put just at the proper area where you have to see focus. So one will place focus is often better for multiple unnecessary foci, and it improves the image quality. The frequency, high frequency have better resolution, and low frequency have better penetration. So highest frequency that adequately penetrates the target is very important. Then the dynamic range, actually dynamic range controls the range of echo amplitude display as a gray shades. So lower dynamic range, in the lower dynamic range you will able to see fewer gray shades and a higher contrast. But in the higher dynamic range you will see more gray shades and the softer contrast. So basically in this image you can see the narrow high contrast image best for the vessels, and the broad smooth gray transition is for the any solid organs like liver or kidney. It is important to set dynamic range. Then the tissue harmonic imaging, it is basically optimized further images when you require a proper crisp boundary of the, if you are not able to see simply just on this THI, it will enhance your image. Zoom is very important when you have to see properly for the particular area. Just use zoom button. Either you there are various depends upon the machine, there are various types. You can just rotate or just stroke the button. So that will actually optimize proper zoom. So it is very useful for the small lesion when you will take measurements. So the margin visualization is very important for the small lesions. In that case we can use zoom. So zoom of the region is interest only, it will give you better image quality. Just do not zoom all the images, then it will actually reduce the resolution. Then finally, when you freeze button, but basically 10 to 30 seconds machine stores images. Just freeze that use freeze button. Then you can use trackball for proper where it is the better visualized, and then you can use measurement and all the documentation parameters, annotation, and all kind of things. So before measuring, it is very important correct plane, that is correct magnification and the proper image quality and the caliper placement. So golden rules of novology is choose the correct probe and use the highest frequency that penetrates adequate to the body tissue, and depth according to the target, and optimizing the overall gain. Then use TGC to compensate for depth and place the focus at the target. Then optimize dynamic range. Then use harmonic or compound imaging, whatever is appropriate. Then use zoom before detailed measurement and optimize the image before interpreting it. So final message is a good ultrasound image is not produced by machine alone. It is produced by basically use of understanding of the physics and choosing the right probe and optimization of the control, understanding the tissue interaction and applying the clinical knowledge. Thank you. Oh yeah.
Thank you so much, sir, for such a clear and insightful session. Now we move from the fundamentals of ultrasound to one of its most powerful bedside application, that is the cardiac POCUS. In critically ill patient, when hemodynamics can change within minutes, bedside cardiac ultrasound can provide us invaluable information regarding ventricular function, volume status, pericardial pathology, and possible cause of hemodynamic instability. To guide us through the important subject, it is my pleasure to invite Dr. Rajesh Roshan Sir, Secretary IACCM Patna, Head of Department Critical Care Medicine, Mediversal Hospital Patna. Sir, may I request you to kindly come on the stage and take over the session.
Okay. A very good morning. First of all, I would like to thank and congratulate Dr. Kundan for organizing such a wonderful conference on POCUS, critical care ultrasound and echocardiography. It's a very important to know everyone who is an intensivist who should know every bits and bits of the ultrasound and echo and during day-to-day clinical practice. So with the advancement of the critical care, echocardiography is also getting advanced, and it's really difficult to cover all the critical care echo things to cover in next 20 minutes. So I will try to cover as much as possible, and I will try to justify my time. So do have a hand wipe. The thing is, when you will consider when you will consider the echocardiography in the critical care scenario, to identify the cause of, say, differentiating the different type of shock, then to know the cause of dyspnea, to assessing the fluid responsiveness, cardiac arrest, suspected PE, to identify the cardiac tamponade, acute RV failure, unexplained pulmonary edema, and when the patient suddenly deteriorated, you have to go for echo. So these are the common scenario where you will go for the echocardiography. So what are the views? When we put a probe on the parasternal area, apical, and subcostal. So we'll go one by one. So first we will look for the parasternal long axis view, that is Plaque's view. So patient should be in the left lateral decubitus position. Place probe at the left side, second to fourth intercostal space, and the left side of the sternum, and the direction of the probe should be towards the right shoulder, that is the 10 o'clock position. What we'll look for? Left atrium, left ventricle, mitral valve, right? LVOT, aortic valve, and RVOT. This is how you look in the echocardiography. In the short axis view, you just have to keep the probe on the same position and you tilt the probe toward the left shoulder, right? In the 1 to 2 o'clock position, you will get different view depending on the how much you are tilting the probe. It can be apical, mitral level, or aortic valve level. This is at the level of mitral valve. We can see a face mouth valve. This is at the papillary level. We can see the two papilla, right? And at the apical level. This is at the level of aorta. We can see the Mercedes-Benz sign of the aortic valve. Left coronary cusp, right coronary cusp, and the non-coronary cusp. LA, RA, RVOT, and some part of pulmonary artery. Then apical fourth chamber view. You put in the probe on the apex of the heart, and direction should be, the probe pointer direction should be 3 o'clock position. You will get this view, apical fourth chamber view. Left atrium, left ventricle, right ventricle with mitral and tricuspid valve, you will get it. In apical 5 chamber, you just tilt the probe, you will get the LVOT, aortic valve, and the initial part of the proximal aorta. You will get this type of view. In the colored mode also, you will get it like this. In apical 2 chamber view, place the position at the same side, same point, and you have to rotate the probe towards the 12 o'clock position. You will get this type of view. Here you will get LA, LV, mitral valve, anterior LV valve, and inferior LV valve. It is good for the assessing the RWMA. In apical three-chamber view, we just further rotate the probe, and direction, the pointer direction should be 10 to 11 o'clock position, and you will get ascending aorta view. You will get LVOT, aortic valve, and ascending aorta. Ascending, not margin part of the ascending aorta only. You get like this. Then coming to the subcostal view, put the probe in the G5, below the G5 process. Pointer should be around 3 o'clock position. You will get like this. Then we have to know the different segment of the left ventricles. In apical form, basically these segments are divided as per the coronary artery supply. It can be apex, apical lateral, mid anterolateral, basal anterolateral. In the apical fourth chamber, in apical septal, mid infroseptals, basal inferoseptals. Same with the parasternal lung, plaques view, apex, apical lateral, mid infralateral, basal infralateral, in short axis, in apical region, anterior, inferior, and lateral septals. In the mid cavity and basal view, anterior, inferior, and anterolateral, inferolateral, anteroseptal, and inferoseptal views are added. These are the coronary territories. When we'll get the RWMA, we can identify by knowing this which artery is involved and responsible for the RWMA. Now coming to the how to assess the LV systolic functions. Of course, there are a lot of ways, but the most important we routinely do is that is eyeballing. That's the best way. Then fraction sorting, Simpson method, it can be single plane or biplane. Biplane is better, obviously. MAPC, tissue Doppler, LVOT, of course, it can guide you, and EPSS, end point septal separation. With the eyeballing, we can mostly accurately tell you that how much ejection fraction we have, and routine fraction we do it very regularly in different view: plaques view, apical fourth chamber, short axis view, subcostal view. Then coming to the fraction sorting. So in this mode, what we do is we put a probe on the plaques. We get a plaques view, and what we do is put a M mode cursor on at the level of mitral valve leaflet, mitral valve leaflet tips, and we measure LV IDD and left ventricular internal diameter at the diastole and systole, and this formula is applied: LV-IDD minus LVDS into 100 divided by LV-IDD. And if it is 25 to 40 or 45% of the shortening, that is normal. If it is more than 45% hyperdynamic, is less than 55%, then severe LV dysfunction is there. Then Simpson view, what we do in the apical fourth chamber view, we trace the endocardium in the end of the systole and end of the diastole, and your echo machine will calculate automatically your ejection fraction by this formula: end diastolic volume minus end systolic volume into 100 divided by end diastolic volume. In biplane method, we take apical fourth chamber and apical two chamber. This is more accurate than the single plane Simpson method. Then EPSS, that is end point septal separation. What we do in plaques view, we put a M mode cursor at the tip of the mitral leaflets, and we check the distance between the anterior mitral leaflet, that is E point, and interventricular septum, that is the minimum distance. And we with this formula we can get the EPSS. So if it is less than 7, it's normal. If it is more than 10 to 12 mm, then it's a severe LV dysfunction is there. It's a very rapid method to assess the LV systolic function. This is now coming to the MAPC, mitral annual systolic excursion. What we do, we put a apical fourth chamber view, put an M mode. Then what you do, put a M mode at the mitral annulus and the lateral annulus and see the excursions. If it is more than 12, it's normal. If it is less than 8, then it's the LVEF is decreased. This is how you can do that. It's apical 4-chamber view, M mode, right? Now we have to measure the distance. It's 0.58 centimeter, right? This is MAPC. Same with the lateral view, and we have to average on both of the value. Then tissue Doppler, what you measure? Measure the S prime. So how we are going to do that? Apical 4-chamber view. I will show you. Put in mitral annulus. Put a pulse Doppler over there. You will get this type of graph, right? We have to measure S velocity at the mitral septal annulus and the mitral lateral annulus, and we have to make average of those things. 3 number, septal will say 5.61. Same with the lateral annulus. Then LVOT VTI. Obviously, LVOT VTI, as we all know, that it is good for assessing the fluid responsiveness, but it can also give you some hint that how LV is working. So if normal value is 18 to 22 centimeter, if it is less than 18, it means LV is compromised. If less than 10, then LV is totally compromised. Severe LV dysfunction might be present. How do you do that? In apical 5-chamber view, put a pulse wave Doppler. Put a pulse Doppler. It should be just proximal to the aortic valve. And what you need to do, you have to get the good spectral envelope, and most importantly, the systolic lead should be present. And you have to trace the spectral envelope, and you will get the VTI. If VTI is 18 to 22, is normal, and you can also check for the VTI variation. I think it will be discussed later on. Then how to assess the LV diastolic dysfunction, that is most of the times missed. You have to, if you want to know whether patient is having diastolic dysfunction, we have to check for the E and A velocity, E by A ratio, E wave deceleration time, septal and lateral E prime, average E by E prime, peak TR velocity, PASP, and pulmonary venous Doppler and IV RT, that is isovolumetric relaxation time. This is a huge chart. In normal cases, E is more than the A wave, but when there is a diastolic dysfunction, E will be smaller, A will be larger. Then grade 2, again, the pseudo normalization of the E wave, that is E wave will be more and A wave will be smaller. But in case of Valsalva, it will revert back. And in grade 3 and grade 4, that E wave will be much longer than the A wave. And E prime, same. E prime will be normally, E prime will be more. Here you can see E prime. E prime. Normally E prime will get higher than the A prime. But as the diastolic dysfunction will increase, E prime will be shorter. In the pulmonary venous Doppler, S wave and D wave, and there will be A wave. S wave is usually larger than the A wave, D wave. Then as the diastolic dysfunction increases, S wave will become smaller, and ultimately, in case of severe MR or severe left atrial pressure, S wave reversal can you see. And there is a flow propagation velocity, that is VP. We have to measure the velocity of the flow propagation. We'll discuss. So, a mitral inflow pulse wave Doppler, what we measure? E wave, A wave, E wave, E by A ratio, deceleration time, right? This is what we do. Apical 4-chamber view, right? Put in a pulse wave Doppler at the tip of the mitral valve, right? You get the E wave and A wave. Measure the E wave, height of the E wave, measure the A wave. Okay, so E is greater than A here, and E wave deceleration time. Number 3, yeah. How much time it will take E wave to come down to the baseline? That is the E wave deceleration time. The time required. 160 millisecond is the cutoff. Then we can check diastolic dysfunction by the tissue Doppler by measuring the E prime, A prime, and S prime. This is how you do it. Apical 4-chamber, tissue Doppler, use tissue Doppler. you will get this type of wave. Number 3, that is the S prime. Okay. So you can assess diastolic dysfunction. Sorry. This is diastolic dysfunction. For that, E prime or A prime should be measured, not the S prime. Sorry. Again, you have to measure mitral, lateral E prime and A prime, and you have to put the pulse wave Doppler at the lateral annulus, and you will get this type of graph. Again, you have to measure E prime and A prime, and E by E prime ratio you can calculate. If it is more than 14, then LVEDP is higher side. Then you can measure by LA diameter, measuring the LA diameter. If its interposterior diameter is more than 4, it means LA is enlarged. If LA area is more than 20, it means LA is enlarged. If LAVI, we are going to discuss LAVI, how to calculate left atrial volume index. If it is more than 34, it means LA is enlarged. And LA volume, if it is more than 58 to 60 ml, then left atrium is enlarged. So what's the LAVI? LAVI is the left atrial volume index. Okay. So how to calculate? We measure the LA volume and divided by body surface area. So what we do? We measure the LA volume in apical 4-chamber view and apical 2-chamber view. And we make average of that and divide it by body surface area. If it is more than 34, LAVI is increased. If it is more than 48, his severe enlargement is there. So how to calculate it? By again, you have to trace the inner border of the left atrium in the apical 4-chamber view and the apical 2-chamber view, and make average, and you divide it by body surface area, and you will get the left atrial LAVI, that is left atrial volume index. Peak TR velocity and PSP also help you to understand whether there is a chronic diastolic dysfunction. So if it is peak TR velocity is more than 2.8, it means severe LV dysfunction, LV diastolic dysfunction might be there. PSP is more than 35. It might also help you to identify the LV diastolic dysfunction. This is how you get it. You have to apical 4-chamber, color Doppler, put in continuous wave. You will get this type of tongue-shaped graph. You have to measure the maximum TR velocity, and for calculating the PSP, 4 TR square into 4 Bmax square into plus your RA pressure, and how to calculate RA pressure will tell you. And if you add it, you will get the PSP. Then coming to the pulmonary venous Doppler. It is measured in apical 4-chamber view. You have to go for the right upper pulmonary vein, put a color Doppler, put a pulse wave Doppler over there, right? We'll get the systolic wave, that is S wave, then D wave, that is the diastolic wave, and the A reversal wave, that is A wave. Okay, and you have to measure AR duration also. So S wave, D wave, and A wave, right? This is the S wave. S wave is generated when the blood flows from the pulmonary vein to left atrium, right? Normally S wave is greater than the D wave. But in case of diastolic dysfunction, S wave will be smaller, D wave will be higher, and severe cases, S wave reversal will be there. S wave will go below the baseline, right? In D wave, what happens? When the blood flows during the early ventricular diastole, that is PV, when the pulmonary vein to left atrium. In AR wave, when there is atrial systole, we'll get the A wave, right? This is not a very good echo window, but anyway, this is S wave, D wave, and AR wave. These are the values of S and D during the different diastolic dysfunction. I'm not going to discuss all these things in diastolic dysfunction, but the important point is diastolic dysfunction AR duration will be more than A duration by 30 millisecond. A duration in mitral inflow pattern, E wave and A wave, right? If it is more than 30 millisecond, then it's significant. And in case of MR, there will be reversal of S wave. If reversal of S wave is there, then we are dealing with the severe MR. Then isovolumetric relaxation time. Okay. So what we need to do is we have to apical 4-chamber view. We have to go get a apical 5-chamber view and put a probe at the between the LVOT and the mitral inflow, and you will get if isobolometry relation time is less than 70, then left atrial pressure is increased. This is how you get it. Here the time is 48 milliseconds. It means your LAP is increased, right? Then the flow propagation velocity is the velocity of the early diastolic transmitral flow propagates from the mitral valve toward the LV apex. So what we used to do, we get a apical 4-chamber view. First you get the apical 4-chamber view, then a color flow, and then put an M board. Okay, and you will get you have to measure the slope of the alaging velocity. Okay, then you will get the flow propagation velocity. It's not a routinely practice, but I'm just going to discuss all these things. This is how you get it in the flow propagation velocity. Apical 4-chamber view, put in a color Doppler, get an then apply M mode, right? And you will get this. I need some time. So you will get this, and you have to measure the slope from the tip of the mitral valve to the where the alaging ends. And if it is less than 50 centimeter per second, it means diastolic dysfunction is there. Then coming to the RV function assessment, we have to check for the RV size, RV LV ratio, septal morphology, TAPC, fractional shortening, TR severity, TAPC, PSP coupling, RVOT VTI, and RA IVC, and hepatic venous congestion. I think hepatic venous congestion will be discussed later on. So first we measure eccentricity index, LV eccentricity index and RV eccentricity index. So how to measure? A short axis view. You make a in the systole and diastole, you have to measure the diameter of the internal diameter in the across the septum and vertical along the septum and across the septum, and divide it. If it is more than 1, then RV pressure is high. Then we have to measure the PSP. We have discussed how to measure the PSP. Apical 4-chamber view, color Doppler, CW you have to apply. You will get this graph. And 4 TR square plus RAP. How to calculate RAP? We have to measure the IVC diameter, and 3/8/15 formula should be applied, right? And you can roughly estimate the right atrial pressure. Then you can measure the RVOT diameter. There's a proximal RVOT and distal RVOT. In the proximal RVOT, you can identify by in the plaques view or in short axis view at the aortic level. Aortic and distal RVOT at the aortic wall level. You can identify if it is more than 3.3 in the plaques or more than 3 in the distal RVOT. It is RVOT is dilated. Sorry, this is the plaques view where you can measure the RVOT. At the end of the diastole, you have to measure it, right? And in case of aortic, second one, here you can get the RVOT proximal and distal, just proximal to the pulmonary valve. Then TAPC, tricuspid annular plane systolic circle. It will tell you the RV's function. If it is more than 17 is normal, less than 10 is severe RV dysfunction is there. How to measure? Sorry. How to measure it? Apical 4-chamber view. Put in M board at the right lateral annulus. We have to measure the distance between the maximum and minimum excursions. If it is more than 17, it's normal. Less than 10 is severe one. Severe RV dysfunction is there. Then RV S prime we can measure. If it is more than 9.5, it's normal, and it's less than is RV dysfunction is there. So how to measure it? Apical 4-chamber view, tissue Doppler, put in a pulse wave Doppler at the lateral annulus of the right ventricle. You will get this type of graph. Okay. Measure this one, RV S prime, and if it is less than 9.5, it means RV dysfunction is there. Then right ventricular fraction area change, how to measure it? If it is more than 35% is normal, is less than 35% is RV dysfunction is there. How to measure it? In RV focus view, you will get the diastole and end of the diastole and end of the systole, measure the area, and you will get the difference. Here in this case, RV fraction area is 27.87, it is less than the 35% is abnormal. Then TAPC and PSP ratio. Okay, it is it tells you whether the RV contractility is good enough for pulmonary hypertension or pulmonary afterload. If it tell you that whether the RV failure is going or not. If it is normal is 0.5 to 7, what we do, we measure the TAPC and measure the PSP, right? And we check for the ratio. If it is 0.5 to 0.7, it means normal. If it is less than 0.3, it means your RV is failing, and that indicates increased mortality. You can calculate the RA area. It will also tell you the RA pressure, increased RA pressure or failing RA and RV. If it is less than 19, normal. If it is more than 24, severe RA enlargement is there. Then pulmonary acceleration time. What you need to do, put in short axis view at the aortic valve level. Okay, put a pulsar Doppler at the pulmonary valve, and you get the pulmonary waves Doppler. And what you need to measure is this time required to get the maximum depth, maximum this wave. Here you can see this one. This wave you have to, this time you have to calculate. If it is less than 105 millisecond, means pulmonary arterial hypertension is there. If it is less than 60 second and TR velocity is less than 60, it means 60 by 60 sign. So it means it's an acute pulmonary embolism we are dealing. So it has got very high specificity. This is not a very good view, but this is how you calculate the pulmonary acceleration time. Now coming to the mitral registration, I'm just skipping things. This is that way how to assess the severity of MR. This we have to check for the different view. We can check by putting in a color Doppler. If it is less than 20%, it's a mild MR. If it is more than 50%, it's a blue jet. That is the getting the MR in apical 4-chamber view. And you can calculate, you can calculate the vena contracta, the distance between the orifice of MR. If it is less than 0.3 is mild, is more than 7 mm is the severe MR. Mitral stenosis, going through a few slides. Mitral valve area is less than 1 is severe, more than 1.5 is a mild one, and the most important is gradient. If it is more than 10, in case of mitral stenosis, severe, is less than 5 is the mild. So what we need to measure is when we are suspecting mitral stenosis, we have to do planimetry, pressure of time, and check for the gradient and PSP if required. So this is a parasternal long axis view. We can see the LA is dilated, mitral valve is thickened and calcified, and movement valves are restricted, and AML is hockey shaped, hockey stick appearance. That's a very significant finding. Huh? In short axis view, face mark valve is there and limited opening. How to do planimetry? We have to go to the tip of the mitral valve, otherwise there will be erroneous result. So it's very important to understand how to do planimetry and get the area. Then apical 4-chamber view. Put in pulsar Doppler, you can trace the pressure of time at the E wave. You get you get the mitral valve area by calculating the pressure of time by divided by 220. You can get the mitral valve area. Or you can trace the whole spectral envelope. You will get the gradient. If it is more than 10, then severe MS is there. This is pericardial tamponade. This is a floating heart and RV diastolic collapse. This is pulmonary embolism. RARV is dilated, McConnell sign in the last one, and D-shaped LV we can see in the center. This is endocarditis. I'm not going to discuss anything, so time is limited. This is right atrial myxoma. is attached to the why it is myxoma, because it's attached to the intraarterial wall. It's not attached to the leaflet. Thank you.
Thank you, Dr. Rajesh. Let's just see if I can take a few minutes.
Yeah, please.
Just want you to be around. So, thank you for a very exhaustive, very comprehensive echo. I mean, but from the perspective of point of care ultrasound, this is the entire spectrum of what echocardiography can be possibly offered by a trained cardiologist also. पर हमें इस लेवल तक नहीं जाने की ज़रूरत है. मोटा मोटा, we need to restrict ourselves to predominantly eyeballing, as he has correctly mentioned, and a very few measurements. क्योंकि रीज़न है, देखिए हर कोई एक्सपर्ट नहीं होता है इको में. मेजरमेंट करने से पहले you have to be very thorough in the basic 3 views. 4th तो suprasternal होता है, वो तो हम करते भी नहीं है. Parasternal long, parasternal short, apical 4, apical 5. मैक्सिमम वॉल मोशन के लिए 2 और 3 कर सकते हैं. दैट्स अबाउट इट. तो बेड साइड पे आई वुड लाइक ऑल ऑफ यू टू जस्ट एटलीस्ट ट्राई टू गेट अ हैंड ऑफ हाउ टू डू इट. ओनली व्हेन योर यूज आर परफेक्ट एंड आइडियल, देन ओनली वी गो इन फॉर मेजरमेंट्स. अदरवाइज ऑल मेजरमेंट्स आर एरोनियस. सो even if you want to quantify that there is a regurgitation and there is mild to severe based on your eyeballing, less than 50%, more than 50%. eccentric jet है, मान लिया सिवियर है, अदरवाइज माइल्ड टू ट्रेस है, उससे कोई मतलब नहीं हमें. सिस्टोलिक फंक्शन सबसे पहले शुरू चीज होती है आईबॉलिंग से. आईबॉलिंग में लेफ्ट बड़ा लग रहा है कि राइट बड़ा लग रहा है. लेफ्ट हमेशा राइट से बड़ा होता है. लेफ्ट वेंट्रिकल की बात हो रही है हमारी. सो राइट वेंट्रिकल इज 1/3 ऑफ लेफ्ट वेंट्रिकल, 2/3 1/3 रेशियो रहता है. सेप्टम हमेशा राइट की तरफ रहता है. दिस इज द फर्स्ट थिंग यू सी. अगर ये नहीं है, राइट बड़ा लग रहा है, फिर दिक्कत है. देन वी लुक फॉर पल्मोनरी एम्बोलिज्म एंड अदर थिंग्स. सो ग्रॉस आइडिया ऑफ कंट्रैक्टिलिटी, एबिलिटी टू मेजर वेलोसिटी टाइम इंटीग्रल एज यस perfectly shown how it is to be done, वो चीज. डायस्टोलिक डिसफंक्शन कम्स लेटर, वो ना थोड़ा स्पेशलाइज हो जाता है. पहले सिस्टोलिक फंक्शन तो देख लीजिए, देन यू कम टू डायस्टोलिक. Most of your answers on the bedside why this patient is in shock starts with an echo, and the echo will tell you whether the heart is contracting visually hyperdynamic or hypodynamic, severely hypodynamic. Wall motion abnormality है या globally hypodynamic. This is what you need to see मोटा मोटा. IVC सबको आना चाहिए, right? Gross valvular abnormality दिख गया तो wonderful. Excellent, if you can see that. If you're seeing vegetation, some masses, wonderful. बाकी जो भी calculations हैं, always go with when you have a good view. And mind you, I'm telling you, good view लाने में बहुत time लगता है. ऐसा नहीं कि everybody will get the hang of it in one go, right? We have a whole course and people still will not manage to get a good view of the heart. And it's not always possible in an ICU setup where a lot of patients are lying on the bed, monitors, can't turn the patient, and all those things are there. So my simple question is there any questions which you would like to ask right now? So any questions from the audience? कोई चीज़ clear नहीं थी तो सर है अभी, सर से भी directly पूछ लेते हैं. Because see, this ultimately is a workshop. Workshop में सवाल जवाब ना हो तो फिर मतलब लगता है कि बात नहीं बन रही है.
And most important, we have hands on.
हाँ.
तो अगर नहीं भी है, अगर क्वेश्चन है तो प्लीज पूछिए. अगर नहीं भी है, we will discuss. इंपॉर्टेंट है कि आपको इको करना है. इंपॉर्टेंट ये नहीं कि सही हो रहा है गलत हो रहा है, करते रहिए, यू विल गेट द राइट रिजल्ट, राइट? आप करना इंपॉर्टेंट है. प्रोब उठाना, दैट इज मोर इंपॉर्टेंट. मोस्ट ऑफ द टाइम्स हम जो रेसिडेंट्स को देखते हैं कि प्रोब उठाते नहीं है. दैट्स अ वेरी बैड थिंग. प्रोब उठाना है, आज नहीं तो कल आप एक्सपर्ट हो जाओगे, राइट? प्रोब उठाना इंपॉर्टेंट.
तो कोई सवाल है तो पूछिए अभी. कोई भी चीज़, इवन द फर्स्ट टॉक पे, मतलब जो नोबोलॉजी की बात हुई थी उसमें भी कोई सवाल है तो पूछिए. कोई चीज़ जो क्लियर नहीं हुई, कोई टर्मिनोलॉजी है जो समझ नहीं आया हो. सबको सब कुछ समझ आ गया तो बहुत अच्छी बात है फिर तो, मतलब क्या ही बताऊं. राइट. यस. Absolutely.
We are here to help our critically sick patients who may be benefited from the critical care ultrasound, whichever will be applicable to my patient care, right? And that has to be done in 5 minutes. If you are spending more than 5 minutes, honestly speaking, then you are actually harming the other patient's care, and that ultrasound is not going to save completely the life. There are multiple things in my checklist which I need to do for my critically sick patient. It's not only the echocardiography or ultrasound. So that's why everything whatever we are discussing today, you have to make a 5-minute checklist for your patient at the bedside. Am I right?
Absolutely.
मोस्ट इम्पोर्टेंट जो आपको फोकस होना है, नॉलेज आपका हो सकता है बट फोकस होना है कि क्या मुझे देखना है. इट्स नॉट रूटीनली रिक्वायर्ड कि आप ईच एंड एवरीथिंग यू सी ईच एंड एवरी पेशेंट, है ना. तो आपको ये देखना है कि मुझे क्या देखना है. मुझे आईसी देखना है, आईसी देखना है, वॉल्यूम स्टेटस देखना है, वॉल्यूम स्टेटस देखना है, फ्लूइड रिस्पांसिबिलिटी देखना है, यू हैव टू गो फॉर दैट. आपको देखना है कि पेशेंट को टैम्परेचर हुआ है कि नहीं है, आप गो फॉर दैट. यू आर चेकिंग फॉर द पल्मोनरी एम्बोलिज्म, गो फॉर दैट. आपको फोकस होना है. डॉक्टर तापस राइटली सेड कि आपके पास टाइम लिमिटेड है, तो बहुत इंपॉर्टेंट है कि आप क्या देखना चाहते हो. दैट्स मोर इंपॉर्टेंट. हर समय आपका पूरा नॉलेज सिंगल पेशेंट पे नहीं यूज करोगे, राइट.
जस्ट गोइंग फॉरवर्ड, कब कार्डियोलॉजिस्ट को बुलाना है ये भी ज़रूरी है. हर चीज़ के लिए, हर पेशेंट के लिए कार्डियोलॉजिस्ट को बुलाने की ज़रूरत नहीं होती. रीज़न है क्योंकि ये सारी फाइंडिंग्स डायनामिक है. अगर उसने एक बार आके बोल दिया EF 50% है, तो वो रूल ऑफ द थंब नहीं है. अगली बार BP कम होगा तो 50 का 20 भी हो जाएगा, तो उसमें कोई बड़ी बात नहीं है. और 20% जब लग रहा है, आपने आइनोट्रोप स्टार्ट कर दिया, वो 30-40 भी लगेगा. जैसे विड्रॉ करोगे फिर से 20 पे आ जाएगा. तो दिस इज ऑल डायनामिक थिंग्स विच विल कॉन्स्टेंटली कीप चेंजिंग. इफ यू हैव एन आइडिया ऑफ अ बेस लाइन, इट इज़ गुड, बट अ बेसिक इको इज जस्ट अ बेस लाइन, दैट्स अबाउट इट. उसके ऊपर कुछ और चीज़ नहीं होती. यू नीड टू नो व्हेन something seems to be grossly abnormal. When it is grossly abnormal, then if you can further do all the things which has been said, excellent. और टाइम आपके पास तो बहुत कुछ कर लीजिए, अब कोई दिक्कत नहीं है. बट इट इज़ ऑलवेज टू बी फॉर अ क्लिनिकल क्वेश्चन. मैं 50 मेजरमेंट करके क्या करूँगा? मेरे को करना तो वही है, मेरे को वॉल्यूम देना है कि नहीं देना, एनोट्रोप स्टार्ट करना है कि नहीं स्टार्ट करना, टेम्पोनार्ड है या सिर्फ पेरिकार्डियल एफ्यूजन है, कब मेरे को इंटरवीन करना है, कब मेरे को इंटरवीन नहीं करना है, can this heart take more fluids of mine or not? That is a basic question which I need to answer as an intensivist. I don't need to go out finding out every single thing which may not have any clinical relevance to me at all, right? And all the clinical questions has to fit into a pathway for this patient. अगर मैं हार्ट का evaluation कर रहा हूँ तो क्यों ही कर रहा हूँ, मतलब कोई तो कारण होना चाहिए ना क्यों मैं कर रहा हूँ. मेरे दिमाग में क्या चल रहा है, what is my primary diagnosis which I am trying to verify or refute by the means of an echo. So that is something which you have to do, and that is why we say limit yourself to the things which are easy to learn and applicable on the bedside, right? So do those things. Personal interest है तो सब कुछ करिए, कोई दिक्कत नहीं है. But as sir has correctly pointed out, do not waste too much time on one patient just taking more and more and more calculations, because that calculation is not going to help you in the long run. आपको मोटा मोटा पता होना चाहिए सिस्टोलिक ग्लोबल कैसा है, डायस्टोलिक डिस्फंक्शन है कि नहीं है, पेरिकार्डियल एफ्यूजन, पेरिकार्डियल टेम्पोनार्ड है कि नहीं है, इस पेशेंट को मैं फ्लूइड दे सकता हूँ, इस पेशेंट को एनोट्रोप से फर्क पड़ेगा कि नहीं पड़ेगा, इस पेशेंट में कोई कोरोनरी इंटरवेंशन करने की जरूरत है कि नहीं है. बस इससे ज़्यादा कोई सवाल के जवाब आपको जरूरत नहीं है फ्रॉम अ क्रिटिकल केयर पर्सपेक्टिव. हम यहाँ कार्डियोलॉजिस्ट को रिप्लेस करने के लिए तो नहीं बैठे ना, अल्टीमेटली करना तो उनको ही है.
And one more thing, last thing, I think Dr. Shashank rightly said, important ये है कि को का जो findings है, that is just a value, it's a paper वैल्यू है. अगर इस वैल्यू को हम सही तरीके से क्लिनिकली यूटिलाइज नहीं करते हैं तो सिर्फ वैल्यू रह जाएगा. तो हर फाइंडिंग आपका क्लिनिकली यूटिलाइज होना चाहिए. दैट्स मोर इंपॉर्टेंट. अगर आप नहीं कर रहे हैं तो सिर्फ पेपर पे रहेगा, एंड इट्स नॉट गोइंग टू अफेक्ट योर पेशेंट, राइट. थैंक यू.
थैंक यू, थैंक यू, थैंक यू.
Thank you so much, sir, for such an interactive session. Moving on. Now we have something called as fluid management. It perhaps is the most important and most frequent and sometimes the most challenging decision we make in critical care. The question today is no longer that does this patient need fluid? The more meaningful question is, will the patient actually benefit from the fluid that we are about to give? To elaborate on this extremely important concept, My privilege to invite Dr. Mudit Joshi, sir, Senior Consultant, Critical Care Medicine, FMRI, Gurgaon. Sir, may I request you to kindly come on the stage and take the session.
Good morning, everyone. Teachers, friends, colleagues, and uh, after such an interactive session where such heavyweights have discussed things in such great detail, it becomes, hard for a lightweight like me to start. But we'll start anyway. So, this is my topic. I am Dr. Mudit Joshi. We will be discussing fluid responsiveness assessment using our POCUS, that is point of care ultrasound. So, fluid responsiveness, this is a word we have all heard multiple times. And by and large, most of us understand. Just to visualize that understanding, I put this diagram forth in front of you. So, what you see here at the rising part of the slope, if my pointer is visible, then this is the part where most of our fluid responsive patients are. What we are talking about in fluid responsiveness is a physiological state where an increase in preload, that is the amount of blood returning to the left atrium, would be significantly beneficial in increasing the stroke volume and the cardiac output. So this is just a visualization of that for your sake. Now, why are we talking about fluid responsiveness? Why most of the recent guidelines are mentioning it? And why this is such a topic that everybody says that this should be a basic assessment that we must deploy in almost all of our patients, right? So that comes because of this dilemma that we face at the bedside every day. Like the Surviving Sepsis campaign, if you have gone through it recently, it has still recommended that in the initial resuscitation, we are to provide at least 30 ml per kg of fluid over the first 3 hours to most of the septic shock patients. Fine, we have a guideline for that. But what happens after 24 hours? What happens after 48 hours? When do I know? What happens after 6 hours? If my patient is 60 years old and he has an ejection fraction of 40%, how do I know whether my fluid is going to benefit him or harm him? Because fluid is also possible to cause toxicity. That is what we are weighing always at the bedside. Again, even in a depressed cardiac state, like the point I just made, it is not necessary that preload will always be harmful for a patient. Don't think that if my patient has a 30% fluid ejection fraction, I just cannot give fluids. There is a narrow part of the slope, even in a decreased cardiac contractility, where your fluids are going to benefit the patient, although there is a larger part of the plateau portion where it is just going to harm the patients if you continue to give further fluids. So when we talk about fluid responsiveness, one of the dichotomies we discuss very often is the dynamic markers versus the static markers. Static markers, by and large, what we can understand, if anything can come and or be expressed as a single value in a single metric, then you think of it as a static marker. This would be your IVC diameter. This could be your left ventricular end diastolic area. This could be your CVP, or even your MAP as a single number, not the trend. Then mechanism, it is single, isolated, and it usually has a lot of confounders. There are a lot of factors that can confound these single values. So when we wanted to refine our measurements, we went to dynamic measurements. So what are dynamic measurements? Here, what we are utilizing are three things essentially. One, we are utilizing our ability to make two measurements, one followed by the other. Between these two measurements, we are going to give a measured intervention, a small intervention. Usually it has to be reversible in case of a PLR, or a mini fluid bolus, something which is not going to be a large volume. And then we are going to repeat our measurements and see the change. This change guides us, because it is a trend, it guides us whether or not we want to follow on this path further. And that is why it has shown a better risk reduction, 0.59% or 0.61% in the case of the recent meta-analysis. So these are this was a recent paper that was published in the Critical Care Explorations. This is SSCM paper. And in this, they compared dynamic measures of fluid responsiveness to guide resuscitation. specifically in patients with sepsis and septic shock. This was a meta-analysis, and here what they found that when you use dynamic measures instead of static ones, the primary outcome, the 28-day mortality, what they found, there was a difference. And it is one of the rare things in our critical care field that we find something directly having a mortality benefit. So that's why it has been enforced again and again that we utilize these dynamic values. And they also reduce the risk of major adverse kidney injuries, and reduce cumulative fluid balance on day 3, which sounds like a non-patient centric metric. This is not a patient-centered metric, but when your relatives come to the bedside and they see that our patient is fully puffy, there is edema everywhere, there I think this value also becomes patient-centric at the bedside. Then, again, coming back to the basics, why we are looking at one of the first steps in dynamic measurements, what most of us have started with is IVC. And IVC, either distensibility you will hear or collapsibility you will hear. So distensibility and collapsibility, two sides of the same coin, depending on the type of respiration that we are doing. I am audible, right? Everybody's with me. Yeah? Okay. So the distensibility and collapsibility, the two sides of the same coin. Basically, collapsibility is something we are looking at whenever our patient is in a mode of spontaneous respiration, because in spontaneous respiration, your diaphragmatic efforts, your intercostal muscles are generating the negative intrathoracic pressure, and this is inviting more preload to come into the thorax. It's facilitating that. Whereas in positive pressure ventilation, during inspiratory phase, we are having higher inspiratory pressures, which if they do get translated, whatever extent gets translated into the positive intrathoracic pressures can reduce the fluid intake and the preload in that setting. So that's why when we are talking about spontaneously breathing patient, we will be talking about IVC collapsibility. Since the collapse happens from the max diameter, always remember this bottom value would be the IVC max. And from the IVC max, the IVC minimum you get, you subtract that, divided by the IVC max, multiply by 100, you get the percentage, a 40 to 50% collapse, highly predictive of fluid responsiveness. It has a very good specificity, and that is what we are looking for. And less than 15 to 20% collapse is something which has a good negative predictive value. That means that this patient is very likely, when we say nearly 100% negative predictive value, so what we are saying is this patient is very unlikely to increase his cardiac output by further fluids or further increase in preload. Then positive pressure ventilation, like I said, whatever transmission is happening through your lungs, that is going to be in the intrathoracic compartment. It is going to impede your preload. That's why here what we are seeing, the change is also slightly different. What we are looking at is distensibility. So from your minimum IVC, which you would be measuring at the end of the expiratory cycle, versus the maximum IVC, which we would measure during the inspiration. And then taking out the difference gives us this value. Always remember, this is minimum, because distension happens over the minimum. So that's why here the bottom value is minimum. This is something most people have seen at the bedside. Often this confounds our numbers. So always remember these things. Continuing forward, this is the diagnostic metrics. These are the cutoff values that I want you to remember. Then just focusing on the practical part aspect of it. So this is the probe positioning. This is where we'll be keeping the probe for IVC. When you want to look at the IVC, the position of the probe is substernal, right, in the mid-9. And some patients, you might require a left slide. We'll be talking about how to name and how to understand the probe movements when we do the hands-on sessions even more. The image you get is something like this. This is your liver. The echo texture you can see is like this. The hepatic vein, the RA, and this is your IVC. Here, it has been color-coded for you. You put in a M mode at the origin of the hepatic vein, and this is the picture we get, and we can make our measurements during the minimum and the maximum measurements. Okay, so this is your M mode picture. So IVC distensibility, well and good, simple to use. Why not? Why do we need to think further? Well, there is a reason. So this is a paper that has been published in 2025 in original research articles in the SCCM. And here they have looked at the comparative efficacy, the area under receiver operating curves of different ways of looking at fluid assessment and these different dynamic markers as compared to bioreactance. Bioreactance, just to brief you a bit about it, is a way to measure the conduction of electricity and how it varies from beat to beat, and how that beat to beat variation changes from inspiration and expiration. When you look at these three phases of electricity, you get bioreactance. It is supposed to be as it is coming out, as long as your electrical conduction through the skin is okay, it is very accurate. So when they compared it with that, what they found was that the IVC distensibility, even in a completely sedated, paralyzed, mechanically ventilated patient, did not have the accuracy. It was the showing us a area under receiver operating curve value of 0.68, or in certain cases 0.7 at the best ends. When compared with the LVOT VTI, so what is LVOT VTI? Left ventricular outflow tract velocity time integral, right? So when they looked at that method where you are looking at the velocity time integral, then they found that it had a much higher association, more than 90% AUROC. So 0.9, more than 0.9 AUROC. So this is LVOT VTI, and what it is measuring and how it is measuring SV, we will be discussing it in a bit further, a bit more detail, in a little more granular way. So VTI, basically we are looking at the stroke distance. So stroke distance is how far an average column of blood has moved forward in one single contraction. So if I see velocity on one side and time on another side, if I plot each instance of this velocity under this curve and I add it up, so I will get a total distance traveled. So in arithmetic also, basic arithmetic also, what we discuss, when you combine when you multiply velocity and time, when you integrate them, then you get displacement. So this is what we are going for here. This is a visual representation where all these columns have been added and you get this distance. And once we have this distance, that will form our H. And to calculate the area of a volume of a cylinder, the other thing you need is the R, that is your LVOT. Diameter divided by 2 will give us the R, and based on that we can get the area. So how do we calculate our LVOT area? So for this we need a measurement in the parasternal long axis view. We zoom into the LVOT territory. We measure the LVOT diameter in centimeters, as you can see just beneath the aortic wall, and calculate the LVOT area using area of a circle formula, basically pi r square. So calculating the LVOT VTI, this is the place where you would measure it. For this, apical 5-chamber view has been recommended. Place your pulse wave Doppler at gateway Doppler at LVOT. Again, activate pulse wave Doppler, trace around the elevation, ejection wave, and record the VTI in centimeters. So what I showed you in the upside, think of that same diagram upside down and you get this waveform. When you measure it across this time, this is time on this axis, x-axis. So when you measure it across this, you get your VTI. As an example here, it has been shown 17 centimeters. So once you multiply your LVOT area and this VTI, then we get these two values together, the pi r square multiplied by h, and that gives us the stroke volume. So this is a direct measurement of stroke volume. The advantage of directly measuring the stroke volume with LVOT VTI, and probably what gives us the credence, what gives it the high AUROC in those studies, is that it is not dependent on your atrial contraction. It does not, arrhythmias do not have as large an impact when you are directly measuring the stroke volume. So that is why your assessment of cardiac output is more accurate. In our case, we will be measuring about the fluid responsiveness. These are just a few quick tips for you that how to optimize the plaques view for LVOT diameter measurement. Basic idea is that you should be able to see the major structures that we want to see, and our zoom should be such that we have to focus on the area that we are going to measure. It should not be that my LVOT diameter that I'm going to measure is being shown like the cone we get. If you are on one edge of the screen and you are measuring at that edge, you're never going to get an accurate value, because it's going to be a diagonal look through that. It's going to be a diagonal section through that LVOT diameter. You want it straight down. This is when you get, like sir also showed you the images and the flows. So when you look at the chamber apical view and you look at the aortic opening, not the classical diagram that you would get, but you get the idea that this is the ejection that is happening. Probably this is the valvular click that you're getting. And this is the part of the velocity time integral that we are going to measure. For this, we have to go to the settings, options, cardiac output. There is an option to choose LVOT VTI. You select that and the machine helps you calculate this tracing. Certain machines nowadays, I particularly use this machine, and this shows me, this has an option to automatically measure the VTI. If my trace is correct, if my heart rate is matching with the ECG, it can match my ejections with their velocity time. As you can see, there is a high respiratory variation here present. This is probably going to be your fluid responder patient, but we will discuss about this further. Right? So when we want to see this LVOT VTI and you have seen this measurement, once you have made these measurements, so the next step, what we are going to do, we are going to do a passive leg raising test, or you can do a mini bolus, right? So when we do a passive leg raising test, our head has to be up, propped up by 30 degrees. We have to give the patient time to equilibrate. And while keeping the probe in that same position, you want to bring the upper half of the body, the upper half which you have put at 30-degree elevation, parallel to the ground, which would effectively lift your legs up by 30 degrees. And at that point, you make a second VTI measurements. And when you have both the LVOT VTI measurements, the variability in that, the stroke volume increase, if it is more than 10%, it gives you a good idea. It shows you that this is the patient who is going to respond with fluids, right? And once we start looking at the LVOT VTI, what else is there? What are the other ways of thinking and talking about fluid assessment? So there is carotid indices, carotid velocity time integral. The indices have also been developed, the peak flows, the ratios of peak flow percentages. And based on that, we can also calculate the variability in that. Idea is to keep your probe steady. During the position, you have to keep your hand steady. You have to be there when you are doing the PLR so that you can measure the change in real time. Do not lose your view, because if you don't get the same view, your measurement is not going to be the same again, right? So in the same view, in the same patient, we have to get that measurement. Again, role of capillary refill time and POCUS and their integration. A great detail of that has been discussed in the Andromeda Shock 2 trials, the personalized resuscitation algorithm, which talks about how when you use capillary refill time, if it is not corrected by fluid bolus, how you will identify the fluid responders in that. It has been discussed in great detail in that. I would encourage you to go through that also, and we can discuss it also. And then again, going forward, this is whatever we have discussed up to now is all about preload. But preload is not the sole determinant of cardiac output. That is also when we are doing these fluid responsiveness assessment tests, one thing that I would urge you all to keep in your mind is that fluid responsiveness is not the sole determinant of cardiac output. Your heart rate, your afterload, your cardiac myocardial contractility, all those things have an equally, if not more important role also. Okay, so now the new concept of ventricular arterial coupling, basically now we are understanding the afterload even better than we used to earlier. So that is what we will be discussing about in further trials, right? So I thank you all for your attention. And if there are any points, anything you want me to discuss further, or you want to ask any questions, I'm here ready to answer. Right, sir? Thank you. Sir.
Thank you so much, sir. Now, moving on to next, we now move to an organ where POCUS brought us about a remarkable change in bedside assessment, that is the lungs. For this, I have privileged to invite Dr. Shrikant Srinivasan, sir, Chairman, Manipal Institute of Critical Care Medicine. Sir, may I request to kindly come on the stage and take over the session.
Yeah. Very good morning. I think I'll take the hand mic. Yeah. So as Dr. Sukanya has correctly said, this is probably the only modality which has totally changed the way we have approached our patients. If you ask me what has the change over the last 25 years of my doing intensive care, this modality has changed the way I examine my patients and has had the maximum impact on our day-to-day way of evaluating our patients on the bedside. Why? Because enormous potential. And this potential is based on the principle that any disease condition involving the lungs will produce some changes in the aeration pattern. The lungs are full of air. हवा भरा होता है. कोई भी disease होता है, so the ratio between the air and the tissue components will change. And that's going to produce some predictable patterns on which can be caught on ultrasound. If you have a stepwise approach to analyze those predictable patterns, artifacts, then you can come across a multitude of differential diagnosis. The word is differential. With a very high level of sensitivity and specificity, sometimes almost equivalent to that of a CT scan. Right? The impact, as I said, clinical तो मैं बता रहा हूँ, मतलब my experience बता ही रहा हूँ, but the literature also supports that 50% of the cases you may actually end up doing some intervention. You may end up changing the line of your management. And what it does is points you towards deranged physiology which is going on inside the patient real time. एक प्रोसेस शुरू हो गया है, आपने उसको आइडेंटिफाई कर दिया है. अब आपको डिसाइड करना है क्लिनिकली why is this process, why is this lungs getting deaerated or decongested or congested for that reason? What is the primary driving force behind it? And then only you will intervene. And the changes on ultrasound occurs much before any clinical changes occur. Much before there is desaturation. Patient may be just mildly tachypneic. No other change in the monitor, but the changes have already started on ultrasound. So that is how it is a very, very useful advanced warning system for what is going on and a real-time insight to what is going on inside the body. Advantages, rapid bedside diagnosis. The word diagnosis फिर भी गलत है यहाँ पे. Diagnosis सिर्फ एक ही modality में होता है, pneumothorax. वो भी उसमें lung point मिल गया तो. बाकी सब में it points you towards a direction. कि there is some reason why this patient is desaturating, hypoxemic, whatever. Since it's a bedside modality, there is no need to transfer the patient to a CT scan. So very safe in pregnant ladies. You can do it n number of times, and you should do it multiple times, repeated. Every time the patient becomes, there is some change in his oxygenation and ventilation, then that's the time when you should actually go ahead and do it. Repeatable, low recurring cost, and most importantly, very small learning curve. अब यही सबसे advantages बात. Unlike echo, which has a very big learning curve because it's a muscle memory. Echo करना muscle memory होता है. Your hand has to move, that rotation, tilting, everything has to, sliding, everything has to move in a specific sequence. And that only when you start doing it again and again and again, then you'll get some hang of it. इसमें कुछ नहीं करना है. इसमें सिर्फ probe लगना है और देखना है. So that's why the learning curve is the least. जो आज आप देख रहे हो, वो आपको याद भी हो जाएगा. And high sensitivity and specificity, sometimes, as I said, rivaling that of a CT scan. Now, uses just a few. There are many more to it. You can go to very much details, but this is just an overview. Diagnostic, therapeutic, monitoring. हमारे लिए सबसे शायद ज़रूरी है monitoring. Monitoring of the patient over a period of time. So in ICUs, that's what we do most of the time. We are only doing monitoring. Diagnostic part छोटा सा aspect है, therapeutic छोटा सा aspect है, बाकी सब monitoring होता है. Requirements. Good news, any probe can do. Why? Because we are dealing with artifacts. Artifacts are the noise, as Dr. Jha has initially said, the noise, the interference, the background chatter which goes on. So for that reason, if you remember the first talk, Dr. Prabhash had said, the tissue harmonic imaging एक चीज़ों को और refine कर देता है, सारा background noise हटा देता है, that should be switched off. Why? Because we want that background noise. The artifacts are created because of the background noise and we want it. So either we use a lung preset when we want to look at artifacts, or we switch off the tissue harmonic imaging. So then only you will be able to appreciate these artifacts. Since they are artifacts, they'll look the same with any probe. But important is that we need to have quick, rapid, reliable answers. Yes or no type answers. Is my lung expanded or not? Is there air outside the lungs in the pleural cavity in the form of a pneumothorax? Yes or not? If the lung is expanded, is it moving to and fro with every breath? Yes or not? If the lung is expanded and moving to and fro, is it congested or fully aerated? Yes or not? यही एक सवाल है. And can I see some gross pathology? Yes or no? यही 5 सवाल है. इसी के ऊपर सारा lung ultrasound revolve करता है. So any of these probes will do, but to start with, we go with this, the curvilinear. Why? Quick answer चाहिए. बड़ा probe है, 2-3 intercostal space में एक साथ चढ़ जाता है, तो 2-3 intercostal space एक साथ देख लेते हो आप. So you can see 2-3 intercostal spaces in one go, and can have a rapid. You just have to answer 3-4 questions. All those 5 questions I asked, यही 5 सवाल आपको हर intercostal space में देखते देखते आगे slide करना है. So the entire examination is going to take you 2 to 2.5 minutes. That's it. One side. 5 minutes में you're done. You have the answer with you. So start with this, but when they are different parts of the image. So there are sometimes you have to focus on the uppermost part of the image where you need to look at it with more clarity. There you may have to use this, but mostly this or this will suffice for this. And most important, training, practice. Training, learning curve is small. Practice you can always do on the bedside. We all need to follow a map, because I need to have the same map as you are having. If you are having some other map and I have some other map, we'll never reach where we want to reach. So we divide the zones in lungs into 6 arbitrary zones. Arbitrary means not based on any lung lobe or any segment or any such thing, but 6 zones. 2 anterior, above the nipple, below the nipple, upper and lower, 1 and 2. Axillary 3, infraaxillary 4. Scapular, मोस्टली स्कैपुला से बाउंड होता है तो कुछ खास दिखता नहीं है क्योंकि बोन है. 5 और 6 क्यों ज़रूरी है? क्योंकि फाइंडिंग्स आर डायनामिक. दे विल चेंज फ्रॉम टाइम टू टाइम. माइंड यू, विच मे सीम एब्सोल्युटली नॉर्मल टू यू, हाफ एन आवर में चीज़ें कैन टोटली चेंज. एंड दैट्स हाउ इज द ब्यूटी ऑफ दिस modality is that things will change so fast and much before anything else happens that you will be pre-warned of what is you're doing. So zone 6 unfortunately सबसे crucial है, at least for our ICU patients, and we rarely turn our patients around. How many times do you turn and auscultate from the behind? But the importance is that there are 6 zones, so you need to see 5 and 6 also. Most of the pathology, चाहे वो collapse हो, consolidations हो, effusion हो, सब gravity based नीचे ही आता है, 6 पे आता है. Normal X-ray जो AP view है, उसमें zone 6 नहीं दिखेगा, क्योंकि dome of diaphragm will obscure it. So the X-ray may look clean to you and the patient is grossly hypoxemic. Why? You turn the patient, put the probe, you see a large consolidation sitting there, you have your answer. So now let's just jump into the image formation. I'm sure most of you already must be knowing the few terminology. I'll just go through it quickly. So they are real images and they are artifacts. Real images क्या होता है? Real images में real time images of skin, subcutaneous tissue, muscle. आपको अगर पहला लेक्चर याद हो, एयर जहाँ से शुरू होती है वहाँ से आर्टिफैक्ट चालू हो जाती है, क्योंकि अल्ट्रासाउंड बीम्स विल बाउंस ऑफ फ्रॉम द टिश्यू एयर इंटरफेस. एयर तो अंदर है ना, शरीर के अंदर है ना, स्किन के थ्रू गया. अल्ट्रासाउंड कैसे एक्ट करता है? इट बाउंसेस बैक फ्रॉम टिश्यूज ऑफ डिफरेंट डेंसिटीज. स्किन का एक्स डेंसिटी है, सॉफ्ट टिश्यू का अलग डेंसिटी है, तो जो इंटरफेस बिटवीन ये तो डिफरेंट डेंसिटी वाले टिश्यूज है ना, वहाँ से दे स्टार्ट बाउंसिंग बैक. Right? When they start bouncing back, the machine will reconstruct those pixels into an image. Right? So skin will appear differently, the subcutaneous tissue will appear differently, the muscle will appear differently. Now what happens when it comes to air? Air की density तो 0 है. So when there is a sudden change in the density between the tissues and the air, there is bouncing and scattering. So air behaves like a mirror. It will behave like a refractile mirror. So it doesn't allow the beams to go through, and all the beams will scatter from the tissue air interface. Okay, and that's where the artifacts are produced. These artifacts can be normal artifacts which are seen in normal aerated lungs, and they could be pathological artifacts, which is what will form the foundation of lung ultrasound. So आपने एक linear probe लिया, छाती पे रख दिया. So you have these various parts of the image. You have skin, true image, subcutaneous tissue, true image. Then this is the muscle. तो देखिए different डेंसिटी से तो different लग रहे हैं देखने में, और हर जगह का स्किन ऐसे ही लगेगा, हर जगह का सबक्यूटेनियस टिश्यू ऐसे ही लगेगा, हर जगह का मसल ऐसे ही लगेगा. So you have kept the probe in such a way that you see a bright white line and a dark shadow. This is something which is extremely dense. The ribs are extremely dense, they are bones. So 100% reflection from the surface of the rib itself. So a bright white line and a black shadow beneath. No beams go through. And you see another bright white line and a black shadow. So this is the lower rib. So in दोनों ribs के बीच में क्या है? Intercostal space. And this is our area of interest. अब intercostal space में यहाँ तक तो अल्ट्रासाउंड बीम्स बढ़िया तरीके से आ गई पेनिट्रेट करते हुए. यहाँ पे टिश्यू एयर इंटरफेस आया थोरेसिक कैविटी के अंदर, तो वहाँ पे scattering will start. And you'll start seeing artifacts. The first artifact which you see right here is this bright white line. You see this bright white shiny line? This bright white line, sorry, ये line. This bright white line refers to the first tissue air interface within the thoracic cavity, and in any of us, it is a fully expanded lung. So the surface of the visceral pleura, or the surface of the lung, which is fully aerated, is in contact with the chest wall, right? And since it's filled with air, it produces this white line, which is an artifact. It's an artifact. This white line is called the pleural line. It corresponds to the surface of the lung. And this white line seems to be moving to and fro with every breath. हिल रहा है ना, आगे पीछे जा रहा है. So that means this area of lung beneath my probe is fully mobile and receiving some gas exchange. That's why it's moving to and fro. This to and fro movement is called lung sliding. ठीक है? तो दो चीजें. The first tissue air interface, which is closely approximated to the chest wall, is the pleural line here, and this to and fro movement is called lung sliding. So these are two things we have understood. इसके नीचे जो भी आता है ये सारा आर्टिफैक्ट्स, सारा आर्टिफैक्ट्स. अब किस तरह के आर्टिफैक्ट्स होते हैं ये भी बताते हैं, पर पहले we'll talk about the pleural line. Again to you, the bright white line, pleural line. The to and fro movement of the pleural line is what's called lung sliding. Now आपने अगर ध्यान दिया हो तो फर्स्ट टॉक में किसी ने बोला M mode. M mode का क्या मतलब है? There's a button called M. That is motion mode. If you want to put it in very simple parlance, it is basically to differentiate between mobile and relatively immobile structures along the line of this green beam. तो जब आप प्रोब को टाइटली चेस्ट के साथ प्रेस करे रखे हो तो स्किन सबक्यूटेनियस टिश्यू मसल्स तो हिलेंगे नहीं. तो जहां मूवमेंट नहीं होती वो स्ट्रेट लाइंस, हॉरिजॉन्टल स्ट्रेट लाइंस प्रोड्यूस करती हैं. द प्लूरल लाइन मूव्स so that any kind of movement on an M mode produces granularity. So if you have a normally expanded, fully expanded lung in approximation with the chest wall, moving to and fro with every breath, you will get this kind of appearance on an M mode. जैसे M mode select किया तो ये appearance आ जाएगा. So this is called the seashore appearance. देखने में ये sea है, ये surf है और ये sandy beach है. इसका क्या मतलब है? इसका मतलब यही है कि आपका प्लूरल लाइन हिल रहा है, हर ब्रेथ के साथ स्लाइड कर रहा है. दैट्स अबाउट इट. और ये करने की ज़रूरत भी क्यों है? कभी कभार क्या होता है, स्पेशली हाइपर इन्फ्लेटेड लंग्स में, एम्फाइसीमा हो गया, सीओपीडी हो गया, मूवमेंट बहुत कम होती है, बहुत ज़्यादा अप्रिशिएट नहीं होती है. एंड मूवमेंट इज़ इंपॉर्टेंट. वाई इज़ इट इंपॉर्टेंट? आई टेल यू वाई इज़ इट इंपॉर्टेंट. मूवमेंट है तो सब ठीक है, मूवमेंट नहीं है तो कुछ गड़बड़ है. अब मूवमेंट नहीं है तो क्या मतलब है वो भी बताऊँगा. सो इस मूवमेंट को रीवेरीफाई करने के लिए ये एम मोड वाला होता है. Not necessary you do in everything. If you can see it, there's no need to do this. Now let's talk about the artifacts which are below the pleural line. The most common artifact which you can see in all of us when you put the probe, and what you will see on your volunteers also, is A. What did I say? Air produces, is a mirror. It will produce reverberation artifacts. क्या है ना, surface of water है, आपने ज़रा हिला दिया तो multiple reflections दिखते हैं आपको. वैसे ही phenomena इसके साथ भी होता है. So you're going to see the same pleural line being reflected here, equidistant depth में. और ये depth क्या है between two artifacts is the distance from the skin to the first tissue air interface, that is the pleural line. इस depth को बार बार इस level पे ऐसे repetitive तरीके से दिखा जा रहा है. तो ये horizontal lines जो दिखते हैं आपको उस कोने में आपको दिख रहे हैं, यही A lines कहलाते हैं. A means air. मोटा मोटा समझ लो, A for air. A line with lung sliding, normally fully inflated lung. बहुत बढ़िया. A lines without lung sliding, हवा तो है पर स्लाइडिंग नहीं हो रहा, हो सकता है वो हवा लंग के बाहर है, in the form of a pneumothorax. So A with sliding, good. A without sliding, probably very bad. Okay, so यही difference है. COPD exacerbation में hyper inflated है but sliding preserved है, तो A with sliding. Pneumothorax में A without sliding. So that's why sliding was important. Now come to the enemy or the villain. This is B. जैसे A horizontal था, ये vertical है. ये तो सबको साफ समझ आ रहा है, ये vertical होता है. Vertical. So laser like straight bright white line starting from the pleural line going all the way to the bottom of the screen without fading, erasing out the underlying A lines. This is B. अगर आपको ध्यान से देखो तो ये एक फोटो बना रखी है ऊपर. इसका क्या मतलब है? This is the secondary pulmonary lobule. So this is supposed to be the functional unit of the lung. So क्या है? There are thousands of these pulmonary lobules all over the lungs. What does it contain of? It comprises predominantly of alveoli and the interstitium around the alveoli, which will contain the capillaries and the lymphatics. यही होता है secondary pulmonary lobule. ये secondary pulmonary lobule पूरे छाती के surface तक होता है, lung के surface तक होता है. Normally, it is fully inflated because alveoli are functioning. If it is fully inflated, 99% तो हवा ही है, 1% थोड़ा सा interstitium में जो टिश्यूज हैं, जो वेसल्स हैं, उसका प्रोपोर्शन होता है. हवा जहाँ तक है 99%, it will not allow beams to go through because just like a continuous air column, it will not allow. But what happens when the interstitium becomes thickened? Interstitium अगर thicken हो गया तो there are channels, अब पतले पतले चैनल बन गए जिसके अंदर से अल्ट्रासाउंड बीम घुस जाता है. अब वो घुस के they start vibrating like this. So they produce this B lines. So any condition which is going to thicken the interstitium or replace the alveolar air is going to produce B lines. तो समझ रहे हो? तो B line का मतलब ये नहीं कि सिर्फ पानी जमा हुआ है, ऐसा कुछ नहीं है. Interstitial fibrosis हो गया तब भी B line प्रोड्यूस होंगी. Interstitium thicken हो गया ना. Interstitial edema हुआ, interstitial pneumonia हुआ, ARDS हुआ, pulmonary contusion हुआ, सब में B line प्रोड्यूस होंगी. If it is limited to the interstitium, it will produce B lines which are like separated while nicely defined. If it involves alveoli also, then it will produce thick bands of white lines which are called lung rockets. So the more and closer the B lines are, the more is the degree of deaeration of the lung. Okay. So that is how we grade it. तो फिर से again revision for you. Horizontal, vertical, दोनों में difference ही है. More than 3 B lines in one single plane may be significant if there is a clinical correlation to it. हर चीज़ clinically correlate होता है, ऐसे random नहीं होता. How is this B line important? It is directly an indicator of extravascular lung water. तो interstitium सबसे commonly हमारे critical care setup में क्यों thicken होता है? Is because of leakiness of capillaries. Right? Capillary can leak because it is a leaky capillary state, as in sepsis. Or it could leak because of increased hydrostatic pressure, or it could leak because of an inflammatory or infectious processes. All these three things are the sum total of the cause of your leaky capillaries. So either the threshold is low for leakiness or the pressures are high, more than 18 pulmonary arterial occlusion pressure. In both the conditions, the capillaries will leak and they'll produce the same kind of B line. So B line is just an umbrella term to say that it could be because of a lot of conditions which are producing deaeration. The more the deaeration, the more the number of lines. तो थोड़े पड़े बहुत सारे, ये तो बिल्कुल भर गए. तो पेशेंट का कंडीशन यहाँ शुरू हुआ, आपने फ्लूइड देना शुरू किया दबा के 30 ml per kg, विद इन 5 minutes ऐसा हो गया बीच वाले की तरह. यू शुड स्टॉप राइट देयर. और दोगे तो तीसरे में पहुंच जाएगा एंड यू आर गोइंग टू क्रिएट iatrogenic lung injury. Mind you, the lungs have the maximum. Oh my God, only 1 minute left. अभी तो मैं शुरू किया. इतना कुछ बोल दिया मैंने. अच्छा ठीक है, सुनिए क्योंकि मेरा वो दूसरे वाला भी कंप्लीट हो जाएगा इसमें. हाँ, सो 5 मिनट में अगर यहाँ से यहाँ पहुँच गए, यू स्टॉप. व्हाई? बिकॉज iatrogenic लंग इंजरी हो रहा है. आप देखो लंग का सबसे मैक्सिमम कैपिलरी नेटवर्क इन द एंटायर बॉडी. हाँ, सो लंग फेसेस द ब्रंट ऑफ योर फ्लूइड थेरेपी, राइट? Whatever fluids you are giving, the brunt is faced by the lungs, followed by the encapsulated organ, which is the kidney and the liver. So these are the next organs which come into picture, but first and foremost the lungs. So we need to stop right there. The patient will not desaturate or anything, but after some time, if you continue on with your fluid therapy, that's going to happen, is number 3. So increase congestion, more the markers. तो A और B आपको समझ आ गया. What is the implication of an A? What's the implication of a B? What's the implication of preserved sliding? What's the implication of loss of sliding? ये मोटा मोटा clear हो गया, I hope. Now let's show you more lines. ठीक है, इंटरवल हो गया. हाँ नहीं मैं तो बोल रहा हूँ, मैं कौन सा रुक रहा हूँ. तो हाँ, आप देखिए सबकुटेनियस एम्फाइसीमा. अब सबकुटेनियस एम्फाइसीमा क्या है? हवा टिश्यूज में घुस गई. हवा टिश्यू में घुस गई तो टिश्यू एयर इंटरफेस टिश्यू में ही आ गया. टिश्यू एयर इंटरफेस से ही, मतलब जो हवा का जहाँ टिश्यू में घुसा है वहीं से आपका आर्टिफैक्ट्स शुरू हो गए. So since the artifacts are starting from the skin and subcutaneous tissue and muscle itself, and wherever there's artifacts, you can't make out what the underlying structures are. So there is no way you can make out whether the sliding is there or not, whether the pleural line can be visualized or not, and what is the A है या B है या क्या है, आपको नहीं पता चल सकता. So E lines, since this tissue air interface has moved into the soft tissues at different levels, you're going to be seeing something which look like B, but from the tissue, skin and subcutaneous tissue itself. तो superficially अगर आपको ऐसे linear streaks नजर आती हैं तो ये subcutaneous emphysema है. Subcutaneous emphysema का इंपॉर्टेंस ये है कि कोई तो कारण होगा जिसकी वजह से हो गया, नंबर 1. एंड अंडरलाइंग लंग का आप देख नहीं सकते बिकॉज आर्टिफैक्ट्स तो वहीं से चालू हो गए, तो नीचे का लंग का कुछ आइडिया नहीं लग सकता. अब उस प्लूरल लाइन को देखिए, हिल रहा है कि नहीं हिल रहा. फर्स्ट क्वेश्चन यही है, यस और नो. यस, हिल रहा है ना. हिल रहा है तो ठीक है, आई मीन नॉट एज बैड एज अ न्यूमोथोरैक्स, बट हिल रहा है. बट इज इट मूविंग टू एंड फ्रो विथ एवरी ब्रेथ, नाइस एंड लॉन्ग मूवमेंट? नो, रादर इट इज जस्ट फ्लिकरिंग. इट्स फ्लिकरिंग विथ द कार्डियक पल्सेशंस. See, the heart shares thoracic cavity along with the lungs. So every time the heart beats, it transmits its pulsations. During a breath pause, जब आपने सांस छोड़ के रुका हुआ है तो pulsations तो आती रहती है, वो नॉर्मल है. बट जब आप सांस लेते हो, यू आर सपोज टू सी अ नाइस बिग स्लाइडिंग. यदि वो नहीं हो रहा है और इंस्पिरेटरी फेज में भी आपको सिर्फ ये पल्सेशन ही नजर आ रही है, तो इसका मतलब यही है कि उस एरिया ऑफ लंग जो प्रोब के नीचे पड़ा हुआ है उसमें हवा नहीं पहुंच रही है. तो इसलिए वो ट्रांसमिट कर रहा है पैसिवली पल्सेशन को. सो द इंस्पिरेटरी एब्सेंस ऑफ अ लंग स्लाइड इज कॉल्ड अ लंग पल्स. सो विच कंडीशंस विल प्रोड्यूस दिस इज वेयरएवर देयर इज लैक ऑफ एरेशन ऑफ अ स्पेसिफिक एरिया ऑफ लंग. क्या दिमाग में आ रहा है, क्या कारण हो सकता है? म्यूकस प्लकिंग, एटेलेक्टेसिस, ठीक है. एंडोब्रोंकियल इंटुबेशन ऊपर साइड पे चला गया तो दूसरी साइड पे ऐसे ही पल्सेट करता रहेगा. ये पल्सेट तो करेगा, फिर क्या होगा? इस हवा का क्या होगा? रीअब्जॉर्ब हो जाएगा. रीअब्जॉर्ब हो जाएगा तो क्या आएगा? बी लाइन्स आना शुरू हो जाएंगे. वेरी गुड, वेरी गुड. बी आएंगे, सारे बी जुड़ जाएंगे, फिर वो बिल्कुल टिश्यू जैसा डीएरेटेड सा होके पड़ा रहेगा. दैट इज final stage of atelectasis. This is the earliest stage of atelectasis where there's a lung pulse. Okay. Consolidations one should understand and identify. There are specific patterns of consolidation. तो सबसे obvious sign of consolidation होता है liver-like deaerated tissue-like appearance of a lung. जब लंग के alveoli से हवा निकल जाए तो लंग तो ट्रू इमेज हो गया अब, क्योंकि इट इज अ टिश्यू नाउ. इट्स नो लॉन्गर एन एयर फिल्ड स्ट्रक्चर, इट्स अ टिश्यू. इट इज अ सॉलिड टिश्यू, सेमी सॉलिड, फ्लूइड वाटर वो जो भी भरा हुआ है, पर एल्वेलाई में हवा नहीं है. तो दिस टर्न्स आउट टू व्हाट्स कॉल्ड हेपेटाइज्ड और लिवर लाइक लंग. सो दैट इज हेपेटाइजेशन. हेपेटाइजेशन इज वन ऑफ द साइंस ऑफ कंसोलिडेशन. सेकेंड साइन ऑफ कंसोलिडेशन, विद इन दिस हेपेटाइजेशन यू मे सी these white streaks coming and going. These white streaks coming and going is basically the bronchi bronchioles which are still open. हवा आ रही है, जा रही है, आ रही है, जा रही है. So this is called dynamic air bronchograms. ये आपको सिटी में भी नहीं नजर आता क्योंकि इंस्पिरेटरी एक्सपिरेटरी फेज दोनों है इसमें. एंड दिस इज पैथोग्नोमिक ऑफ अ कंसोलिडेशन एंड डिफरेंशिएट्स इट फ्रॉम अ एटेलेक्टेसिस. मैंने क्या बोला, वो सॉलिड टिश्यू तो एटेलेक्टेसिस में भी बन सकता है, बट यदि ये मिल रहा है आपको तो ये कंसोलिडेशन है. पोस्ट ऑफ डे 2 जोन 4 ये मिल गया तो जितना भी आप ठोक बजा लो, फिजियोथेरेपी कर लो, ठीक नहीं होने वाला. ये कंसोलिडेशन है. ओके, इट्स नॉट एटेलेक्टेसिस, राइट? So this is dynamic air bronchograms. The third thing, which is more commonly in our ICU setup, is this. सरफेस ऑफ लंग कंसोलिडेट हो गया, सॉलिड हो गया, यहाँ तक तो ट्रू इमेज आ रहा है, अल्ट्रासाउंड बीम जा पा रही है बढ़िया से। अंदर जाते जाते कहीं तो होगा जहाँ हवा आ रही है अभी भी, तो इट लुक्स लाइक अ प्लूरल लाइन विद इन द लंग टिश्यू। नॉर्मली प्लूरल लाइन तो सरफेस पे होता है ना, तो ये टिश्यू एयर इंटरफेस विद इन द लंग टिश्यू इज कॉल्ड अ श्रेड। तो बहुत सिंपल टर्म में tissue air interface or the pleural line, something which looks like a pleural line within the lung tissue, that is called a shred. It is a translobar consolidation. It's the most common form of consolidation which we see in our ICUs, right? So it can be thought of as a, this is how it looks like when you see this. So देख रहे हैं ना, ऐसा लग रहा है जैसे कि ये tissue air interface तो यहाँ lung के अंदर है, तो this is a shred. This is the third form of consolidation. तो मोटा मोटा these are the 3 different types जो consolidation में आपको नजर आएगा. Okay, atelectasis, first stage lung pulse. Gradually धीरे धीरे हवा निकल जाएगी तो फिर ये totally solid deaerated piece of lung with loss of lung volume रहेगा. Loss of lung volume मतलब the diaphragm of that side is pushed upwards, the surrounding effusion is much more, and this small area seems to be pulsatile because it is just transmitting pulsation, and there are no dynamic air bronchograms. So all these things will suggest that this is atelectasis, probably because of some plugging, and can be definitely relieved once you remove the plug or you drain out this fluid. One of the two things. The lung should re-expand promptly. So how do you differentiate between consolidation and atelectasis? Yeah. Dynamic air bronchograms, static air bronchograms. कलर डालेंगे तो ब्लड फ्लो कंसोलिडेशन में ज़्यादा होगा, atelectasis में कम होगा, राइट? यूजुअली कंसोलिडेशन हैज कॉम्प्लेक्स प्लूरल एफ्यूजन, सेप्टेशंस वगैरह इधर होती हैं, एंड द क्वांटिटी ऑफ एफ्यूजन इज यूजुअली लेसर. atelectasis में सिंपल एंड लार्ज एफ्यूजन होते हैं क्योंकि लंग कोलैप्स छोटा हो गया है. कंसोलिडेशन में देयर इज प्रिजर्व्ड लंग वॉल्यूम. व्हाई? बिकॉज द एल्वियोलर एयर हैज बीन रिप्लेस्ड बाय सेल्युलर डेब्री, फ्लूइड मटेरियल, सो ऑन. तो आर्किटेक्चर मेंटेन्ड है, यहाँ कोलैप्स हो गया है, तो देयर इज अ डिफरेंस. ओके, सेंसिटिविटी या स्पेसिफिसिटी बहुत हाई है दोनों के बीच में डिफरेंशिएट करने के लिए, सो यू कैन एक्चुअली मेक आउट टू लॉट ऑफ एक्सटेंट. सो यू कैन सी दिस. नाउ डू वी गो अबाउट सीइंग ए बी सी क्या है, कितने काउंट करना है? नो. दो 6 zones you remember, 1 2 3 4 5 6. We look at the predominant pattern in each zone, and what patterns can be there is these 1 2 3 4 5 patterns. First pattern, A profile, A lines with sliding, जो normal aerated lungs होती हैं, ये predominant है. तो अगर आप बोलो zone 1 में A profile है, तो everybody understands that we are talking about normal lung sliding with A lines. Put this to memory. ये pleural line हिलती हुई नजर आ रही है, to and fro, up and down हो रही है, to and fro तो नहीं हो रही. This is a static A line, static A. This is extra pulmonary air. So A lines without sliding, a pneumothorax. I'll show you more in detail. B lines straight with lung sliding. This is B profile. If it is bilaterally symmetrical, gravity based, it is hydrostatic pulmonary edema. So next obvious question, how is the heart? Is it a systolic heart failure? Is it a diastolic heart failure? And answer भी simple है, decongestion, positive pressure ventilation. दोनों चीजों से काम हो जाएगा. This on the other hand, you can see the pleural line seems irregular. They are B lines and the movement is very much restricted, है ना? तो ये restricted sliding का क्या मतलब है? ये inflammatory edema है, तो दोनों प्लूरा के लेयर्स चिपक गए आपस में, तो ये स्लाइड नहीं कर पा रहा है. Even a slightly deep-seated consolidation will produce this on the surface. तो चाहे consolidation 2-3 सेंटीमीटर अंदर हो स्किन से, मतलब सरफेस से, तब भी ऐसा सरफेस पर प्रोड्यूस करेगा. So this is inflammatory B lines profile. So this is seen in ARDS, it is seen in lung contusions, it is seen in interstitial pneumonia. जो viral pneumonias होते हैं उसमें ये ऐसे ही होता है देखने में, and not necessarily will follow laws of gravity. It may be more anteriorly, lesser laterally, and so on and so forth. It can have all kind of patterns. And finally, this consolidation pattern, this shred, which we also, okay. So best aeration is when we, from here, if it's deaerating, then it's going to become like this, then this, then this. If you're going to re-aerate, it's going to become like this, then this. But mind you, this, beyond this, we do not know this is normally aerated or is it hyperinflated. Hyperinflation cannot be seen on lung ultrasound. Hyperinflation is equally dangerous. Why? Because of volutrauma, barotrauma and all that. So hyperinflation भी A profile ही लगेगा, बट आपको नहीं पता कि ये ज़्यादा है कि कम है. निमोथोरैक्स में फिर से आपको याद दिला दूं, स्टैटिक कहाँ पे कलेक्ट होने वाला है, जोन 1 या जोन 2. हवा तो आगे को आएगी, पीछे थोड़ी चली जाएगी, तो यहीं आएगी, यहीं ढूंढोगे. It has to be a reason why there's a pneumothorax. You have put in a line, you have given very high pressures, the patient has coughed vigorously on a tube, हो गया pneumothorax. या कोई बुला बुला था वो फट गया है तो ऐसा था. तो ये तुरंत आपको बता रहा है immediately pneumothorax है. As soon as the lung is pushed away from the chest wall and even with the slightest amount of air in middle, this will start. It does not quantify the amount of pneumothorax you have. It will just tell you that there is separation of the chest lung from the chest. So once you find a pneumothorax, you're going to search for the margin of the pneumothorax. So you're going to go and search down, down, down. यहाँ पे you see a zone of transition. Purely static movement. This is the margin of your pneumothorax. If you put in an ICD, you want to put it this side, not this side. And you're going to see return of this movement all the way along if your ICD is correctly placed. So diagnostic, therapeutic, monitoring, all three together. And this confirms the diagnosis of pneumothorax to 99.9. Why 0.9 तक क्यों ना 100%? क्योंकि कभी कभार हम फ्लोरोडेसिस करते हैं तभी ऐसे दिखता है, चिपका देते हैं ना एक साइड की लंग को, तो इसलिए ये साइड कभी कभार मूव नहीं करेगा. दैट इज वन. दूसरा चीज विच कैन प्रोड्यूस इज अ लार्ज बुल्ला दैट कैन ऑल्सो लुक समटाइम लाइक दिस with the margin of the bulla looking like this. So a large bulla, like almost 1/3 of the lung, can produce a similar kind of a picture. So that these are the only two areas where we may be having some confusion. Otherwise, it is diagnostic and the only diagnostic modality. ARDS, again, bilateral disease, inflammatory edema, not necessarily gravity based. So, and unlike a smooth pleural line, is going to be a shattered pleural line and irregular ऐसे ना गंदे से B lines with decreased sliding. So irregular fragmented pleural lines, small micro consolidations and non-homogeneous B lines. आपने बहुत सारा प्लाज्मा किसी को दे दिया 20 ml per kg for correction of coagulopathy. थोड़ी देर में डिसैचुरेट कर गया आप, यू आर वरीड ये 35% हार्ट फंक्शन था, क्या पता इसको ओवरलोड हो गया है या इसको ट्राली हो गया है. ये है तो ये ट्राली है. दूसरा था बायलैटरल बी होता, ग्रेविटी बेस्ड होता, वो टाको था, associated circulatory overload. There has just a diuretic would have helped you, but here diuretic won't help you much. It will, but not too much, and the prognosis is different. So for ARDS, it is diagnostic, it's for monitoring. It will tell you aeration कैसा है, aeration का distribution कैसा है, prone position से फर्क पड़ेगा कि नहीं पड़ेगा, ठीक है, and whether when you start weaning, how was the patient going to tolerate the weaning, and fluid resuscitation देना है, नहीं देना है, कम करना है. Subphenotyping, focal versus non-focal, and complication in the form of pneumothorax or VAP. You can do, these are the various utility of lung ultrasound. There's a lot to speak, so we'll not go too much into this. So फिर से pulmonary edema versus ARDS. Pulmonary edema मतलब hydrostatic pulmonary edema versus ARDS. Lines, ये वाला ये चीज़, तो दोनों में फर्क समझ लो. ये हो गया, प्रोफाइल्स हमने कर दिया. Now coming to blue protocol, which I have to also cover in the protocolized approach. So blue protocol is basically a 3-step approach to diagnosing pulmonary edema, pulmonary embolism, COPD, pneumonia, pneumothorax with 91% accuracy by seeing lung ultrasound alone. आपने मरीज से बात भी नहीं किया, आपने सिर्फ प्रोब रखा और आपने ये कर लिया. 3-step approach. First, anteriorly and laterally, you look for whether sliding is there, yes or no. Second question, is it A profile, is it B profile, is it a consolidation profile, is it A dash or a B dash profile. जब anterior और laterally कुछ नहीं मिलता, तो then you start looking posteriorly in stage 3, which is we look at the posterolateral alveolar pleural syndrome. That means look for collapse, consolidation, effusion in zone 5, zone 6, zone 4. Right? So this is the blue protocol, but now we have to go above the blue protocol and beyond. So see, we can't be just limited at one. Blue protocol बना था ER physicians के लिए, हमें तो उसके आगे जाना है ना. So we have to always confirm or reaffirm the diagnosis with a further modality. अगर आप pulmonary embolism सोच रहे हैं, हार्ट का evaluation तो करेंगे ना, उसके बिना थोड़ी pulmonary embolism बना देंगे किसी को. तो हार्ट का evaluation में आपको राइट साइड में acute dilatation मिलेगा, septum moving towards the left मिलेगा जो normally राइट की तरफ रहता है, and the right sides of the heart will become almost equivalent to the left side of the heart. So these are the three things which you will say. फिर आप pulmonary acceleration time, McConnell sign, eccentric ratio, ये सब चीज़ें आप कर सकते हो. But that will tell you that this is what it is. Cardiogenic edema के लिए you have to look at left ventricular systolic function, global versus regional, and you have to look for diastolic function of heart. दोनों चीज़ों की देखना पड़ेगा. Right? So, an ARDS के diagnosis के लिए you have to exclude heart failure as a cause of ARDS because definition में है, इसलिए you have to do it. So, इसलिए an echo has to be accompanied along with the blue protocol. Now, can we quantify this amount of aeration, deaeration? Yes, to some extent, we can have a lung ultrasound score, which will sort of tell you a semi-objective way of measuring whether deaeration or aeration is occurring. Why? Because 4 patterns हैं. A pattern, few B lines, coalescent B line and a consolidation. यही है degree of deaeration होता है ना. तो जैसे आप रिक्रूटमेंट कर रहे हो, यहाँ से यहाँ पहुँच गया तो आपने बहुत सारा लंग रिक्रूट कर लिया, लंग वापस हवा आनी शुरू हो गई. या जब वीनिंग कर रहे हो, यहाँ से यहाँ पहुँच गया तो बहुत सारा लंग डीएरेट हो गया है. So this aeration deaeration score, which is now modified, and 0, 1, 2, 3. So you look for both the lungs and you calculate a total amount of aeration score and deaeration score. Aeration score आप use करते हो recruitment के time पे, deaeration score आप use करते हो weaning के time पे. Weaning is more reliable as compared to recruitment. Why? Because I said hyperinflation cannot be seen. So जहाँ आपको लग रहा है recruit हो रहा है, ARDS non-homogeneous disease है. जहाँ आप collapsed area को recruit कर रहे हो, वहाँ normal area फट जाएंगी. तो इसलिए आपको इतना भी नहीं देना है, आपको नॉर्मल एरिया को ही जितना पार्शियली कोलैप्स्ड है यहाँ से यहाँ लाना है. दैट्स इट. उसके ऊपर पीपी नहीं दे देना है, नहीं तो फट जाएगा. तो ऑन द अदर हैंड ड्यूरिंग वीनिंग इट्स वेरी यूजफुल बिकॉज चेंज ऑफ अ पैटर्न फ्रॉम हियर टू देयर and an increase in score by more than 18 will say that you will fail weaning irrespective of whether your other weaning indices allow you to go ahead and extubate the patient. So क्योंकि आपका ऑक्सीजन डिसोसिएशन कर्व इज लाइक अ बेल शेप्ड होता है ना, तो इसलिए lot of fall in PaO2 can occur before actual desaturation occurs. So a lot of de-recruitment can occur, which can go on during a spontaneous breathing trial, and if you don't see it, then you may extubate the patient, and after some time the patient will again end up back on a ventilator. So how can you avoid it? Continue with non-invasive CPAP दो, BiPAP दो, continue करो. The same thing can be used, as I said, lung is the shock organ for your fluid therapy. तो फ्लूइड दे रहे हो, that should be always having an eye on the lung. So that's why the false protocol has been made, जिसमें आप, this is fluid administration limited by lung ultrasound. इसका full form ये है, fluid administration limited by lung ultrasound. So there is a stepwise approach to obstructive shock में क्या करोगे, cardiogenic में क्या करोगे, hypovolemic में क्या करोगे, lots to it. ये सब मैं सिर्फ बता रहा हूँ आपको क्या क्या हो सकता है. And this is what is of our interest. Aeration recruitment मैंने बताया, PEEP settings, ऑप्टिमम वेंटिलेटर स्ट्रैटेजी, मतलब प्रोन करना है कि नहीं करना है, किस पेशेंट को ज़्यादा प्रोन करने का बेनिफिट होने वाला है, किसको नहीं होने वाला है, किसको हाई पीप स्ट्रैटेजी काम करेगा, ये सब चीज़ें आप एसेस कर सकते हो. कॉम्प्लिकेशंस एंड वीनिंग, रिक्रूटमेंट वी कैन हैव दिस डिस्कशन ऑन द बेड साइड बिकॉज इट्स टू मच एंड आई ऑलरेडी टेकन टू मच टाइम. एंड वीनिंग क्या क्या करना होता है, दिस इज हाउ इट इज. बिफोर स्पॉन्टेनियस ब्रीथिंग ट्रायल, ड्यूरिंग स्पॉन्टेनियस ब्रीथिंग ट्रायल एंड आफ्टर फेलियर ऑफ स्पॉन्टेनियस ब्रीथिंग ट्रायल, तीनों स्टेज में करना है. आपको समझ आ जाएगा कि क्यों आप सक्सेसफुल हुए तो क्यों हुए, नहीं हुए तो क्यों नहीं हुए. तो लिमिटेशंस, सरफेस टेक्निक, आप जो बातें कर रहे हो इतने सारे, ओनली 1/16 ऑफ द लंग यू आर सीइंग, 1/16, 1/116, 1 डिवाइडेड बाय 16, क्योंकि रिब्स हैं, स्कैपुला है, इन बीच में जो, और सिर्फ सरफेस देख रहे हो आप, उसके बेसिस में आपने इतना कुछ बता दिया, which is actually true because that's the impact of this modality. By just simply seeing the surface, I have come across so many things. So deeper pathology, parahilar कुछ lymph node पड़ा है, parahilar consolidations हैं, वो नहीं दिखेंगे आप. But anything else which produces significant physiological derangement, वो जरूर दिख जाएगा. More importantly, to use it as an ultra diagnostic use for everything and anything, ये हर चीज़ का यही मेरा solution है, ये भी गलत है, नहीं है. इसके बहुत सारे शेड्स ऑफ ग्रे होते हैं. ये तो मैं आपको सिर्फ वो जो ट्रेलर दे रहा हूँ, असली मूवी तो बहुत कुछ है. कैन बी अ डेंजरस थिंग, रिक्वायर्स फॉर्मल ट्रेनिंग. ओबेसिटी हो गया, सबक्यूटेनियस एम्फिजिमा हो गया, लार्ज ड्रेसिंग हो गया, इसमें दिखाई नहीं देगा कुछ. सो गुड अल्टरनेटिव, शॉर्टेस्ट लर्निंग कर्व, स्टेप बाय स्टेप यूज एंड मोस्ट प्रॉमिसिंग modality. And I will again reiterate the point that this is a must know skill for all of us intensivists, and doesn't require anything. मतलब बस probe रखना है, artifacts देखने हैं, that's it, और कुछ नहीं करना है. चलिए, thank you. Question? हाँ, बस बताओ.
So it's just a practical question that I wanted to ask. In a ICU which is equipped with the ultrasound, if I am there on duty and I see a patient developing pneumothorax and there is an element of hemodynamic instability also.
Yes.
We have learned and we've been taught again and again that this is not the time to get an X-ray. You decompress the lung first because this is going towards tension pneumothorax. In a similar kind of situation or maybe a grade less severe, if I am there and I have a USG at my bedside, do you want me to do that USG? And if I do that USG to document that pneumothorax, do I document it with a printout before and after decompression, or should I not get into all this and just focus on the clinical aspect?
See, two things. Tension pneumothorax, no brainer. You have to put in an ICD. Okay, that's a clinical diagnosis. As I said, ultrasound will show you that there is a pneumothorax. It will not quantify the pneumothorax to you. Maybe you may have a complete collapse and no lung point at all. पूरी तरह लंग कोलैप्स हो गया तो लंग पॉइंट तो दिखेगा ही नहीं ना आपको. जो एल्गोरिदम है वो कहता है अगर कंप्लीट कोलैप्स है, लंग पॉइंट नहीं दिख रहा है, तो यूज अदर मोडालिटीज टू कंफर्म, प्रोवाइडेड द पेशेंट इज नॉट अनस्टेबल द वे यू आर सेइंग. अनस्टेबल है, आईसीडी तुरंत. आपने लाइन डालने की बहुत सारी कोशिश करी, इमीडिएटली प्रेशर्स बढ़ गया, एक साइड में आपको स्लाइडिंग गायब हो गया. यू नो व्हाट यू हैव डन. गो अहेड एंड डू इट इफ द पेशेंट बिकम्स अनस्टेबल. इफ द पेशेंट इज स्टेबल, हर न्यूमोथोरैक्स में आईसीडी डालने की जरूरत नहीं होती. महज ऑक्सीजन सप्लीमेंटेशन, वेटफुल वॉच, रिड्यूसिंग द प्रेशर से काम हो जाना चाहिए. अगर पॉजिटिव प्रेशर में नहीं भी है तब तो बिल्कुल ही ज़रूरत कम होती है. ठीक है, तो उन दोज केसेस फॉर यू टू डॉक्यूमेंट इज फॉर योर ओन सेल्फ. यू कैन डू वट एवर डॉक्यूमेंटेशन यू वॉन्ट टू डू. दैट विल नॉट चेंज एनीथिंग अबाउट द लाइन ऑफ योर मैनेजमेंट. योर इंपॉर्टेंट थिंग इज दैट इज दिस न्यूमोथोरैक्स प्रोग्रेसिंग और नॉट. सपोज देखिए आपको एक न्यूमोथोरैक्स मिल गया, छोटा सा एरिया है, लंग स्लाइडिंग, सेकंड थर्ड इंटरकॉस्टल स्पेस में लंग पॉइंट मिल गया. ओके, patient is asymptomatic, you are also relieved, no tachypnea, you have just supplemented, gone off on your work. After some time, half an hour, you come back again, check. You have marked that point, you come back and check again. The same lung point has moved to 6th to 7th or 7th to 8th intercostal space. This is an expanding pneumothorax. There is no doubt about it. This is expanding. If not now, maybe 10, 15, 20 minutes, half an hour baad, it's going to end up in a tension kind of a situation. There you will definitely intervene. So a progressive continuity of monitoring is very, very valuable in these cases. And marking and going. आप 24 घंटे तो नहीं रहोगे ना. आपने आइडेंटिफाई कर दिया, आपने स्पेसिफाई किया. That's why the map comes into the picture. Zone 1, 3rd, 4th intercostal space, lung point. So guy coming next to you suddenly sees is gone to zone 3. मतलब या zone 4 में पहुंच गया. So then that person knows that ये तो progress कर गया है. And then will intervene accordingly. Right? So this is how we are going to approach a pneumothorax case. If we have a complete pneumothorax with no lung point, there they still say go ahead and do a CT, X-ray, bedside X-ray करा लो, उसमें तो पूरा दिख जाएगा, लंग कोलैप्स हुआ दिख जाएगा. उस दौरान कभी भी बीच में एक्सरे करते करते अनस्टेबल हो गया, आईसीडी डाल दो, go ahead and do an ICD. There is no question about it. So life saving always takes precedence over any other form of confirmation or non-confirmation. You can always err on the side of caution. And this gives you a diagnostic approach. ऐसा नहीं, it's not going to give you a diagnosis, it's going to give you a diagnostic approach. और कुछ? हाँ, बताइए.
देखे ये देखे, बट आई वांट टू हैव सम इनसाइट फ्रॉम यू कि आप लंग अल्ट्रासाउंड को P4 बेस्ट कंप्लायंस कैसे देखते हैं,
हाँ.
प्रोडिंग के बाद या पहले?
सबसे पहले तो प्रोडिंग किस में करना है किस में नहीं करना है वो डिसाइड करना. हम ये लेके चल रहे हैं ARDS है, नॉन होमोजेनस डिजीज है. प्राइमरी ARDS, सेकेंडरी ARDS नाम की चीज़ होती है, और हाइपर इन्फ्लेमेटरी ARDS एंड फिनोटाइप होता है और नॉन इन्फ्लेमेटरी फिनोटाइप होता है. दे आर डिफरेंट थिंग्स. Hyperinflammatory phenotype usually associated with a secondary ARDS where the primary organ is somewhere else, but because of the cytokine storm, your lung has got hit. Because the maximum capillary network, lung has got hit. Chunki the lung is getting hit because of an outside process, it again is mostly gravity based. आप समझ रहे हो? तो वो लीकीनेस चालू हो गया, वहाँ पे इन्फ्लेमेशन हो गया, लीकीनेस चालू हो गया, बट स्टिल मोर और लेस ग्रेविटी बेस्ड कि भाई लैटरल ज़्यादा, पोस्टीरियर और भी ज़्यादा, एंटीरियरली थोड़ा स्पेड बेबी लंग. अब ऐसे कंडीशन में अगर मैं बहुत हाई पीप दूंगा तो सिर्फ एंटीरियर लंग फाड़ूंगा और पोस्टीरियर लंग नहीं खुलेगा. One should understand that consolidations cannot be opened up with PEEP. First thing you get it out of your mind, I'll be able to open this consolidation by squeezing my back. It does not happen. At that pressure, you're going to burst the other lungs. So we do not focus on the consolidated part at all. We are focusing on something else. So we are going to first of all differentiate how is my distribution of my infiltrates. If my distribution of infiltrates is global, lot of lines all over, anterior B, lateral B, posterior B, such patients will benefit from a high PEEP strategy. It's a global disease, so globally it is there. It is not any area of sparing or something. Global है, पीप देंगे 14, 15, 16 भी जा सकते हो, कोई दिक्कत नहीं, इसे प्रोन करने की जरूरत नहीं लग रही. What about those इसमें ग्रेविटी बेस्ड है, अब उसमें प्रोन करने का फायदा होगा बिकॉज आपने उल्टा कर दिया, आप बहुत हाई पीप दे नहीं सकते. One of the reasons why we prone is that we want to restrict the amount of PEEP also what we want to give. If you can't go to very high amount of PEEP, proning becomes a good measure out from that, either because of a right heart failure or whatever, you're not able to give too much of PEEP, or the patient is not tolerating, their proning becomes a good exercise. So seeing the distribution of lesion, first of all decide high PEEP versus proning strategy. जिसमें posterior involvement ज़्यादा है, gravity base लग रहा है, उसमें prone करिएगा. प्रोन करने से थोड़ा रीडिस्ट्रीब्यूशन, ब्लड का सर्कुलेशन वैसे का वैसा रहेगा, तो वो उसका ओपन अप करने का चांसेस मच हायर होता है विद अ लेसर पीप. तो ये रही बात आपकी. और दूसरा पार्ट क्या था, मैं भूल गया. रिक्रूटमेंट. तो मैंने अपना हाई पीप और लो पीप बता दिया ना आपको. एक बार आप, मैंने जैसे बताया कि यू आर ओनली व्हेन यू आर ट्राइंग टू गिव हाई पीप, इन हाई पीप स्ट्रेटजी यू आर लुकिंग एट द एंटीरियर पार्ट ऑफ द लंग्स, नॉट द पोस्टीरियर पार्ट ऑफ द लंग्स. एंटीरियर 1 and 2 पे डिसाइड फोकस करके कर रहे हो, बिकॉज चाहे कुछ भी हो, ग्रेविटी बेस सबसे एंटीरियर पार्ट ही थोड़ा बहुत एरेटेड रहता है एज कम्पेयर टू जैसे जैसे नीचे जाते जाओ उतना उतना कम रहता है. सो इस बेबी लंग वाले एरिया को जितना खोल सकते हो उतना ही खोलने का प्रोसेस करना है. उस एरिया में सपोज फ्रॉम B2 दैट इज कंजेस्टेड B से A की तरफ आ गया, बस उतना ही है, उसके ऊपर नहीं है. So unlike trying to look from behind and trying to open a consolidation, which you should not do and not set the PEEP accordingly, you are focusing on the more anterior parts and trying to keep that open. That is the level in which the amount of PEEP has to be set. Okay. So the recruitment strategy works in reverse here. You don't look at the collapse part, you look at the A part, which is partially open and try to open it fully. That's it. And जो collapsed है, उसको आप उल्टा करोगे. यही बात अगर कंसोलिडेशन है, कंसोलिडेशन सपोज एक निमोनिया है, निमोनिया में हाई पीप डज नॉट वर्क. वाई? बिकॉज वो कंसोलिडेट एरिया कभी नहीं खुलेगा, बाकी लंग का आपने ब्लड डाइवर्ट कर दिया बिकॉज ऑफ एक्सेसिव alveolar hyperinflation, you have diverted towards the diseased lung. So any unilateral consolidation, never ever a high PEEP strategy is useful in this. So that is a misnomer, a misconception. ये PEEP बढ़ा देने के ऑक्सीडेशन बढ़ जाएगा, नहीं, आपका ब्लड सप्लाई उल्टी तरफ चला जाएगा, जो वो डिजीज लंग है, नहीं होता. So it's only in a global scenario that we'll think about high PEEP, low PEEP and all this stuff. Right? और कोई? हाँ.
Obstetric collapse and compression collapse by the air bronchogram, dynamic air bronchogram.
Yes, a very very relevant question for people who are doing regularly. देखिए, अगर छोटा सा एफ्यूजन है, उसमें एक कंसोलिडेटेड लंग पड़ा हुआ है, उसमें डायनामिक एयर ब्रोंकोग्राम्स दिख रहे हैं, तो वो कंसोलिडेशन ही है. वो एफ्यूजन में इतना नहीं मान सकता कि वो लंग को दबा के बैठा हो. देखो क्या है ना कि हमारे ब्रोंकियल्स तो कार्टिलेजिनस होते हैं, वो एरिया खुली रहती है. अगर सराउंडिंग वॉल्यूम इतना ज़्यादा है कि वो लंग को पैसिवली कंप्रेस करे बैठा है, जैसे कंप्रेसिव एटेलेक्टेसिस, देयर यू मे स्टिल सी अ फ्यू डायनामिक air bronchograms, and as soon as you release the compression by draining out the fluid, the lung will open up fully. So a dynamic air bronchogram in the background of a huge effusion in which the lung is freely floating, there it may be simply compression atelectasis. This is one of the exceptions in the rule, but otherwise small effusion 1 centimeter 2 centimeter thick is unlikely to collapse a lung to a level कि मैं सोचूं कि भाई alveoli सारे collapse हो गए, सिर्फ bronchi खुले पड़े. वो consolidation ही है, वो passive collapse या नहीं है, वो it is a pure consolidation, right? So as I said, atelectasis में large volume of effusion, okay, because loss of lung volume हो रहा है. So compressive atelectasis के लिए, as I said, there could be intrinsic compression, intrinsic blockade, the air is not going, or it could be an extrinsic, the fluid is so much that it is not allowing the lung to expand. दोनों चीज़ें हो सकती हैं. तो जैसे आप पानी निकाल दोगे, लंग खुल गया, तो दैट मीन्स इट वाज जस्ट अ कंप्रेशन. दैट्स इट.
Can you tell us what is the difference between the acute, say, lobar collapse, left side collapse or right side of lung collapse, and the latest stage of lung collapse? How can we differentiate with the
अर्ली स्टेज में लंग पल्स मिलेगा जी, एक साइड में एरेशन चला गया. इट्स सुपर एक्यूट, सुपर एक्यूट. अभी कोलैप्स हुआ नहीं कि आपने प्रोब रखा और वहाँ पल्सेशन नहीं हो रहा है और कुछ नहीं, स्लाइडिंग नहीं हो रहा है, तो आपको तुरंत पता है कि भाई कोलैप्स इमीडिएटली हो गया है. उसको आप छोड़ दोगे, कुछ नहीं करोगे, तो धीरे धीरे वो रीअब्जॉर्ब होकर एफ्यूजन बन के वो टोटल कोलैप्स ही हो जाएगा. राइट. तो फिजियोथेरेपी, ब्रोंकोस्कोपी एंड ऑल, ब्रोंकोस्कोपी का रेस्पॉन्स भी आपको समझ आ जाएगा कि लंग खुला कि नहीं खुला, तो वो इमीडिएटली आपको पता चल जाता है लंग खुल गया कि नहीं खुला. राइट. एनी अदर? ओके, थैंक्स.
Thank you so much, sir, for the insightful session. By far, we have it in scientifically significant session. Now it's time for inauguration ceremony. For that, I would like to request all the dignitaries and faculty members to kindly come on the stage and join for inauguration ceremony. Thank you. Meanwhile, I request everyone to kindly remain with us for the further sessions. Good morning.
Very good morning. Manuel.
All right, sir, all right. Sir, please. Good morning, sir. आप सबको provide करेंगे. मैं यहाँ से चला के देती हूँ. नहीं है, दो मिनट नहीं है.
क्यों?
पता नहीं.
कितने?
एक सेकंड. दो के लिए ऐसा.
और ठीक है.
शामी कैंडल्स ऑन.
You look good.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः. शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः. शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते. दीपज्योतिर्नमोऽस्तुते. दीपज्योतिर्परब्रह्म. दीपज्योतिर्जनार्दनः. दीपज्योतिर्परब्रह्म. दीपज्योतिर्जनार्दनः. दीपो हरतु मे पापम्. सन्ध्या पुरस्तादः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्
तपस कुमार साहब नहीं है अभी 4 सेशन और है टी ब्रेक हो गया क्या ये टी ब्रेक है ना हाँ इसको टी ब्रेक कंसिडर करेंगे ना अभी 5 मिनट का तो रहेगा ना ठीक है Thank you, everyone. Welcome back. Now we come to relatively newer and increasingly important concept in hemodynamic assessment, that is VEXAS. While we frequently focus on whether our patient required fluid, it is equally important for all of us to see the venous congestion and whether the fluid is harmful to our patient. To simplify this fascinating concept, I would like to invite Dr. Tapas Kumar Sahu, sir, Associate Director Critical Care Medicine, Medanta Hospital, Ranchi, to kindly come up on the stage and take the session. I'll request everyone to kindly settle down and maintain the silence. Sir, please.
Very good morning to all of you. I request everyone to please settle down. It's a very important topic, and it's again, I would say, more important and more difficult for me to talk after a very seasoned intensivist and ultrasonographist in critical care, Dr. Srikanth. So I am now taking the full responsibility of giving my justice to this topic, which is VEXAS. Now, we all know VEXAS protocol is increasingly being used in our ICU practice, and I want to make it very interactive. It should be with very, I would say, interactive reels also, how we have done at the bedside. And you will be surprised to know the first one who has used VEXAS, Dr. Phil Rolla. I have taken the clips from him, how he has used it at the bedside. So it would be more interesting to know it practically. Now, anybody tell me, what is VEXAS full form? Can anybody tell me? I would be asking many questions, and I will take maybe 5 to 10 minutes more, because this is one topic which covers most of the things what we are struggling with, that is not giving more fluid to the patients. And that is shown to increase the mortality in form of acute kidney injury, maybe in the form of lung congestion, heart failure, and other complications. Okay. So the full form of VEXAS is venous excess ultrasound, and this is a reading congestion at the bedside. We need to read the congestion at the bedside. Very simple, structured 4-window approach. And this talk I have been privileged to give at Emirates Critical Care Conference at Dubai along with Professor Manu Malbrin. So that's why I have taken the reel from Dr. Phil Rolla, who is one of the pioneer in starting this VEXAS protocol. now, before moving forward, why we look beyond our normal assessment? हम लोगों के पास इतने सारे tools है to read venous congestion or fluid overload at the bedside. Why we have actually devised anything extra? इतना काम है ICU में, already we are stressed, and और एक protocol add करना, already blue protocol, false protocol. So many protocols are like, no, apart from lung ultrasound or ultrasound, there are other protocols also in our critical care. We know about the lung ultrasound, Dr. Sikand has told. We can do TE also, transesophageal echocardiography or transthoracic echocardiography. Then chest X-ray, simple CVP assessment or something else also, like no clinical assessment that patient is fluid overloaded. But isko kyun karna tha? Because they have their own limitations. Now, if we see from one clinical examination, lower sensitivity, we do not know if the patient is not having S3 gallop, edema, raised JVP, तो patient को edema है या fluid overload है या नहीं है. That's a question which is not very significant, at least in critical care, in our ICU practice. और आजकल कोई CVP तो check करता ही नहीं है ICU में. If somebody is still depending on CVP to know that this patient is fluid overloaded, maybe we are working in before 2000. Okay. Natriuretic peptides, cardiologist will say BNP भेज दो, NT-pro BNP भेज दो, then we'll see that this patient is actually having pulmonary edema or not. Very insensitive. Clinical context always is important. Now the next one is chest radiograph. In ICU there are so many limitations of getting a good quality chest X-ray. I will not be preferring chest radiograph for at least excluding or including that this patient is having fluid overload. Agree? Fourth one is the fluid balance chart. Sometimes we depend upon the nursing chart. कितना cumulative balance है? कल intake इतना था, output इतना है, वो 1 liter ज़्यादा हो गया. That means this patient is accumulating fluid. This is again a crude method of getting. This may be one of the method, but this cannot give you with clarity that my patient is now fluid overloaded. CVP, already we know, we are sometimes like, people are very emotional about CVP number. That's why the number we grew up with in our MBBS days also. CVP hona hi chahiye. Then only we can say patient is having fluid overload or not. And IVC in isolation. In our FNB days when we were doing, we are very much I would say obsessed with doing IVC. IVC dilated hai, 2.5 centimeter hai. Patient is fluid overloaded. But nowadays, nobody do it in isolation, at least to document or treat that this patient is fluid overloaded or not. Clear? Now, we need something else. What is that? What is that something else? Maybe I would be little bit right now giving you an idea that there are 10 situations where if you are only depending upon IVC ultrasound, these are the pitfalls that will not be giving you any clarity that this patient is having fluid overload or not, or venous congestion or not. What are they? High PIP, non-invasive ventilation, assist control ventilation or low tidal volume, auto PIP, right ventricular dysfunction, tamponade, abdominal hypertension, mechanical obstruction, respiratory variation, right ventricular myocardial infarction. And in ICU, literally speaking, 1 or 2 things you will get in your ICU patient. So how come just depending upon IVC in isolation will guide you that my patient needs fluid or not? Or my patient needs fluid removal or not? That's also another question. Because it's not about knowing. You have to act also. You have to take out fluid through diuretics, through not giving fluid, or going for dialysis if the patient is still fluid overloaded. Now, the problem statement here, sometimes we can get this type of situation. Fluid दिए नहीं, वहां पे desert हो गया. Okay, so too little fluid, hyperperfusion, shock, ischemic AKI हम लोग normally देखते हैं ना, urea creatinine ratio is now 120, urea and creatinine is 1.5. So we say patient pre-renal AKI में चला गया. So we have to give fluid. Here, restricting fluid is not the solution. So don't always blame the fluid. Fluid also saves lives. Now, अगर हम लोग ज्यादा दे दिए क्या होगा? सैलाब आ गया पूरा. Okay, so that's also dangerous. Venous congestion in every organ, congestive AKI and over resuscitation kills quietly and late. तो अगर आप पहले नहीं दे रहे हो अंडर रिसस्टेशन, सर्वाइविंग सेप्सिस कैंपेन में बोला गया है कि आप आते ही फ्लूइड देना है, बिकॉज अंडर रिसस्टेशन kills early. But over resuscitation, over maybe 1 day, 2 day, 3 day, that would be doing the same thing, killing. But it would be late and quietly. You will not be able to know. Normally होता है ना 6 घंटे के अंदर फ्लूइड नहीं दिया पेशेंट मर गया तो it would be like no blamed easily, but over resuscitation will be doing it maybe gradually. Now the problem is we need to do it, but before that, what is the physiology behind? Why we need the venous congestion to be diagnosed at the bedside and treated? This is the fundamental thing. Congestion is a backward problem. Now when we think about any problem, we start from always the forward. If there is any ventilator problem, we start from the ventilator circuit from the ET tube only and we go in the downstream. But venous congestion, you start from the end, that the organ has been congested. If you take it as kidney, if you take it as heart or lungs, from there you are actually evaluating and coming to the problem. So that's why congestion is a backward problem. Fluid in right ventricle cannot keep, central venous pressure rises, pressure transmit and backward to the organs, renal, gut, intestinal edema happens, and finally perfusion gradient as maybe that will cause the acute kidney injury, congestive hepatitis, gut edema, bacterial translocation, all these problems. So that's why I would be just giving you a roadmap at the bedside. क्या करना क्या है हम लोगों को? First of all, the 4 important things. One is recognize. पहले तो problem है वो देखना है. Second, we have to get 4 windows. 4 windows already you know. वो क्या क्या है? एक है IVC. Second one is hepatic. Third one is the portal. Finally is the renal. These are the 4. I will give you all these videos also. You will be clear. Now we will be grading also. एक बार हो गया, पहले तो problem है उसमें देखना है. Second, कैसे देखना है. Third है उसको grading करेंगे कि कौन सा grade में है. Mild, moderate, severe. And finally, action. एक्शन तो होना पड़ेगा ना, खाली प्रॉब्लम जानने से तो नहीं होगा आईसीयू में. ओके, नाउ आई हैव ऑलरेडी टोल्ड यू, इफ वी आर हैविंग फ्लूइड इन ऑर्गन्स, डोंट ऑलवेज थिंक अबाउट किडनी. किडनी एक ही ऑर्गन नहीं है जो कि फ्लूइड ओवरलोड से प्रॉब्लम आता है. ऑल द ऑर्गन्स हैव सम और अदर थिंग्स कॉम्प्लिकेटेड बिकॉज ऑफ द फ्लूइड ओवरलोड, स्टार्टिंग फ्रॉम ब्रेन, heart, liver, biliary, kidney, skin connective tissue, intestine, and finally lung. So these are the organs that would be affected if you are unable to decide that yes, this patient is actually fluid overloaded, I have to restrict the fluid or remove the fluid. Right? Now, let's start with a clinical case. Everything should be a clinical case based so that you remember more rather than the theory. This is a gentle person 65-year-old, known case of congestive heart failure, AKI, admitted to your ICU. Now, gradually over one day, patient is having worsening dyspnea and anasarca despite escalating the diuretics. You have involved cardiologist, you have involved nephrologist, you have as an intensive care team also. You thought about the patient is a known case of CHF and now AKI, so I need to remove the fluid. But how much is your diuretic is working properly or not? Or is the patient is still having fluid overload or not? That is difficult to decide. Now, conventional assessments were inconclusive. I have told you this IVC, CBP, lactate, all these things are inconclusive. Now, what will you do at this time? This is a clinical case. Can anybody tell me what will you do? Already you have started diuretics. You will again request the cardiologist to give for again another 5 minutes time. Or you will be again depending upon some CT scan or something to know. Or echo again. Anything? Maybe at this point of time, you do something little bit mix up. डायरेटिक थोड़ा बढ़ा दो, हो सकता है फ्लूइड बंद कर दो, बीपी को थोड़ा सा हो सकता है कि बेटर कराओ, कार्डियोलॉजिस्ट को एक और रेफरेंस दे दो फॉर द डॉक्यूमेंटेशन पार्ट, नेफ्रोलॉजिस्ट को बोलो कि डायलिसिस करके फ्लूइड निकाल दो. सो यू विल मिक्स अप, बट नो कंक्लूसिव आंसर्स एट दिस पॉइंट ऑफ टाइम. वी डू नॉट हैव दैट टूल to know what is happening. Now the gap here is IVC doesn't lie. That may mislead you. क्योंकि IVC खाली isolation में देखोगे ना, it would be giving you nothing except IVC is more than 2 centimeter, less than 2 centimeter, 1.5 centimeter, something like that. But as a whole, venous congestion है या नहीं है, fluid overloaded है या नहीं है, maybe that will not be only in isolation, will not be able to give you clarity. Now there are multiple things, I'm not going into detail, already I have told you. Now, for this, we need to do something extra. Now, what are these things? I would be telling you 3 concepts. related to fluid. Remember this. Fluid responsiveness, fluid tolerance and venous congestion. It ends with a red light for you to like, now this is danger. Now, is there any difference between fluid responsiveness and fluid tolerance? What do you mean by fluid responsiveness? Already in the first class, Dr. Mudit has already explained very nicely. Fluid responsiveness is nothing. Only if you give fluid, it will improve your cardiac output or stroke volume. Nothing else. If you check my fluid responsiveness, it may be more than 75%. That doesn't mean that I will immediately stop my talk and take to 1 liter of fluid. Doesn't make sense. Okay. Anybody can have fluid responsiveness. That doesn't mean I will like immediately flood the patient or the person with fluid. Now, fluid tolerance is something else. Now, the terminology has changed from fluid responsiveness to fluid tolerance. What is this fluid tolerance? Can this patient absorb more fluid without harm? That is the question which is pertinent to me at the bedside. I'm not interested that this patient needs fluid. Coca-Cola dena hai, usko cold drink dena hai, coffee dena hai. I'm not worried. Okay. Now, if my patient after giving fluid is developing lung B lines, venous congestion, then the question should be, should I give it? Maybe I should stop now. Patient will be like, it will be more harm to give fluid rather than any benefit. Now, venous congestion is the last stage. Already we have discussed and we will discuss in detail. Now, the origin of this score came from 2021 article. And you can see here, this is the primary author. I would say you are not able to see. Bibin Skolin et al. Ultrasound Journal 2020. He published that article and the title was Quantifying Systemic Congestion with Point of Care Ultrasound, Development of a Venous Congestion Grading System with Ultrasound. That was the article. Please go through. Very interesting article. And that was actually designed to know that what is not. You should not be depending upon this Vexer score when the patient is having septic shock, because maybe it would be giving you confounding results. Cirrhosis patients, maybe it is not a validated thing till now, as a treatment protocol. That's why there are also some opponents of Vexer's protocol. Dr. Srikant will agree with me. People don't like also Vexer's protocol to be so much aggressive in your management. Okay. So, but yes, this is a very beautifully physiological driven protocol we need to know. Now, this is the 4 windows and this is the 4 veins that you need to do. This is one slide you should remember, and it starts from, you can see here, IVC, first one, IVC 1, hepatic vein 2, portal vein 3, renal vein 4, and that would be again how it is flowing. This is the 4 windows, and this is the why we need these 4 veins as a scoring system or grading system. Now I am just keeping, let's start with chapter. Dhurandhar movie, so I am also made it like that only. Chapter 1. Okay. There will not be Dhurandhar 2. Huh? This is only one movie. Okay. So chapter 1, let's start with acquisition. How we want to go ahead with IVC. I think there is a workstation also. So I'm not going into detail of that because it will kill time. How to get it in workstation, please find out. IVC, how to get it, and how you need to develop that idea. IVC less than 2 centimeter, grade 0, no need to do anything further. If it is IVC more than 2 centimeter, then the chapter will proceed, Dhurandhar movie will proceed. Okay, now, and you are all Dhurandhars. Okay, now, getting a measurable IVC, how you should start with the short axis, get the view, then again change it 90 degree, you will get the long axis, and in the long axis, you can feel whether it is collapsing, whether it is dilated, what will be the the diameter, all these things will be seen. Now I will have the reels also so that it will be clear. Okay. Now collapsibility will be the spontaneously breathing. Distensibility will be when the patient is mechanical ventilated. Don't confuse. Okay, if the patient is sedated paralyzed, so you have to check the distensibility. And why? The physiology also you need to remember. In spontaneous breathing, the venous return actually increases with every negative inspiration. So that's why it would be collapsing normally. Now, how it is correlated with CVP? IVC less than 1.5 centimeter, collapsibility more than 50%. You have a rough idea CVP of 0 to 5. Okay. Now, as you go ahead with the IVC size more than 2.5 centimeter, collapsibility less than 50%, you can roughly estimate your CVP to be around 15 to 20. So this is a rough estimate. Okay, don't completely depend upon this. There are many things you need to see before you believe that yes, this is the problem. Now he's Phil Rolla, who has actually taken this on a real patient. You can see here, just for IVC. Sound, can it come?
And here we are.
Yeah.
We can see that it's got a nice plethoric IVC. I'm going to pan up and down throughout as much of the hepatic segment as I can see. And we can see that it's fairly circular, has minimal variation. And there we go. So that is right there a grade 4 IVC. From right here, I'm going to pick hepatic vein.
Okay. How is the IVC here? What will be your interpretation? Just looking at the IVC? Anyone giving fluid? Okay. And what about this? Okay. And this is in the M mode, measuring it. Okay. Now let's come to chapter 2. It's जल्दी जल्दी खत्म होगा. 3.5 घंटे का मूवी तो नहीं है ना धुरंधर. Okay. So now hepatic vein. This is the second one. IVC हो गया. More than 2 centimeter, less than 2 centimeter. They have made it very clear. Now, how to get it? Hepatic vein. And why we have chosen hepatic vein? Because this is closest to the right atrium, apart from the IVC. Okay. Same subxiphoid or right intercostal window. Identify hepatic vein draining into the IVC in 2D. And then color Doppler over the junction. Normal flow is away from the probe. That's why the color will be blue. And place the pulse wave gate in the 1 to 2 centimeter before the IVC is entering into the liver. Okay. Now angle it correct. Otherwise क्या होगा ना वो gate जो है वो small large होगा, that would be confounding your result. So that is the reason why normally sample the hepatic vein, not the IVC itself, too close to the junction, and you record turbulent mixed flow that grades as artifactually actually abnormal. And that's the reason why you would need to do. And this is the how you should do it. You can start from here. This is the mid axillary line Gifford process, and you can see this is known as Playboy bunny sign. Maybe there are some people who will be very fond of Playboy, so you can remember it easily. Okay, Playboy bunny sign. Okay, so you can see here. Okay. IVC, right hepatic vein, middle hepatic vein, left hepatic vein, and it looks like this one. Okay. Look at this, how I am taking this picture, and this, you can see, this is the middle hepatic vein, and you can, sorry. Okay. Now you can get the tracing of the hepatic vein, the Doppler. You can keep the cursor like this, get the pulse wave, and this one will be the S and D wave. Now, if we will be analyzing, the normal is S is bigger than D, mildly abnormal, S would be like, no, the height would be less, D would be bigger, and severely abnormal, there would be reversal. Red, always red is for bad, and you can see both waves below the baseline, S would be the dominant, because like that's why normally it is lies in the systole and still below the baseline, but D wave becomes the prominent or dominant, and here there would be reversal. Clear? Now let's go ahead with the video. This is hepatic vein, S reversal, severe abnormality. Sorry.
See. From right here, I'm going to pick hepatic vein, put color on it, and we can see that this is kind of a, from right here, police siren sign, it's got lots of hepatic vein, and instead of a nice little color on it, blue, we've got lots of red, and we can see that this is kind of a police siren pulse on it. We've got lots of red. Remember, you have to get your venous settings on, red to scale a bit. We've got lots of red and blue all the time. Now you can see right there that we've got a pulse on it, a markedly abnormal. Remember, you have to get your venous settings on, above the base scale a bit. S wave.
There is reversal.
We can see right there that we've got grade 2 markedly abnormal hepatic venous trace scan with a above the baseline.
Now, mild, moderate, severe, S and D ratio, relation, how it would look like. Normal it is like this, S and D. S would be dominant. Now mild, how like no, it is increasing the right atrial pressure. You can get S is less than D, then S is very less than D, and here in the last you get the reversal. Okay. Now chapter 3, the portal vein, easiest window and the loudest sign. You can say how we'll get it. I'll show you. And how you want to get it, the pulsatility index by Vmax minus Vmin divided by Vmax. Normally it should be less than 30% variation. I can show you also. 30 to 49% mildly abnormal. More than 50% it would be severely abnormal. And the portal vein has the bright echogenic wall in the liver. So that would be easy to. That's why it is said at easiest window and loudest sign. So you can see here how to get it. 2D echo, you start from, I will show you the site where you want to do it. Yeah, here. You keep it, and then maybe in this picture you can see how you want to keep it. This here the subject coastal view, not subcoastal, it would be hypochondrium, and here you can see the view here. Now portal vein grading, how it will look like. There would be minimum pulsatility index less than 30% because everything will be, there would not be any changes. But as you go ahead with the congestion, you can see the pulsatility index is now 30 to 50%. And in severely abnormal, you can see definitive dips in the S and D. Okay, Vmax and Vmin. Now in the picture, you can see.
Go out laterally, and we can see that we get actually a better angle on the portal vein. There's a little less respiratory motion. Again, I'll put my pulse wave on it. Actually here, for fun, we'll put the color on it, and we'll see that even on color, there you go. It's clearly a pulsating portal vein. Here we've got a tracing that's actually got both arterial and venous.
Here arterial and venous, both you are getting.
Focus more on the venous.
Now you will be concentrating on the vein. Now you can see like this. This is the vein. This is the artery. This is the artery. This is the vein.
So we've got a nice superimposed images here. We've got the nice venous tracing in a brighter white, and we can see is essentially 100% pulsatile. So already we've got grade 2 in portal, grade 2 in hepatic, and a fixed IVC. So we're already of Vexus 3.
So by this time you get at least more than one abnormal wave along with IVC diameter more than 2 centimeter. So you have already diagnosed that this patient needs fluid removal or you have to stop fluid. Okay. Now how you should get it? Minimal. There is nothing, no variation. As you increase the RAP, fluid overload is increasing. You can see the pulsatility index is increasing, and gradually you can see more than 50%, you get distinct waves. Right? Sorry. Now chapter 4, last one, intrarenal vein, and chapter 4 is difficult because as you go in the movie, no, the last part would be a little bit interesting. So that's why this is also the hardest window, and most important organ, kidney. Kidney hona hi hai. Okay. So that's why now you can see also how you should look the interlobar vessels and arterial and venous. Here you can get both arterial and venous waveforms very distinctly. And where would be your probe? You can see here, backside. Okay. Posterior axillary line, color Doppler, you can get the interlobar vessels. That should be your target. And the scale would be low here, 10 to 25 centimeter per second. That's why it is difficult. You have to set your ultrasound as per getting a good view. And then you capture both arterial and venous flow together. Grade only the venous trace. Don't focus on the arterial trace, and ask for a breath hold if the patient can cooperate, because you can get a better waveform. And this would be the intrarenal vein, grading the venous trace. Normally continuous monophagic. This is venous, this is arterial. So below the baseline, this would be the continuous monophagic flow. As you go little bit mildly abnormal, you can get distinct wave. And at the end, you can see only diastolic wave. There will not be any systolic wave. Okay.
Intrarenal venous Doppler. So here I'm going a little laterally. I have a little rotation of the probe that is counterclockwise to my hand. I try to get a nice long axis kidney. And I put some color on it. Try to aim I'm aiming for an arcuate vessel or an interlobar. I've got a couple of ones that look decent here. I'm going to drop my depth here to maximize my ultrasound power. We'll see what we can get from these areas. This is the hardest part of the exam. So we can see here we've got, it's actually a nice tracing you don't often get to see. Pretty much an isolated venous trace. We've got a little bit of arterial trace in the background.
Little bit of arterial tracing is also there. Okay.
Interrupted, what we typically call monophasic, because we usually don't get to see the venous flow above the baseline, but in this case we do. So this is really analogous to your hepatic vein tracing with a positive deflection in what's the S wave equivalent, which we normally don't see, and then a D wave equivalent, which is the systolic, the diastolic portion, obviously, of the flow. So again, markers of severe congestion. So
now all the three things. This is the arterial trace, monophasic. As you increase the right arterial pressure, there would be increased pulsatility, distinct S and D wave, and finally D only below the baseline. Okay. Now 6 settings. Along with this, if you have the ECG on, that would be having a proper agreement between your wave. You are putting it properly, you are getting the correct wave or not, because there is a correlation. S runs from R wave to the end of T, D runs from the end of T to the next R. So that's why you should have your ultrasound machine should be having the ECG tracing along with the waveform analysis. Fix the scale. Again, depending upon which vein you are targeting, you have to reduce your sweep scale and small gate, good angle, sample on the same respiratory phase and record. Don't eyeball only, because otherwise you will be confused. What was the last time somebody has done? Okay. Now chapter 5 would be a little bit like making it all together, because you have now got all those views, 4 views. Now how to grade it. Now let's start with the simple thing. IVC less than 2 centimeter, no congestion, no movie further. Okay. Now more than 2 centimeter, abnormal wave. The first one is criteria is now filled up. So now you have to proceed. 0 mild congestion, 1 moderate congestion, 2 severe congestion. That means 1 abnormal wave if you are getting, or more than 1, then it would be moderate. No abnormal wave, only IVC more than 2 centimeter, grade 0. You have to monitor the patient regularly and also see that patient is not entering into the moderate congestion or the grade 1 or grade 2 level. Now if you are getting 1 wave, then it is moderate congestion. You have to definitely act at that time. If you are getting 2 abnormal waves, that means out of hepatic vein, portal vein and renal vein, if you are getting 1 severe abnormal wave in each one, 2. If you are getting hepatic vein already 1 abnormal wave, portal vein 1 abnormal wave, so you don't need to go for renal vein also. That means it's already the criteria is fulfilled. So you can safely say that this patient is having grade 2 venous congestion, or the VEXA score is now 2. Okay. So 0, 1, 2, 3. And that has shown that if you increase in the severity, the chance of acute kidney injury because of the back pressure in the kidney is rising, or the patient will need renal replacement therapy and the mortality will increase. Now all the things together, IVC step 1, step 2 is the hepatic, step 3 is the portal, step 4 is the renal, and how we want to interpret it, grade 0, grade 1, grade 2, grade 3. Clear? Now everything together in one slide. You can see IVC you have already seen. Now hepatic, portal and renal. All the things normal, mildly abnormal, severely abnormal. How you should get it. एक ही स्लाइड में आपको टोटल प्लैटर मिल रहा है. Okay. Now whole examination, 1 page. If again, for the last benchers, please, this slide maybe if you have missed all the movie, maybe the 5 minutes of the last is the climax scene for the movie. Is the patient venously congested? If I am thinking whether this patient is venous congested, go ahead with the IVC. Do the measurement less than 2 centimeter, grade 0. Don't need to put effort for further assessment. If it is more than equal to 2 centimeter, go to the stage 2 or step 2. Hepatic vein, color, you know the S versus D ratio, you have to see relationship, look for S reversal. Okay. Now, if that is also fulfilled, go to the portal vein. Again, in that also, the pulsatility index. There is not S and D. That is V max minus V min divided by V min. Now, you can get it, easiest window. Maybe if you are not getting hepatic, go to the portal. Now, last one is the intrarenal vein, posterior axillary line, you will get it. And you can get it like, no, whether it is monophagic or biphagic or the waveforms are distinct or not. Grade 0, grade 1, grade 2, grade 3. Now coming to the last part. हमारे केस में क्या हुआ था? We did the vexus and we got IVC 2.8 centimeter. तो stage 0 जो first step है वो fulfill हो गया. Hepatic vein we got S wave reversal. That means हो गया वहां पे. Portal vein 100% pulsatility with reversal. And renal vein हम लोग कर लिए, वहीं पे भी stop कर सकते थे. And we got discontinuous monophagic flow with only diastolic phase. So diagnosis is vexus grade 3. Okay. So impact, we continued with the diuretics, guided decongestion, involved the nephrologist, opted for renal replacement therapy also, and rapid clinical improvement, renal recovery, discharge within a week. Now there are certain pitfalls or limitations also you need to know. Vexus is not a रामबाण और मंत्रा जो कि आप सारे पेशेंट में कर लोगे और वेक्सस से पेशेंट ठीक हो जाएगा. It's not a volume meter. It will not guide me 1 liter निकालना है, 2 liter निकालना है, 500 ml निकालना है. Okay. It's not a contraindication to fluid. Only thing it can guide you. एक होता है ना लैम्प पोस्ट होता है that can show that maybe you have to be cautious now. Okay. It is not explained away by the comorbidity. I have told you there are certain confounding factors. Sepsis है, cirrhosis है, right atrial pressure enlargement है, right heart failure है. Maybe it will be little bit like you have to see with a pinch of salt. When vexus lies to you, that is also, the opponents will be always saying this, cirrhosis, portal hypertension, atrial fibrillation, tachycardia, because आपको ECG सही से नहीं आएगा ना, कहाँ पे S है, कहाँ पे D है. उसके ऊपर भी बहुत जगह पे है ना. You can get some waveform and you say that it is S, it is D. It is not right also. Okay. High PEEP, RV strain, extrinsic compression, young, thin, hyperdynamic circulation patients, severe TR, intra-abdominal hypertension, and the operator. Finally, the operator है ना. ठीक है. Machine cannot guide you everything, no. But yes, vexus can predict. This is one of the study. Only one RCT has been done using vexus. And this is the vexus guided decongestion in cardiorenal syndrome type 1, randomized single center, 140 patients they have done, and they found that vexus as a target made decongestion faster and more complete. That's why normally cardiorenal syndrome, it has a very good utility. Vexus, okay. So where it is and its place and where it doesn't, post cardiac surgical patients, cardiorenal syndrome, acute decompensated heart failure, known or suspected right ventricular failure, deciding whether to stop fluid or whether patient can tolerate more, monitoring the response to your decongestion over hours and days, and maybe as a trigger to go and look at the heart properly. So with this, I would be closing my things. Only 10 things to carry back to your unit when you enter your ICU tomorrow. Don't call your management to bring one ultrasound just to do vexus. That is not the message that I want to give. Or you don't expect for the chapter Durandar part 2. So IVC under 2 centimeter ends the examination. Okay, you don't need to put your effort. अब बोला गया है क्लास में फोकस में अटेंड किए थे, अब हम लोग सब में पेशेंट में जाके करेंगे और कंसल्टेंट विल कॉल मी. Grade 0, do not go hunting for Doppler abnormalities. Okay, this is not the message I want to give. In a ventilated patient, IVC is biggest in inspiration. Okay, distensibility and collapsibility, उसको आपको देखना है. Put the ECG on trace on the screen. It is free and it makes S and D unambiguous. So you will not be confused. Okay. Start with the portal vein when you are learning because it is easiest to get. That's why I am saying portal vein. IVC के बाद portal vein ही start कर दो. And it is the most forgiving window. A high grade doesn't forbid fluid. So vexus को blame मत करना कि ये high हो गया तो fluid. It is your clinical decision again. Center the IVC in short axis. पहले short axis से हमेशा करना चाहिए. Then you go to the long axis. Only severely abnormally patterns count towards grade. Mild ones never lift you past grade 1. So grade 1, grade 0, very thin line. Okay. Grade 2 हो गया ना, then you have to be definitely cautious. Then portal pulsatility, young thin patient, cirrhosis is not automatically congestion. And always echo the heart before you act upon a volume guided therapy. Thank you very much for your patient listening. And Vexus doesn't tell you how full the tank is. It tells you whether your organs are actually drowning. Maybe at that time you need some lifeboats, and that's the reason why we are at the bedside. And final bottom line, a fool with a tool is still a fool. Okay, so don't expect that you get an ultrasound machine and probe and you can cure your patients. It's finally you, not the machine, that can cure it. Thank you. Any questions? Okay. So you are all drowned in knowledge, not fluid. Yeah, please. Thank you. Yeah, you can get it here.
So, Tapas bhai, suppose in case of, as you already told, in case of severe TR or severe pulmonary arterial hypertension, vexes, particularly hepatic or portal vein will be totally false positive, you will get, right? So can renal vexes will be helpful in that case?
Agree, but again, we do not know how much would be the contribution from this, the tricuspid regurgitation, which is having the back pressure in the kidney. So there would be definitely some amount of renal congestion, venous congestion, because of the TR itself. So we do not know how much is actually isolated in the maybe hepatic and portal vein and how much is going to the kidney.
Suppose if we are getting hepatic and portal vein vexus is abnormally wrong, but renal vein vexus is normal. So can we think that it is probably hepatic and portal vein is due to the severe TR and renal one is probably the actual one?
I don't think, maybe Dr. Srikanth, this is a hypothetical or maybe a question which can create a confusion. He's saying that severe TR patient is there. We know that patient is having severe TR. Now you are getting the hepatic vein congestion and portal vein congestion because of the TR. So that would be something clear. Now, if you are getting the renal vein not congested, then can you say with confidence that this patient needs fluid and this hepatic vein congestion and portal vein congestion is due to TR, not due to fluid overload?
See, in both cases, if there is a TR, decongestion is the way forward. ठीक है, तो वो और फ्लूइड देके और फ्लड करने का मतलब नहीं बनता. प्रैक्टिकली हम तो डिकंजेस्ट ही करेंगे, क्योंकि देखिए बैक प्रेशर चेंजेस, राइट हार्ट इज नॉट गोइंग टू टेक दैट फ्लूइड एट ऑल, इट इज जस्ट पुशिंग इट बैक इनटू द ऑर्गन्स. आप एक्स्ट्रा पानी देके क्या अचीव करेंगे इसमें? तो यू रियली वॉन्ट अचीव एनीथिंग इन दिस स्टेज. So that question as a practical aspect has no value whatsoever.
We don't want to de-risk state.
We would still would.
So the question is important in one scenario because TR is there.
Yes.
By fear of TR, if you always want to keep the patient dry, patients maybe becomes more we are keeping prone for the AKI.
Yes.
So this is the right thing. We should think in a TR patient will give the fluid or not. That question is always coming in a mind.
See,
so that's the question.
Again, the thing is, see, ultimately this is used as a marker of congestion of encapsulated organs, which is the liver and kidney. लिवर में दो चीज़ें, पोर्टल और ये हो गया अपना हेपेटिक. किडनी दूसरा encapsulated organ है. TR है तो ऑलरेडी बैक प्रेशर चेंजेस तो एग्जिस्ट कर ही रहे हैं. You having a severe pulsatility in the hepatic and portal and having none in the kidney would be a bit of a rarity, let me put it that way. ठीक है, तो वो नहीं होगा यूजुअली. प्रॉब्लम ये आता है कि किडनी का पल्सटिलिटी और किडनी का एक्चुअली डॉपलर एग्जामिनेशन करना भी थोड़ा मुश्किल होता है. दैट इज वन ऑफ द मोस्ट टफेस्ट ऑफ द थ्री. रीजन बीइंग कि इट रिक्वायर्स अ पेशेंट टू बी lying still and reducing the breath rate, which normally an ICU patient does not do. So getting the perfect intra-lobar vessels and interrogating the interlobar vessels may always be a bit of a problem. So if you want to still push in fluids in those patients, the only thing you would do is you would push restricted aliquots and not go too much. क्योंकि देखिए अल्टीमेटली आपका फ्लूइड देने का पर्पस क्या है? पर्पस ये है कि राइट साइडेड प्रीलोड बढ़ा के लेफ्ट साइडेड प्रीलोड बढ़ाना. जब राइट साइड प्रीलोड ही टॉलरेट नहीं कर रहा तो लेफ्ट साइड तक कहाँ पहुंचेगा?
माय क्वेश्चन इज टोटली डिफरेंट. मेरा क्वेश्चन दो पर्सपेक्टिव लेते हैं. ओके, तो फर्स्ट पर्सपेक्टिव इज कि सीवियर टीआर और सीवियर पीएस इज देयर इन बोथ केसेस, राइट? In one patient, we are getting, false positive, hepatic and portal vein vexus, right? But renal vein is okay. In another case, hepatic portal vein abnormal and renal vein are also abnormal. So when to de-resuscitate? In first case or in second case? The second case obviously you have to de-resuscitate.
Yes.
In first case, we might get help, we might not get help.
Yes.
That's what I'm trying to say.
Yes. So if you are seeing signs of congestive hepatopathy, इसमें हम दूसरे इन्वेस्टिगेशंस पे भी आ जाते हैं. कंजेस्टिव हेपेटोपैथी के साइंस आ रहे हैं, आपके बिलिरुबिन बढ़ना शुरू हो गया, एंजाइम्स बढ़ना शुरू हो गया, तो आप डी-रेसिस्टेट करेंगे. Here the fluid is not going to be, I mean, see, you're talking totally about de-resuscitation. You're not talking about increasing the cardiac output or anything. You're only talking about de-resuscitation. Decongestion.
Yeah.
Option number B जो
Vexus is for only for decongestion.
Yes, option number B जिसमें सब चीज़ ही congested है, उसमें तो करना ही करना है, उसमें दो राय नहीं
That's for sure.
रही बात ऑप्शन नंबर ए का, जिसमें हेपेटिक और पोर्टल आपको कंजेस्टेड लग रहा है, रीनल नहीं मिल रहा है फॉर वट एवर रीजंस, you can wait for the decongestion and not do anything about it.
That's what I'm trying to say. Can it will help? Yeah. And another last question. Sorry, another last question. Which one? Suppose you have got the positive vexus, and you have started de-resuscitation. Okay, which one first to disappear and which one last to disappear?
First to disappear सबसे देखिए proximal से distal होता है. क्या है कि जितना कंजेशन उतनी पल्सटैलिटी. अगर डिस्टल तक पल्सटैलिटी चल रही है सबसे ज्यादा कंजेशन है, तो पल्सटैलिटी भी डिस्टल से प्रॉक्सिमल ही जाएगी. रीनल विल गो फर्स्ट. सबसे ज्यादा पल्सटैलिटी तो सबसे दूर ट्रांसमिट हो रही है ना जी, तो ट्रांसमिशन भी कम होता जाएगा. तो जैसे जैसे पास होता जाएगा तो ट्रांसमिशन कम होती जा रही है. तो द ऑर्गन विच इज फर्देस्ट फ्रॉम द हार्ट विल गेट द पल्सटैलिटी लॉस्ट फर्स्ट एज यू डी-रेसिस्टेट. आप समझ रहे हो? अगर आपको पल्सटैलिटी आइलियक्स तक नजर आ रही है तो बहुत ही ज्यादा कंजेस्टेड. नॉर्मल केसेस में बता रहा हूँ, नॉर्मल केस में भी बता रहा हूँ कि नॉर्मल केस में भी क्या होता है कि नॉर्मली आवर सिस्टम डैम्पन्स द पल्सेशन. ठीक है, आवर सिस्टम डैम्पन करता है. डैम्पनिंग विल गो अवे वंस इट इज फ्लडेड, द सिस्टम इज कंजेस्टेड. तो जाहिर सी बात है जितना आगे जाते जाते डैम्पन होता जा रहा है, अगर किडनी तक भी पल्सटैलिटी दिख रही है, सबसे ज़्यादा वहीं पे इन्वॉल्वमेंट है. जैसे जैसे आप डी-रेसिस्टेट करोगे, सबसे पहले सबसे दूर जो चीज़ है उसकी डैम्पनिंग कम होगी, उसकी पल्सटैलिटी कम होगी, मोनोफेजिक हो जाएगा. उसके बाद आएगा आपका पोर्टल, फिर आएगा आपका हेपेटिक. क्लोजेस्ट टू द हार्ट विल गो लास्ट.
दैट्स व्हाई आईवीसी और हेपेटिक वेन बहुत पास में है, तो दैट्स व्हाई वी नॉर्मली गेट कंफ्यूज्ड. तो आईवीसी का देख रहे हैं या फिर हेपेटिक वेन का देख रहे हैं? तो जस्ट
ओके,
ऑलराइट, थैंक यू.
Thank you so much, sir, for this clinically relevant session. Now, moving on to next session. As we all know, in trauma care, the time is physiology, and every minute before identifying a life-threatening problem can significantly influence the patient outcome. To take us through a structured, focus-based approach to trauma, it is my privilege to invite Dr. Kishore Jhunjhunwala, sir, President ISCCM Patna, Head of Department of Critical Care Medicine, Medanta Hospital, Patna. Sir, kindly come on the stage for your session. Thank you, sir.
So, very good afternoon. Now is afternoon. So today what we are going to present is just for the backbenchers. And this workshop, I think, for the new beginners. Please be here. So what we are talking about, the very basic things, how you are going to approach a trauma patient. My work has been done very easier by the previous such a speaker like Dr. Shrikant, Dr. Joshi, Dr. Rajesh, and Dr. Tapas. So we discussed a lot of things about how you're going to approach fluid, echocardiography, lung ultrasound, vexus. Now is the time when the patient really arrives in front of you to how you are going to apply all these things for the betterment of a patient. So question always arises, why POCUS? The POCUS has a purpose. We want more information. We are an information seeker for the better management of your patient. We know there is a clinical limitation. We know in a trauma patient when we perform the primary and secondary survey, still so many times we become clueless how you are going to manage your patient. In those scenarios, we need more information. We are not the radiologist. We are not the cardiologist. We are the information seeker. So many times when way back in 2010, I am here in 2009-10. We started doing this POCUS. Everyone is saying, oh, are you a radiologist? Are you a cardiologist? No. I am the information seeker, and as you all are the information seeker. We need information for the betterment of a patient. That's why we all are here. And the purpose of this kind of workshop to learn how to do and how to apply your clinical knowledge and implication. And Shrikant is not in front of us. I know in this country, he is the pioneer who started the WinFocus program, a structured training program for the POCUS way back in 2013. And that time, people are going to the Delhi at the Gurgaon Medanta to attend that WinFocus training program. And it's very expensive for us. Now this POCUS is everywhere. We are doing on a district basis. So that's the achievement because of all the professionals, and we know this is a stethoscope in everyone's hand. So just like is a very interactive session. I just want everyone, all the backbenchers, please come forward if the seat is vacant, because I am going to ask a question from you. There is no lecture for this presentation, just you need to participate. Please give a mic to the back audience, because they really are here to learn. Rajesh and all knows very well, and all the dignitaries knows how to do, and they are talking about the more advanced things. Please give the mic to the back. So suppose you are approaching a trauma patient, and the patient's in a casualty, and you are in an emergency, and your consultant is asking, oh, have you seen the patient? What is the pupil? And you have this kind of patient. If you have this kind of patients, when you are unable to see the pupil and your consultant is asking what is the pupil? So anyone, how you are going to assess this pupil? Is it possible with the ultrasound or not? Yes, please participate, dear. This workshop is for you all purpose, for all you delegate. Is it possible with the ultrasound? Because we know it's not possible with your torch. And it's very important to know this, what the status of a pupil, where pupil is dilated or constricted. Here we also want to know what the first thing about the pupil. Is it possible? Yes or no? ओए, अभी तो लंच के लिए टाइम बाकी है, आवाज भी नहीं आ रही है. हाँ? Yes, yes. Then how? Yes. So you can perform like this. Please, dear, participate, because this workshop is for you only, है ना? So how is using, which probe they are using? Linear, great. And this is the consensual light reflex, है ना? We are giving the throwing the light on the normal eye or another eye, and we are watching in another eye. So what precaution they have taken? आई के ऊपर क्या डाला हुआ है इसमें? कवरिंग डाली हुई है ना? You cannot contaminate, you cannot give the infection to your patients. So this you learn, है ना? सब बता देंगे कि लाइट रिफ्लेक्सेस देखने पर कैसे. पेशेंट प्रिपरेशन इज वेरी इंपॉर्टेंट. ओके, सो क्या किया इन्होंने? एक स्क्रीन डाल दी है. इसके बाद क्या लेंगे ये? दे विल टेक द जेली, एडिक्वेट जेली, एंड व्हेन यू आर परफॉर्मिंग you should be very gentle. Hold the probe gently and use this linear probe and see the eye window. क्या दिखेगा इसमें? Pupil दिखेगा. तो फिर बिकॉज बीच में रोक रहे हैं, श्रीकांत आए हैं, जरा इनके लिए ताली. एक बिग अप्लॉज, बिकॉज ही स्टार्टेड मोस्ट स्ट्रक्चर्ड ट्रेनिंग प्रोग्राम इन दिस कंट्री, द WinFocus. तेरी तारीफ कर रहे थे श्रीकांत, है ना? एनीवे, सो अब हमने देखा, हमने लाइट दे दिया. अब हम देखेंगे कि क्या हो रहा है. व्हाट वी आर ऑब्जर्विंग हियर? पीपल कंस्ट्रिक्ट कर रहा है या पीपल डायलेट कर रहा है, एंड विल अप्लाई द एम मोड. पीपल का एक्सेस लिया, एम मोड डाला, एंड एम मोड में क्या दिख जाएगा? लाइट जाएगी तो मियोसिस एंड माइड्रेसिस, एंड यू कैन मेजर इट. सो यू नो दैट whether the pupil is heavy dilated, mild dilated, or pupillary reaction present or not. So very simple. Apply this thing in your day-to-day practice also. You can apply. So maybe video is not coming. Anyway, in this video, what is there in the last picture? What we are seeing that the pupil is there. You have given the light, pupil constricted and dilated, and you apply the M mode. You see that the depth of the during the M mode, and you can quantify the pupillary reaction and size and all. So pupil देख लिया. When he is not able to see the pupil, pupillary reaction देख लिया. What next coming in your mind? When you are evaluating a trauma patients, maybe you are asking for CT head. Head trauma patient is there. Patient is little drowsy, and you want the CT head. But there is a delay in a CT head. Lot of technical issues. TPT नहीं है. CT होने में time लग रहा है. And you just want कि भाई अब TPT देंगे, CT head देखेंगे. Then only try to give the mannitol or hypertonic saline, or you want to give before. The purpose of POCUS is to get the information prior to your CT scan, prior to any kind of other monitoring. This is the information which we want to gather so that you can be faster your reaction. You can precise the treatment and faster as well as. So we are living in an era of precision medicine. अब आपको fast भी होना है और accurate भी होना है. And टाइम सेव तो ऑब्वियसली फास्ट है, टाइम सेव है, प्रिसीजन है, एक्यूरेट होना है. सो आपने बेड साइड देखा, अब पेशेंट को आप सीटी स्कैन के लिए भेजने वाले हैं, देयर इट विल टेक टाइम. आप क्या करेंगे? सो यू हैव टू अप्लाई. सो किसी तरह से देख सकते हैं उसका इंट्राक्रैनियल प्रेशर. एनीवे, बैक बेंचर, यस, या ONSD, एनीवन फ्रॉम द बैक साइड, क्या हम उसका प्रेशर देख सकते हैं इनसाइड इंट्राक्रैनियल प्रेशर? इज एनी वे अल्ट्रासाउंड कैन बी हेल्पफुल? यस और नो? एटलीस्ट वर्कशॉप है तो यस तो बोल दे. आवाज नहीं आ रही है जोर से. यस, तो वी कैन मेजर, क्वांटिफाई whether the intracranial pressure is high or normal. So we can decide whether we should give the your any mannitol, hypertonic saline and all. So क्या देखेंगे? ONSD. तो ONSD क्या हुआ? Optic nerve sheath diameter. So why we want to measure the optic nerve sheath? What the anatomy is there? Because we know that the optic nerve sheath is a dural extension of the subarachnoid space. And when the ICP rises, CSF is transmitted forward and causing the sheath to dilate, and we can measure it, dilate and measurably. This can be detected non-invasively by bedside ultrasound. And threshold क्या है? If it is more than 5 mm, I'll say you how you are measuring, and 3 mm behind the globe, so we can say that the ICP is more than 20. And you know how to calculate the cerebral perfusion pressure, MAP minus ICP. And here if you find it is more, this is the time before CT scan, you can give those drug you can try to reduce the pressure. Otherwise what will happen? Meanwhile you shifted the patient to the CT scan report will come, and meanwhile what will happen? Patient will started throwing seizure, or the GCS will started deteriorating, further deteriorated. So this is the picture. In this picture, the very simple, if you put the your probe, linear probe gently, you will get this cornea, iris, vitreous chamber, optic disc, and behind this optic disc what we are saying that the optic nerve. So 3 mm down to this disc, you will measure this diameter, that is your, that you measure the ONSD. So how you are measuring the ONSD? You have to take the two picture. One picture, see like you put the probe horizontally, and another you are putting the transverse. So what happened during this this longitudinal? During two picture, you measure the ONSD and make it average. This will give you the real ONSD diameter. So what I say that this is the real picture. What you will get? See this A, the optic disc 3 mm down to this, measure this diameter B to B. So now this happen, you make it the pressure is high, if that diameter is high, more than 0.5, you started giving the your treatment prior to your CT scan, and CT scan will confirm what the exact picture is there. And the one scenario will come. This young man is following the one trauma victim, saying that how the intensivist or ER guys is going to intubate this patient, how they are going to manage this kind of patient when the entire facial injury is there, you are unable to, maybe situation will arise, can't intubate, can't ventilator. So ultrasound can have a role here. So how? कैसे help करेगा? Please. Yes, great. One person is showing. हम क्या देख सकते हैं? Front of neck assessment. Or this patient, suppose that will a condition where can't ventilate, can't intubate kind of condition is there. So you need to assess the front of neck, and ultrasound probe is helpful here. And again helpful is when you inserted the tube, endotracheal tube, you don't have a ETCO2 or you don't have a bronchoscope. So ultrasound can be helpful here. Yes, you can see the tube within the tube, or you can set the tube is in the esophagus or not. So you learn this basic thing. So just put your probe and you will get this kind of picture. You know why it's so important, why we are saying the ultrasound is operator dependent, because how we are putting the probe, what kind of anatomy we want to see is very important. If you know the anatomy, then only you are going to match with your ultrasound images. So what here you are looking for all? This is your cricothyroid membrane, because if you want to emergency airway secure, you want to see the cricothyroid membrane. Clinically, by palpating, you can make the cricothyroid membrane, but USG is the more confirmatory. So many times you are unable to feel the cricothyroid membrane by palpation only. And with this USG probe, you can confirm that this is the cricothyroid membrane where you want to perform the cricothyroidectomy. So it's very important to understand the anatomy and use this USG probe. See here, you see the cricothyroid membrane, and you know the place where you just want to put your needle. And the same way, this is again anatomical. When you keep the probe like this, you will get the picture like thyroid, cricothyroid membrane, cricoid cartilage, and your tracheal ring downward. So this is again a pictorial presentation of your cricothyroid membrane. So again I say that the use of USG here is, what is the bullet sign? When you are seeing the tube within the tube, one is trachea is there, and if endotracheal tube is in a right place, you just put your probe and you confirm that whether your tube is in the trachea or not. If it is not in a trachea, you will get the double track sign. Here is in esophagus, and you will get this line. You can say that the double track sign is there. Now this situation will arrive. So now what you learned? One, you learned how to recognize see the pupillary reaction. Second, you learn how to measure your CPP, cerebral perfusion pressure, or ICP. You learn how to protect the airway. These all happen in your emergency and trauma. Now, suppose that patient is in your in ER, presented with shortness of breath, SpO2 less than 60%. And what comes in your mind? What comes in your mind? What can happen with your patient? Pneumothorax? Yes. Pneumothorax, hemothorax, fracture of ribs. These all can easily detect with your ultrasound probe. Already Dr. Srikant mentioned about how you are going to see the pneumothorax. And also he say how you are going to see the hemothorax. So if there is blood in a cavity, pneumothorax, hemothorax, even you put the linear probe on the ribs, you will get the fractures also. This you can get the images prior to your X-ray, because for the X-ray you need to call the technician. Maybe you have that console where you will see the X-ray, or maybe you will wait till you will get the picture of an X-ray. So before that, you will have your ultrasound that will give you a lot of information, and you can change your within a minute you can manage your patient. Otherwise you are going to lose your patient. So pneumothorax, I am not going. How you are going to see the pneumothorax? Already Dr. Srikant discussed. Hemothorax, you may see the picture of lung contusion like you have see the, and one more important, if your patient is aspirated, if the patient is came from the some periphery where a lot of fluid has been given, that could be the reason of shortness of breath and hypoxemia. You can assess with the B line and already explained. Maybe some aspiration is there, maybe some atelectasis is there. So already you know in the previous lecture how you are going to assess all this. So now patient is in a ER after post road traffic accident in a shock. You see the patient is in hypotension, cold, kami. You did all the clinical examination and you established patient is in a shock. So lactate is high, periphery is cold, but why? You don't know. And how you are going to manage all, because there are a lot of protocol, I will come to that, but you just want to manage this patient. You want to know whether this is the cardiac origin, whether this is due to hypovolemia, where this is due to obstructive shock is there, whether this is the hypovolemic, where is the distributive, all kind of shock. To manage this kind of shock, you need the one thing, this is your ultrasound probe. Because stethoscope only give you the picture, patient is in a collapse, clinical picture is giving the patient in a shock, but how you are going to phenotype this shock? How you are going to make it the phenotype? You want to go to the phenotype, you need this probe. You need this probe to establish the phenotype, and according to phenotype, you are going to manage these things. So Tapas is also telling of access of fluid and all the blues protocol. Dr. Srikant talk about the blue protocols, false protocol, Vaxxus protocol. Now this is one more rush protocol and high map protocol. These all you learn and try to utilize in your patient. And one about the eFast. So what is the rush protocol? Very simple. There are three things. One is that is rapid ultrasound in a shock patient. You are talking about the pump, you are talking about the tank, and we are talking about the pipes. So pump is what? Heart. So pump is contracting, not contracting. When you are talking about the contracting and non-contractility, you have to see the LV. And if you do the RV strain, if you perform the TAPSE, you know the RV strain. So how you know the RV and LV contraction on TAPSE, Dr. Rajesh must have taken your class. And one about the tamponade. Tamponade is obstructive shock. You get the pericardial effusion. So pericardial, you will get the picture of pericardial effusion. But the pericardial effusion is not tamponade until unless associated with the history of trauma, and another more is the shock condition. If the shock condition, if you are getting the fluid around the heart, you say that this is the tamponade. And you see the LV contractility and RV strain. Now you think about the tank. What the happening of tank? That is your thorax and or abdomen. In the tanks, what you are going to see? The IVC, already discussed. And you have to do the FAST. I will come to the FAST. FAST is the focus assessment of sonography for in a trauma patient. You look for the B lines, you look for the pleural effusion, and also you look for the pneumothorax. So you put the linear probe, you see that the seesaw sign, and all this kind of your there is a pleural lung point, all has been taken care about what the pleural lines, what the your lung point is there, and how you are going to make a diagnosis of a pneumothorax. So every intensivist or every your sitting in this house, everyone should know how to this probe and see this kind of basic rush protocol bedside. And again about the pipes. Pipe, maybe trauma patient is there, maybe the injury to the abdominal aorta is there. You just put the probe and just roll the your probe downward. You see that how the aorta is there. Is there any intimal injury, or is there any intimal injury of the aorta is there or not? You can make a diagnosis of any abdominal aortic injuries. And if you put your probe down, if you put on the your vein in the leg, you will get the picture of a DVT. So you can use this protocol like the pump, tank and pipe to know that the patient is in a shock or not. In the same way, other is rapid ultrasound sec. In the same way, somebody is saying the high map protocol. Whatever, you have to see the heart, tank and pipes. Like in the heart, You can use all the views like parasternal, subxiphoid or apical 4-chamber about the cardiac ventricularity and all. You can here also see about the sometime patients is coming there, maybe some pulmonary embolism is there. You can see the RARV, McConnell sign and all that has been taken care by the Rajesh. You can see the IVC. Now I am coming to the fast, then I can talk about the Morrison pouch. That is the hepatorenal space. When you are seeing the hepatorenal space in the right upper quadrant, just put your probe, you will get the picture between the hepatorenal space. If fluid is there, you can set the Morrison pouch. Morrison pouch fluid with the shock. This is to find out that if there is negative, we cannot say that there is no hemorrhage, no internal injuries there. But if it is so positive and the patient is in a shock, you can take this patient to the OT directly before the CT scan if the hemodynamically unstable is there. If it is positive, means there is something. But if it is negative, you cannot confidently say that there is no internal organ injuries there. So similarly, you have to see the aorta like aortic slide views and the pulmonary like the lung views. In the lung views, B line, barcode sign and all sign to know the pneumothorax. Now about the E-fast. E-fast is extended fast. The same thing what I am repeating in last 3-4 slide, rust, blue, false, everything is for the information. Same in a E-fast. E-fast we are doing at the 5 location. One is at the right upper quadrant, first position. Second, we are saying in the left upper quadrant. Third, we are seeing the pelvis. Fourth, we are seeing the subxiphoid to look for the heart. And the fifth, what we are seeing, the lung window. These 5 window, whenever you are examining, don't fix to the single window. Look for all the window and try to document your observation in your doctor progress sheet or in your case sheet. So how you are seeing this, all these things will come to the next. So again is very important in this picture, the position. Whenever we are saying that the USG is the operator based, is the so better how you are going to examine your patient. So many times seeing the people are doing the ultrasonography or POCUS, side rails are up. So if you are an uncomfortable position, if your probe is in the not right direction, you will get the wrong image. And if you get the wrong image, you will have the wrong interpretation. So it's very important to capture the right image. If you want to capture the right image, it's very important the right position. Your position, screen position and the patient position. So this is very, very important and fundamental for this kind of workshop to know how you are examining your patient. So properly if you are going for the fast examination, keep the patient like this. Your eyes should be directly on a screen and hand should be free and there should not be any side rail. So you are struggling to get the image. So these are all the quadrant, right upper, left upper, cardiac view, lung view and the pelvis view. So this is very important if you are, how you are holding your probe. Selection of a probe that you have taken care in your first or second lecture, how you are going to select the probe, linear versus phase arrayed versus your curvilinear. And this is important how you are holding the probe and how you are facing this, this point towards the axilla, towards the head side cranially and holding the probe like in a very, in this way, you are just holding like a pen kind of holding this probe. So what you will give? If you, the anatomy is like, anatomy is what? If your hair is putting like this, what happen? यहाँ पे what are the structure? Lung है, right side है तो liver है तो बीच में lung है, liver है तो बीच में diaphragm है, and पीछे में क्या है? Kidney है. This all is structure because this anatomy is there. And once this ray is going like this, you will get the picture like lung, diaphragm, liver and kidney. So if you have a right position and this ultrasound beam is like going this in this way, in a perpendicular way, you will get the image like this. So it's very important the position of your probe, position of your patient to get the good images. So by end of this workshop, go and just try to make the images. It's very important during hands-on. ask your who's demonstrating, show me the picture, how you are going to make all the picture. So similarly, if you know the anatomy, if you right position your probe, you will get the image like this, like your diaphragm, here the lung, how the artifact already explained to you. This is the liver, hepatization mode. This is the kidney. And in between the liver and kidney, what we are saying is about the hepatorenal space. This hepatorenal space or anything in the hepatorenal space is also called the Morrison pouch. And if there is any fluid, any accumulation there, we say that the EFAST positive. So when you are looking towards the left upper quadrant, similarly, see the knuckle. Where is the hand knuckle is there? On a bed. So you will get the proper image. So see the position of the hand. Why I am saying that is very important, ki how you are positioning your hand, how you are holding your probe. So this is the way, see the knuckle is here and see the images and direction of this pointers towards the cranially. So if you put the probe to left side hai, what you will get? Up hoga kya hoga? Again lung hoga, liver, left side hai to spleen hai, diaphragm hai. That's all you are going to see. So in the same way, if the ultrasound beam is will move, you will get the lung, you will get the diaphragm, you will get the spleen, and you will get the kidney. If you see in the real ultrasound image, how it looks like, diaphragm and the artifact, spleen, and this is the image of the kidney. And this space is called splenorenal space. If any collection is there, we'll say that the EFAST again positive. There must be some trauma is there. You can quantify the splenic injury and all. Let the radiologist to take a part. Don't go to the deep. Or if you have with your increasing your skill and knowledge, you can also quantify where is the splenorenal ligament, how much fluid is there, and how you are going to make. But it's your duty to find out only here EFAST positive or EFAST negative. And again, third view. Third view is about, see the pen holding position of your probe, and this is your curvilinear probe. See the direction of the probe. Here is the what? Pubic bone. You have to put for the pelvic vein near the pubic bone. Pubic bone ke just niche bladder hai. Where is the bladder? Just below the pubic bone. So this is the position you will keep, and in this position what we will get? Ultrasound beam is going like that. This is your pubic bone. You will see the picture of bladder, and from the bladder there must be the rectum. And here is the only deviation between the male and female. Once you will get the prostate, another you will going to see your uterus. So in a male, in a male, what happened in the real ultrasound beam? The bladder, the prostate, and this is the retrovesicular space. If any collection is here, you can say that the EFAST positive. If you see in the female, the bladder, here the uterus and the rectum and the collection around, this say that the EFAST positive. And after seeing this view, you just rotate your probe and keep this toward the right of the patient, toward the right side, and you will see the image like this, the bladder, uterus and the rectum. And in a male, you will see the bladder, prostate and the rectum. And you can have if any collection there, you can say that the EFAST positive is there. Similarly, now first, second, third image is there. Fourth image is the subxiphoid. In the subxiphoid, if you put the probe, if you are putting the probe, you are again the pen holding kind of probe in your xiphisternum space, and the heart is like this. So heart is like this, heart is like this, and if your direction of a probe towards your left shoulder, you will get the heart. So heart is like this, and the ultrasound beam is going like this. So if heart is staying like this on the left, ultrasound beam is going like that, you will get the image. You will get this kind of image, and keep the pointer towards the right shoulder. Okay, the pointer should be on the right shoulder and direction towards the left. You will get the image of your heart, subxiphoid image. And in a ultrasound image in a black and white, I'll see that your RARV, LALV, and this is the pericardium, and here you can see all the contractility, size, any kind of pericardial effusion. This window will give you whether any pericardial effusion. If with the shock, you can say that the tamponade. You can see the contractility. You can see the size of RA and LV compared to the LV. So many information you will get here, and by rotating from here, you will get also the picture of IVC, and you can see that the diameter of your IVC already explained in the previous lecture. Next is about the lung ultrasound, the fifth one, already explained, where you are going to put the probe. Just see the hands of how they are holding the hands on a chest of a patient to get the proper image. This is all about this eFast and how you are going to get the images. Thank you. So very important in this kind of workshop, just try to make the images. When you are going to the bedside, just try to make the images. Just play with the probe and keep it in mind you are getting the right picture, right images. Confirm from your senior, this is the right picture or not. If it is a right image, take a photograph. If your seniors are not there, then only you try to interpret. First make the images, then try to interpret all these things. And thank you. Apply your knowledge at the bedside. And thank you to Dr. Kundan and the hospital or Jeevandan Healthcare Hospital for such a wonderful platform. And I'm thankful to all the great speakers from across the country here to make this for this event. And thank you for your participation. Thanks again to Dr. Kundan for your great effort and the entire team of Jeevandan.
Thank you, sir, for the excellent presentation. Now we are moving on to something very important that plays very important role in respiration and remain assessed at the bedside. To help us understand its technique and clinical application, it is my privilege to invite Dr. Jyotirmaya Prakashpati, sir, Assistant Professor, Trauma Emergency, AIIMS, Devgar, to kindly come on the stage and take his session on diaphragmatic ultrasound.
Good afternoon, everyone. I will try to complete it within my stipulated time because we are already running late. So I will try to cover the practical aspects of diaphragmatic ultrasound. So through our anatomy days, n number of times we have come through this structure or this diagram. Basically, the diaphragm contains a central tendon. There are 3 hiatus and the muscular part with 2 ends, one sternal end and the vertebral attachment. And we know that this rough picture shows, the animation shows that during inspiration, the diaphragm flattens because of the muscular part and it gets elevated or shortens during expiration. So basically, the principle of diaphragmatic ultrasound is that diaphragm has got a large reserve capacity versus when that reserve capacity fails or the loading capacity fails, there occurs the diaphragmatic dysfunction where the role of ultrasound comes for us. So basically these 4 important things for us. There can be over assistance of diaphragm due to low effort or due to disease atrophy. Mostly many of our patients in ICU on prolonged mechanical ventilator on different drugs like aminoglycosides, polymyxins, neuromuscular blockers causing the neuromuscular weakness. So causing a disease atrophy. Or in patients with ARDS from the morning, we are looking at many lung ultrasound where the how to apply the excessive PEEP, that causing a longitudinal atrophy to the diaphragm. Or there may be a under assistance or high effort, which we tell it self-inflicted lung injury, ventilator-induced lung injury, where there comes the concentric contraction. And the last but not the least, the patient ventilator asynchrony, which causes the eccentric contraction. So how is it important? I will come through the next slides. So the role of diaphragm is that we already know it's real time, it's repetitive, it can help us in winning success, and we can diagnose diaphragmatic palsy. So the two approaches, we have come through many approaches. So the two main approaches which is important for diaphragm, one is the subcostal approach to start with. It's used to visualize the diaphragm dome. So the patient position, basically semi-fowler position or a head up around 30-degree position, or we can do it in supine position, but the best position is a semi-fowler's position. And the ventilator support we need, ideally we can measure the P 0.1, or there can be no support, like a patient only on TPs with some oxygen support, or patient is put on a spontaneous breathing trial with a pressure support of around 8/5 to mitigate the resistance of the endotracheal or the tracheostomy tube. And the probe location. So coming to the probe location, basically to look at the dome of the diaphragm, we use a curvilinear probe which is around 2 to 5 megahertz. At the mid clavicular line, angle directed medially, cranially and dorsally to look the dome of the diaphragm. So how it looks, and the lever provides us a good window, as mentioned in the previous lecture, how it provides a good window to look at the diaphragm. So to optimize my view, we have to adjust the depth, adjust the gain, adjust the focus and place M line perpendicular to the diaphragm. Last line, we need to remember that we should have minimum 3 respiratory cycles in a single frame to calculate the diaphragmatic displacement of the diaphragmatic exertion. So this is the probe location, convex transducer or the curvilinear probe we use at the mid clavicular line. So this is the first picture which comes in the B mode. So you can see the hyperlucent line. This is the diaphragm, this is the lever, and below part is the lung. So we need to put a M mode cursor. So once we put a M mode cursor perpendicular to the diaphragm, where occurs the maximum movement, at that point I need to put the M mode. So this picture comes. If my patient is fully conscious, I can ask him to take a deep breath. I can see, or we can appreciate that the diaphragmatic excursion increases with quiet breathing versus the deep breathing. Or if the patient can do a voluntary sniffing, we can also appreciate the diaphragmatic movement. Next, if the diaphragm is abnormal, means there is a diaphragmatic palsy, we can see absolutely there is no movement. You can see hardly any movement, or there can be a paradoxical movement, means instead of going into positive axis, it may go in the negative axis if there is a absolute diaphragmatic palsy. So how am I going to measure this? This is my real-time measurement. How I used to do, if this is my diaphragmatic exertion, you need to put a line from this part to this part, from A to A, then you measure the height from the midpoint of that line, transverse line, then put a perpendicular, then measure. If you want to take the upper part, then take the upper part. If you want to take the lower part, then take the lower part. So it depends on how you are measuring. So you can see it will show you in the measurement how is the diaphragmatic exertion, which is showing around 2.08 centimeter. The normal values, it varies in many literature according to position. Patient position needs patient support, whether patient is on TPs, patient is on pressure support ventilation, or patient is on control mode ventilation, or the patient is breathing spontaneously, patient is on a fully neuromuscular blockers. So basically in male it is around 2 plus minus 0.5 centimeter on the right side, and on the left side it is 2.2 plus minus 0.6. In female 1.9 plus minus 0.5. And in left side it is 1.9, same, almost same. So roughly this is the mean plus minus standard deviation. What is important for us to detect a diaphragmatic dysfunction, the cutoff, it is mentioned in literature 1 plus minus 0.5 centimeter. But roughly you can remember the number 1. If it is 10 millimeter or 1 centimeter or less than that, then we can say that there is a chance of winning failure. Next, coming to the intercostal approach. So this is diaphragmatic excursion. So in the intercostal approach, we are going to measure the diaphragm thickness as well as the thickening fraction. So this is basically how you do. This is the same semifibulous position. There is something called zone of apposition where the pleural and the peritoneal line merges in when we do the ultrasound. So basically the probe is placed between the 8th to 11th intercostal space at the anterior or mid axillary line. And a transducer basically used here is a linear probe, 7 to 12 megahertz. We can see with a curvilinear probe, but the appreciation of the movement or the M mode pictures are better with a linear probe. So you can see, once you put the probe there, you can see the two hyperlucent lines. This is the pleural line and this is the peritoneal line. So beach is the diaphragm. This part is the diaphragm, and this part which you are seeing another some hazy hyperlucent line, this is basically the muscular part or the neurovascular bundle inside the diaphragm. So this is the end inspiratory thickness. You can measure it in a real B mode, or we can put a M mode. You can put a M mode. Now you can see how is the end inspiratory thickness, how is the end expiratory thickness. So we have to measure both inspiratory and expiratory thickness. You have to minus inspiration minus expiration divided by expiration into 100 gives us the diaphragmatic thickening fraction. So this I have already mentioned, that thickening at the inspiration divided by thickening minus inspiration minus expiration into 100 divided by expiration. So the measurements according to literature, it is roughly, it can go from 20 to 100%. Some patients who is very deeply breathing, they can have a 100% thickening fraction, but roughly the digit which we need to remember, the three numbers are two numbers basically. One is 20%, which detects both diaphragmatic dysfunctions and prediction of NIV failure, and 25 to 30% predicts winning failure. Roughly you can remember 20 and 30. If it is less than 30, there is a chance of winning failure. If it is less than 20%, risk of NIV failure as well as diaphragmatic dysfunction we can detect. So this is a real-time image. This was for my research purpose. Basically you can see this is the diaphragm. Two arrow lines showing this is the peritoneal line, this is the pleural line. I put a M mode, and this is the two measurements, inspiratory and expiratory, 0.37 and 0.28. So roughly it is becoming 0.09 divided by 0.28. So this is the diaphragmatic thickening fraction for this patient. So this is the just the zoom in image. You can see this is the inspiration and you can measure the expiration here. So it is same 0.23 and 0.37. Next, how is it going to help us? Basically, it helps us in titrating ventilatory support. So you can see here a patient put on pressure support ventilation of 15. You look at the thickening fraction. Here it is 0.31 and 0.33. What is the fraction? 6%, means it is extremely low. Next you see another image where I have put the patient on pressure support ventilation of 8. So what is the thickening fraction here? 19%. Next, another scenario where the patient is put on PSV 5, where the thickening fraction is 61%. So by this, I can optimize the pressure support while weaning the patient. If it is very low, means what does it indicate? There is over assistance of the ventilation. If I am putting a very low, means it is not optimal. So how can I optimize it? You can keep it around 20 to 30% or around 30%. So it gives us what is the requirement of pressure support while weaning the patient. Next, can it detect patient ventilator asymptomy? Yes, it can detect, but if it is associated with a airway pressure measurement. So some examples I will show. Here you see, this is the airway pressure and this is the diaphragmatic excursion. You see the excursion is less. There is no effort, means there is a wasted effort or without any ventilator triggering. This we can appreciate. Then double triggering. You can also see double triggering. You see there are two pressures when you measure the airway pressures, but you look at the diaphragmatic excursion, it is single, means at the tip of excursion, means when the diaphragm is maximum excurting, still the patient wants another breath or he is taking another breath. So it is basically double triggering. You can also detect. Next, reverse triggering. You can see Here in the airway pressure, there are same 2 airway pressures, but look at the diaphragmatic excursion. When it should be at the maximum effort, the patient tries to breathe another effort. Means he wants the diaphragm to excurse further. So it sends that there is a reverse triggering. So you need to adjust your ventilator setting. Next, trigger delay. It can also be, you can also appreciate that you see where the diaphragmatic excursion starts. Here it starts, but where the ventilator is triggering after some time. So there is a trigger delay. So you have to adjust your setting. So you can see ideally the trigger should start from here at the start of diaphragmatic excursion. Obviously, all these measurements needs very precise appreciation and measurement of both the thing in a real-time scenario, or else it won't be possible. Next, we can also detect auto-triggering. Now we see there are 3 airway pressures, means patient is triggering here, here, here. But look at the diaphragmatic thickenings. Here there is a excursion, there is a thickening of the diaphragm during the inspiration, but you look at here. The diaphragm is, then there is no movement. So it indicates that there is a auto-triggering. So you need to adjust your setting. Next, can we detect diaphragmatic palsy? Yes, we can detect. It needs very precise detection, but we can roughly think that the end expiratory thickness should be 0.11 to 0.12, means I have told earlier, you need to remember the digit 0.1, 10 millimeter. So if it is less than that, there is atrophy, or the thickening fraction less than 20%, or even less than that, then we can know that there is a diaphragmatic palsy. Next, in COPD. How is it important in COPD? Reduced diaphragmatic mobility, which was inversely correlated with air trapping, dyspnea, and positively correlated with 6-minute walking distance. The important number for us is that same. Diaphragmatic thickening fraction less than 20%. It shows that there is an NIV failure, longer ICU stay, and need a prolonged mechanical ventilation. ILD, it can also detect interstitial lung disease. It can help us. It can also help us in cystic fibrosis. In neuromuscular disorder, there is one important thing which has come up. We can calculate the end inspiratory diaphragmatic thickness at tidal breathing versus breathing at the total lung capacity. If we calculate the ratio, if it is more than 0.75, it is indicative of weakness and may predict NIV initiation in amyotrophic lateral sclerosis. Then the newer concept has come up. Everyone must be aware of RSBI. What is RSBI? Anyone? Rapid shallow. What is the name of this index? Is Tobin's index. It is developed by Martin Tobin. So how is it calculated? RSBI? Respiratory rate divided by in liters. Cutup क्या है? 105 cutup है. मतलब if it is less than 105, there is chance of failure. So diaphragmatic RSBI they have come up with respiratory rate divided by diaphragmatic excursion, what we calculate through the subcostal approach. There are many literatures recently published. Even there are number of articles, Indian studies published in Indian Journal of Critical Care Medicine. They have shown that the cutoff around 1.3 to 1.9. So we can measure the diaphragmatic RSBI. It can show us there can be a extubation failure. The sensitivity is around 84 to 100% and specificity is around 80 to 90%. So roughly more than 80% means it is okay. In my study, which I have done, the cutoff was around 1.36. But we should not forget the limitations of diaphragmatic ultrasound. I am telling you, when I started my thesis on diaphragm, my HOD has told one SR from radiology who helped me learning diaphragmatic ultrasound. And literature says that you need at least 40 times to do it with proper appreciation and take this measurement. 40 times you need to learn it properly to measure the diaphragm, at least the thickening fraction. Diaphragmatic excursion is easier one through the subcostal approach. Diaphragm thickness is different in different intercostal spaces, so you need to remember that. Diaphragm thickness varies from FRC to TLC. History of abdominal or thoracic surgery, it may interfere with our diaphragm motion, so our measurement can vary. Permanent mechanical ventilation affects diaphragm thickness. I have already mentioned one of the major cause of ventilator-induced diaphragmatic dysfunction. Hemidiaphragm motion may be different from one side to other. Why are you looking at the right side? Because the measurements are better. We can also look at the left side. When there is any surgery on the right side, we can also measure it at the left side. But the I have mentioned in the slides that right side and left side measurements according to the sex, they are also different. We need to remember that. So to summarize, if diaphragmatic dysfunction is diagnosed, I need to look at fluid overload status. We need to drain the pleural fluid. We need to prevent atelectasis. And if there is autopip in COPD, I need to manage that. If it is over, there is no diaphragmatic weakness, then we need to think of other causes of weaning failure, diastolic dysfunction, delirium. If after that everything rule out, always we need to remember we have to take a whole of all these factors. I can't say standing here that if you properly measure a diaphragmatic excursion less than 10 millimeter or 1 centimeter and DTF, diaphragmatic thickening fraction, less than 25 to 30%, there is a 100% chance that your patient will fail. It never happens like that. It is not a single tool that it can predict NIV failure or weaning failure. I need to summarize you with like lung ultrasound. I need to look at my clinical things, whether really it is going to fail or there can be a success. So my sincere thank you to my dear friend, my mentor, my senior Kundan Bhai, who has given us, my friends, to have a get together and invite at least 2 speakers who are really very well known in POCUS, Sikand sir and Tapas Bhai, and also helping ISCCM Patna President Kishore sir and IFCCM Patna Secretary Roshan sir to make this occasion successful, enjoying. Hope you a enjoyable day, learning day, because we will go to the bedside and practice what we learned today. Thank you everyone.
Thank you, sir, for the excellent session. Now, coming almost to the end of our scientific session, from the heart, lung, systemic circulation, we move our ultrasound assessment towards perhaps the most fascinating and complex organ, that is the brain. To take us deep into TCD, I would like to invite Dr. Kundan Kumar, sir, HOD, Critical Care Medicine, Jeevandan Health, Hospital, Patna, to kindly come on stage and take over the session.
Yeah. Last talk before lunch must be boring. ये काम करता है क्या? ये तो हाँ हेलो. Yeah. Just one disclaimer. My objective is to just sensitize, not to teach, because it is a very complex kind of modality and I'm still learning. So the transcranial Doppler. When we come across any neurological patient, then which kind of imaging modality come across our mind, like MRI or TCD? But the TCD is also at our disposal, and when we use it judiciously, we can draw very good content out of it. Actually, TCD is the non-invasive and it is radiation free, and it can be done right at the bedside, and it can be and we can I can't say diagnose. We can go through different pathologies of brain through this modality. Like vasospasm monitoring, sickle cell screening, ancillary confirmation of brain death, stroke evaluation, detection of circulatory microemboli, right to left shunt like PFO, and the arterial stenosis and many more others. तो इसमें मेन ये है कि हम एक अल्ट्रासाउंड प्रोब से जस्ट ब्रेन को स्कैन करते हैं, और हमारे पास इसमें 2 तरह के प्रोब्स होते हैं. एक्चुअली टीसीडी के 2 मोडेलिटीज होते हैं, एक होता है टीसीडी, एक होता है टीसीसीडी. तो टीसीडी है ट्रांसक्रेनियल डॉपलर और सेकेंड है ट्रांसक्रेनियल कलर कोडेड डॉपलर. तो टीसीडी एक्चुअली इट इज जस्ट द प्रोब वन Yes, the TCD, it is a 2 megahertz probe, जो कि actually I am indebted to my director, Dr. Prasant, who bought me a toy, you can say, which is a Viasonics Dolphin, very costly. And by this we can do the TCD. तो actually TCD से हम ये जस्ट एक आपका पीएमडी मोड इसमें होता है, ये बोले कि विच इज पावर एम मोड, एंड अलोंग विद द आपका मतलब कि डॉपलर का जो स्पेक्ट्रम होता है वो देख सकते हैं. बट इन द टीसीसीडी वी यूज द ग्रे स्केल इमेजिंग बाय यूजिंग द फेज अरे प्रोब. So as we know that the ultrasound waves can't cross the bone because bone is a dense kind of organ. So but in the skull the spicules are very low, so at some windows it allows ultrasound wave to pass through it, and these are transtemporal, which is most commonly used for the TCD purpose, transorbital, submandibular, and the transforaminal. In the transforaminal window we have the natural orifice through which we can go through. So this is the orbital window, this is the temporal window, this is the occipital window and the mandibular window. And this kind of image we can see via the TCCD. This is the TCCD. In this image we can see that is a grayscale image, and along with that we can show the blood vessels. So so this one is the MCA, and actually this is the circle of Willis. This is circle of Willis, and this is the midbrain, or you can say the cerebral peduncles, and this one is the PCA. This is the PCA. P1 and P2. P1 is red and P2 is the blue, and this one is the MCA, and this one is the ACA, and this is the contralateral ACA, and this one is the contralateral MCA. So by this we can say, we can visualize that this is the circle of Willis, and my probe is like here, and at the temporal window, and this is the TCD which we do in our setup, and this is not a very good kind of image, but in this image we can see that the Y line is the depth. This is the depth, and this is in the millimeters, and at the 60 mm of the depth, and this is the PMD. This is the power M mode, and this is the spectral Doppler. And when we put the line at that the 60 mm, actually we can define the arteries depending upon the depth and their blood flow. And this is the MCA. Actually MCA flow towards the probe, so it is red in color, and this is the ACA which flow away from the probe, so it is blue in color. So this is the spectral Doppler we can see. This is the peak systolic velocity. This is the in diastolic velocity. And you can see that here this is the pulsatility index, this is the heart rate, and this is the diastolic, in diastolic, peak systolic, and this is the mean. This is the diagram of the various vessel we see in the neck, and this is the diagram of carotid artery. And this one, this is the siphon where the ophthalmic artery arises, and it can be depicted by the orbital window. And this one is the circle of Willis, and here we put our probe. Here we put our probe to look for the vessels. And here we can see that this is the MCA. It is going towards the probe, so it is blue in the so it is red in color. And this one is going away from the probe, so it is the blue in color. And this one, and this one is the posterior communicating artery, and this one is the posterior cerebral artery. So the transtemporal window, this is the transtemporal window, just above the zygomatic arch. And here we can see that this is the frontal, anterior, middle and the posterior part. Here we put the probe and the pointer is toward the eye. Pointer is toward the eye, and in this case we can appreciate the midbrain, and this is the contralateral skull bone. And this is the third ventricle. Actually, in the midbrain, there is a mesencephalon. When we tilt towards the cephalic portion, then we can appreciate the diencephalon. And this is the third ventricle. And here we can measure the that skull bone to that one, and this is the A, and that from that to contralateral skull, this is the B, and A minus B by 2 is the midline shift. And this is the lateral ventricles. We can appreciate it also into the transcranial Doppler. And when it is the more than 5.5, then then this may be the indication of the putting the EVD. So it is already described earlier. MCA, this is the ACA, and this is the PCA. PCA, P1 and P2. P1 is red and P2 is the blue. That's we do in our setup. You can appreciate the circle of Willis here. And this is the MCA. This is the red one. This is the P1, and blue one is the P2. And this is the ACA. So this is the simple depiction of the circle of Willis, which we have described earlier. And in this picture, we can easily appreciate that this one is the MCA, this is the ACA, contralateral ACA, and contralateral MCA. And this is the Doppler, spectral Doppler. This is the transforaminal window. Here the probe is put just below the mastoid process and medial to it to look for the basilar and the vertebral. These two are the vertebral artery, and these combine to form the basilar artery. And because these the blood is flowing away from the probe, so these all arteries looks blue in the picture. So this looks blue because we have put it the probe here, and the blood is flowing away from the probe, so these are the blue. Actually our probe is here, and these vertebral artery meets to form the basilar artery. Transorbital window, and here we put the probe at the closed eyelid, and we can appreciate here the ophthalmic artery. And when we increase the depth, we can also appreciate the siphon part of the internal carotid artery. And here we can appreciate that in this picture the end diastolic velocity is very low, so the ophthalmic artery has a resistive pattern. When the end diastolic velocity is very low, that means it indicates that the particular organ has the increased resistive index. We can appreciate this type of pattern in our muscles or in the external carotid artery, where in the brain generally the EDV is about 30 or 40. And this is the submandibular one. Here we put our probe at the angle of mandible, and we can appreciate the internal carotid artery moving upward away from the probe, so this is blue in color. So the factor affecting the window quality: the bone thickness, thicker the bone, the poorer is the window, and it is totally operator dependent, and head position is equally important. And what parameters we can derive from this, the TCD, the peak systolic velocity, end diastolic velocity, mean flow velocity, PI and RI. So these are the normal flow velocity ranges: MCA, ACA, PCA, vertebral and the basilar one. And these are the guiding principles for the normal TCD evaluation. As we already discussed, which color is which is flowing away or which is flowing towards the probe. And the clinical applications. The first one is for the vasospasm monitoring in the post SAH. Here we can see that the velocity, the mean velocity increases to 19 centimeter per second. As we already know that from the day 3 onward, there is a chances of vasospasm in the case of SAH. So we can indicate the presence of vasospasm by using this modality. And this is the range that up to less than 120 it may be normal. 120 to 150 mean velocity, it is a mild vasospasm. 150 to 200 moderate, and more than 200 is a severe vasospasm. And there is a Lindegard ratio. Actually Lindegard ratio is the ratio of mean MCA divided by the mean extracranial ICA. And there are others ratio also, like Solon ratio. It is the ratio of MCA by ACA by ICA. And ancillary confirmation of the brain death. Actually, when there is a increased intracranial pressure, the end-diastolic pressures comes down. When ICP equals to the end-diastolic pressure, it becomes neutral or it becomes zero. When ICP surpass the end-diastolic velocity, then it get reversed. So here we see that in the wave DEF, these are the cerebral circulatory arrest. In this case, here we can appreciate that the systolic and the diastolic are equal. So the net flow is zero. And at the later part, we can say there is short systolic upstroke. Here the velocity is less than 50 centimeter per second, and the duration is less than 200 millisecond. And at last, it gone. So these three type of wave are the cerebral circulatory arrest. And this is the TCD waveform pattern which we did in our ICU. This is a case of a traumatic brain injury. Earlier, it has a normal type of MCA tracing, but later we can appreciate that there is a diastolic reversal. ICP assessment, we can do the non-invasive ICP assessment by using the TCD. There are two types. There are many types of formulas. These two are most common. First one is the Bellner one. It use PI in the consideration, and second one is the Josnaika method. It does not use PI in the consideration. In the Josnaika method, this map is the invasive map, and we multiply map with the V diastolic divided by the V mean plus 14, and this is the cerebral perfusion pressure. When we negate this from the map, we can calculate the non-invasive ICP. And the arterial stenosis, here we can say that there is a we can appreciate in the angiograph there is a stenosis, and in the ultrasonography we can also see a plaque which causes the stenosis, and we can appreciate there is a MES here, and there is a increase in the upstroke. The velocity get increased at the site of stenosis, and when there is a high grade stenosis, we can see the bidirectional bruit. And in this picture, we are going to measure the midline shift, which I already depicted, that at the third ventricle level, the same side and the contralateral side of a skull, we can measure the distance, and we can do the subtraction divided by 2. The BMR so that the brain has the intact autoregulation. And in this slide, where we do in our ICU, that when we at a start there is the baseline. This is the baseline. Before starting the test, we do a baseline, and thereafter we ask the patient to hold the breath for 30 seconds at least, and and after that there is an increase in the velocity, and later we can derive the BHI, breath holding index. If it is less than 0.79, then it indicates that there is a some problem in the autoregulation. The PFO detection, this is the video. This is the when yes, PFO. Actually, in PFO or any right to left kind of shunting, when we do a Valsalva, there is an increase in the pressure in the right side of the heart, which pushes the blood toward the left side. That means it's past the pulmonary circulation, and if we push a agitated saline, that means some air bubble into the venous system, it may pass, it may go into the brain, bypassing the lung. And we can appreciate the microembolic signals which we see in this video. And the characteristic of this MES, that its duration is less than 100 milliseconds. Its sound and the sound is of the more than 3 decibel, and it is generally monodirectional. And we can count the MES and we can diagnose the problem. So the advantage of TCT is it is non-invasive, safe, bedside, portable, real-time information. It is effective, but it is complementary to other modalities. And it is totally operator dependent, and the acoustic window is a major problem. Thank you.
Thank you so much, sir. A well-deserved round of applause for Dr. Kundan, sir, who has also been the main driving force behind this POCUS PULSE 2026. Now, moving on to the felicitation ceremony, and once again, I would like to thank all the faculty members for being an integral part of POCUS PULSE 2026. Knowledge becomes truly valuable when it is shared. And today our distinguished faculty have generously shared not their academic knowledge, but also their clinical experience and expertise. As a token of gratitude and appreciation, we would like to proceed with the felicitation ceremony. For this, I would like to request Shalini to kindly join us on the stage for the felicitation ceremony forward.
Thank you, Dr. Sukanya ma'am. Hello, everyone. First of all, I request you all to please assemble. This is my humble request to all the delegates, respected faculty members, to please assemble in the hall. Okay. पटना के ही ऐतिहासिक धरती पर अहाँ सबके पोकस पल्स 2026 में बहुत बहुत स्वागत। ज्ञान की पावन भूमि पटना में आयोजित पोकस पल्स 2026 में आप सभी का हार्दिक स्वागत एवं अभिनंदन है। Ladies and gentlemen, esteemed and respected faculty members and distinguished guests, I, Shalini Singh, on behalf of Jeevandan Health, extend my heartiest warm welcome to the grand felicitation ceremony of POCUS PULSE 2026, a new wave in POCUS education, jointly brought to you by the Indian Society of Critical Care Medicine Patna and Jeevandan Health here in the vibrant city of Patna, Bihar. Point of care ultrasound is transforming beside clinical care, making rapid diagnosis and life-saving interventions possible in real time. But behind every landmark academic initiative and successful workshop are the visionaries, mentors, and educators who generously share their time and knowledge. Now comes the most special moment of our program to honor, appreciate, and felicitate our luminaries and esteemed speakers who have made POCUS PULSE 2026 a resounding success. To begin our felicitation ceremony, may I request Dr. Kundan Kumar to kindly step forward to felicitate Our first distinguished speaker, Dr. Shrikant Srinivasan, Chairman, Manipal Institute of Critical Care Medicine. May I invite on stage Dr. Shrikant sir. Thank you so much, Dr. Shrikant sir, for your invaluable contribution today, and thank you, Dr. Kundan sir. Ladies and gentlemen, please put your hands together for the guest speaker. Moving forward, I request Dr. Kundan Kumar to kindly stay on stage to felicitate Dr. Kishore Jhunjhunwala, Director Critical Care, Medanta, and Chairman, Scientific Committee. Thank you, sir, for your remarkable contribution to today's workshop. May I request any of the volunteer to please invite Dr. Rajesh sir with us in the hall? He's outside. May I request any of the volunteers? Thank you, sir, for your remarkable contribution to today's workshop. Next, may I request Dr. Kundan to honor and felicitate May I request Dr. Kundan to honor and felicitate Dr. Jyotirmay Prakashpati sir, Assistant Professor, Trauma and Emergency, AIMS Deoghar. Sir, can we please have you on stage? Welcome, sir. Thank you so much, sir, for your enlightening session. Okay. Thank you, sir, for your enlightening session. Can you please put your hands together for Jyotirmay Prakashpati sir? Thank you, sir. I would now like to request Dr. Tapas Kumar Shahu sir to please come up on stage for your felicitation. May I request Dr. Kundan Kumar to do the honors of felicitating Dr. Tapas Kumar Shahu sir.
3 cheers for Kundan.
A big round of applause for Dr. Tapas sir. Thank you, sir. Thank you so much, sir. Thank you, Kundan sir. Next up, I kindly request Dr. Prashant Kumar to step forward and come upon dais to felicitate our luminaries. May I request Dr. Rajesh sir to please come up on stage. Dr. Rajesh is head of critical care unit at Mediversal Hospital, and he is also chairman at Scientific Committee. Thank you, sir, for joining us. Thank you, sir, for your invaluable contribution to POCUS PULSE 2026. I would now request Dr. Mudit Joshi to come up on stage. Dr. Mudit Joshi is consultant at FMRI Gurugram. Ladies and gentlemen, please put your hands together for Dr. Mudit Joshi. Thank you, sir, for your time. Thank you, sir.
Just one word I
Yeah,
want to say.
sure.
Extremely well organized, so smooth.
Thank you, sir. That's so sweet of you. Continuing ahead, I request Dr. Dheeraj to come up on stage for the felicitation. Okay. Okay, sir. Okay. Okay, sir. Thank you, Prashant, sir. May I now invite on stage Dr. Kishore Junjunwala to kindly come up on stage to take forward the felicitation ceremony. Sir, can we please have you on stage? Yeah. Sir, we want you to take forward the felicitation ceremony. May I request Dr. Pranav Srivastav to come up on stage for your felicitation. Dr. Pranav Srivastav is from Max Hospital, Dwarka. Thank you, sir, for sharing your expert knowledge with us today. Thank you, sir, for your kind words. I request Dr. Kishore, sir, to please stay on stage. I request Dr. Kundan, sir, to please come up on dais. Dr. Kundan is HOD Critical Care and Emergency, Jeevandan Health, and Organizing Secretary. Thank you, Dr. Kundan Kumar, for your dedication to advancing POCUS education across Bihar and taking the charge of organizing this wonderful event. Thank you, Kundan sir, for your dedication to advancing POCUS education across Bihar and taking the charge of organizing this wonderful event. Thank you, Dr. Kishore and Dr. Kundan. May I now request Dr. Rajesh? Yeah.
Okay. One thing which I just want to say, last evening I was discussing with Dr. Kundan कि after a week you are looking so relaxed. He's saying the backbone of my team is so awesome, they keep me relaxed. The last evening we was having a cup of coffee with him and he is taking one name, although my prior interaction is not there with him, from the ISSM Patna chapter. I like to say thanks to Dr. Prashant for all this arrangement.
Thank you, sir, for your kind words. May I now request Dr. Rajesh Roshan to step forward to take forward the felicitation ceremony. May I now request Dr. Shivam Shekhar to come up on stage for a felicitation. Can you please put your hands together for Dr. Shivam Shekhar? Thank you, sir, for your valuable insights and participation to POCUS Pulse 2026. Thank you, sir. Continuing with the ceremony, I request Dr. Rajesh to stay back to kindly felicitate Dr. Prabhas Chandra Jha, sir. May I request Dr. Prabhas to please come up on stage. Dr. Prabhas is Senior Consultant, Interventional Radiology, Jeevandan Health. Thank you, sir, for your invaluable time. Thank you for your participation to POCUS Pulse 2026. May I now request Thank you, sir. May I now request Dr. Dheeraj to kindly come up on stage? Dheeraj sir is not there. May I request Kundan sir to please come up on stage? The emergency name which we usually use always. Thank you, sir. Next, I request Dr. Abhishek Chaudhary sir to be on stage for your felicitation. He's not here? Okay. Next, may I please invite on stage. Okay, so Dr. Shrikant sir can also join Dr. Kundan sir to felicitate our other speakers. May I please request him? Thank you, sir. May I request Dr. Prashant Kumar to kindly come up on stage for your felicitation? Ladies and gentlemen, can you please put your hands together for Dr. Prashant? Dr. Prashant Kumar is Honorable Director of Jeevandan Health. A big round of applause for Dr. Prashant Kumar for guiding the milestone of this event. Thank you, Prashant sir, for always motivating us. Thank you for making POCUS Pulse 2026 a dream come true event. May I request Dr. Shrikant sir and Kundan sir to please stay on stage. May I now request Dr. Sukanya to come up on stage for your felicitation. Dr. Sukanya is Consultant Critical Care at Jeevandan Health and Organizing Committee Treasurer. Thank you, Dr. Sukanya, for your wonderful session. You have been a guiding light in POCUS Pulse 2026. Can we please put our hands together for Dr. Sukanya? Thank you, ma'am. May I now request, finally to conclude our felicitations, I request Mr. Sarvjeet Thakur to come up on stage for a felicitation. Thank you, Mr. Sarvjeet Thakur, for your key contribution to making this event seamless and impactful. You have made this event dream come true. Thank you, sir. Thank you for your time. Thank you, sir. Ladies and gentlemen. Ladies and gentlemen, let's give one big, hearty round of applause for all our speakers and felicitators today. Their expertise, passion, and enthusiasm are what make POCUS Pulse 2026 a truly historic event in medical education of Bihar. On behalf of ICCM and Jeevandan Health, we express our deepest gratitude to all our national and local faculty for shaping the future of point-of-care ultrasound in Patna and beyond. Thank you, everyone. And let's keep writing this new wave in critical care education. Now, we may proceed for our lunch break. The much-awaited moment has come up. We need to gather around third floor in the same building. And after the lunch break, we'll resume with the session with hands-on experience. We'll take a break of 1 hour. I guess it's enough. Thank you, everyone.